Sir, shall I start now?
Yeah, start please.
Okay. So, pranam and very good morning. I'm Professor Parthapratempan. I'll talk on platelet-rich plasma in PMR and all P, and my journey will be from a pessimism to positivism. And the very important studies, two important studies, that's PEAK trial and RESTORE trial, they showed that platelet-rich plasma is nothing. It don't work than normal saline, in particularly in osteoarthritis of the knee. And depending upon these two trials, US FDA have not yet approved PRP in osteoarthritis or any musculoskeletal condition apart from intraoperative use. But who is US FDA to approve platelet-rich plasma? Because it's not a drug at all. It's your autologous blood collected and the platelets is taken out from it. And number two, what is your experience? Yes, it cannot reverse complete joint damage and even replace the surgery, particularly in complete joint tear and ligamental tears, complete ligamental and muscle tears. So I'm starting my journey from a perfectly negative baseline, not zero. I'm negative baseline. What is PRP? It's a preparation of, you all know it, it's a preparation of autologous plasma, usually containing between 2 to 7-fold of platelet concentration that normally contain in the whole blood. And are all the PRP same? The techniques used to generate platelet concentration product differ in amount of whole blood, type of anticoagulant, number of spins of centrifugation, time and speed of centrifugation, and the final volume and the number of platelet in the platelet concentration. This number of platelet in the concentration is very much important, and further studies showed that the evidence, not only experience, the evidence showed that the PEAK trial and the RESTORE trial, which I started with, they had only 1 billion, they delivered only 1 billion platelet in the joint. But the studies showed that there should be at least 5 to 10 billion platelets in the joint to act properly. So the number of platelet is very much important. And platelets are mega, actually they come from the mega karyocytes in the bone marrow, and they're unnucleated, and they're the first cell type to arrive at the site of tissue injury, particularly in the early inflammatory phase of the healing process. They play a role in homeostasis through cell membrane adherence, aggregation, clot formation, and release of substance that promote tissue repair, angiogenesis, and control inflammation. PRP may affect soft tissue healing via growth factors released after platelet activation and degranulation, and there are alpha granules and delta granules. Alpha granules contain platelet-derived growth factor, transforming growth factor beta, epithelial growth factor, fibrinogen, fibronectin, vitronectin, and delta granules contains other chemicals like serotonin, histamine, dopamine, calcium, adenosine. Almost 30 products have been released from the activated platelets. And what they do, these growth factors, they help to repair and angiogenesis and ultimately tissue healing. I'm not going to detail. So platelet activation takes place. We have to give some time within few days after injection, triggering the release of significant quantities of growth factors. The process ultimately leads to symptomatic improvement, and most people notice the definitive improvement by 4 weeks. And there are varieties of preparation of PRP. Some contains pure platelet-rich plasma, some leukocyte and PRP, some pure platelet-rich fibrin, and leukocyte and platelet-rich fibrin. last two are mostly used in dentistry. But we use PRP, and that is also two types. One is leukocyte-rich PRP that includes enrichment of WBC and more inflammatory, used in tendon and muscle injuries. And leukocyte-poor plasma, generation 2 PRP, that has low WBC, is less inflammatory and potentially more beneficial in avascular applications like joints and discs. And these are the phases of repair, inflammation, proliferation, remodeling, and platelet is active help in initial two phases, inflammation and proliferation phases, and also some part in remodeling phases also. So how, this is the scientific basis of PRP, how it acts. So how it is prepared. We prepared it by centrifuging autologous anticoagulant whole blood to separate components and concentrate platelets above the baseline level. This is the machine we use, and we use two spins platelet, two spins. First spin is called soft spin. It's in 1800 revolution per minute, and second spin 3200 revolution per minute. And the plasma in what we get it from plasma in the lightest phase in the top, and in the lowest, if the highest volume weight is of RBC, they in the down, and in between the Buffy coat, and in the Buffy coat, ideally, we are in our, after second spin, after proper concentration, in the Buffy coat, the platelet concentration is above, in the higher side, in the top side on the Buffy, in the Buffy coat itself, and leukocyte granules in the lower side. So, this is the mechanism of preparation, this is the process of preparation, and application of PRP is in almost in all field of medical science, and therapeutic application is many gynecological and reproductive medicines, urogenital application, or dermatological applications, and in aesthetic, some reconstructive breast surgery, vulval reconstruction, and definitely in hair. The most well used, as much as we use botulinum toxin to reduce spasticity, botulinum toxin is more used in aesthetic use. So similarly, PRP is, the story is same for the PRP. What are the use in musculoskeletal medicine? Then shoulder injuries, in rotator cuff tear, and different ligamental injuries and slap lesion, in elbow, lateral, and medial epicondylitis, in back and hip facet joint arthropathies, SI joint arthropathy, and wrist and hand decoherence disease, in knee, osteoarthritis, meniscal tears, and all ligamental tears, and an ankle and foot, plantar fasciitis, and Achilles tendinitis. So I'm just overviewing some studies which have shown the different studies and case control studies, double-blind studies, systemic meta-analysis, which showed that PRP injections have a role in osteoarthritis. First, I'm giving importance to osteoarthritis, and it in inflammatory, these inflammatory markers is reduced in a significant decrease in the inflammatory markers. This study showed in the after giving PRP in osteoarthritis joint, and intra-articular PRP helps in knee early to moderate knee osteoarthritis, and also severe knee osteoarthritis, and it can be the second line of treatment after non-pharmacological treatment, pharmacological and oral drugs and non-pharmacological treatment, because that it slowed the progression of arthritis. It has shown that after 5 years study, after giving 3 platelets, it slowed the progression of arthritis in 50% of patients. So, and another important thing is, it's the study showed it has definite beneficial effect over intra-articular hyaluronic acid and definitely steroid injection. So, because PRP has helps to change the biochemistry of the arthritic joint, and it can at least delay the need for knee replacement surgery. But one important thing that studies have not, though we sometimes use, but the studies has not shown any superiority of combining hyaluronic acid and PRP therapy. So, and another important thing is that very much hyped thing, that is stem cell therapy, that does not show any beneficial result, more beneficial result than PRP. Both are same in result, and definitely you know that cost effectively PRP is more cost effective. And these are many more studies, I'm not going details, and these are the studies in epicondylitis that we usually give methylprednisolone or triamcinolone in epicondylitis, but PRP not in short term but in long term do definitely better result, give definitely better result without doing any harm, which that steroid can do in epicondylitis and any other decoherence disease, plantar fasciitis, Achilles tendinitis, all these soft tissue cases. And definitely in shoulder rotator cuff injury, there is a good role in PRP, this study showed. And also in our, we deal with diabetic foot ulcers, and PRP therapy, it can be given in injection form or in topical application, and few weekly injections or applications will help to recover the diabetic foot. So now I'm concentrating on role of meniscal injury. In meniscal injury, there are many more many factors. Platelet-derived growth factors help into repair, and there are many studies which showed the meniscal injury healed with platelet PRP, and intraoperative PRP, which has already approved, has with operation intraoperative PRP has a definite role. And these are different types of meniscal tears. These are MRI findings, and these are MRI grading of grade 1 and grade 2, grade 3 meniscal tear. We particularly used 10 cases of meniscal, we studied 10 cases of medial meniscal injury in the department of PMR. We got the first of its kind machine in West Bengal, and we formulated a study, and patient between 18 to 35 with medial meniscal injury, traumatic, not degenerative, and no associated OA, and injury not more than 6 months, and we given injections, and we studied the outcome of NRS scale and Oxford knee scale. We give the injections like this, and by ultrasound guidance. And 1 to 3 points that cortisone should not be given with it, and no lignocaine, because they altered the pH, and heat can be applied, that it can increase the cell signaling, and NSAIDs should be discontinued 2 weeks before and 4 weeks after, because it is antiplatelet agent. And after injection in meniscal tear, there should be graded rehabilitation protocol, and the results we saw in 6 weeks and 3 months, and we got in both NRS scale and Oxford scale, we got significant result. So we are, this is not a study, this is only some cases we have shown, and we are going to plan some case control study and in-depth studies in different grades of meniscal tear. So I could got crowned the platelet and completed my journey. I could not started the journey from a pessimism to positivism. Pranam.
Thank you, Dr. Khan. Now, any comments, queries from the audience?
Yeah. Hi, sir.
Please provide a mic in the audience.
Definitely. The market PAP, I don't have any personal experience, and I think it may cause some side effect because it is not autologous. In our cases, and all the studies showed that is mild symptomatic pain, or in some few cases that is with acute inflammatory reaction for few days, but after that everything subsides with rest and rehabilitation. But markets PRP, I don't have any experience. I think it may cause some reaction, allergic reaction, all these things. And number two is that in the studies showed, and our experience is definitely PRP definitely works. And there are many MRI findings after 6 months. We have not done any MRI findings because we do in a government hospital. It's not that we have not that opportunity to do plenty of MRI. But the MRI findings in various studies showed the definite improvement after 6 months of therapy. Thank you, sir.
Consultant in R.N. Tagore Hospital, Kolkata, and today she will be talking about role of virtual reality in balance rehabilitation in patients with spinal cord injury. Dr. Sen Gupta, please.
Good morning, sir. Should I start? Okay. A very good morning to everyone. An absolute pleasure to be on the stage and also to share the platform with some of my favorite speakers. I'm going to talk about the role of virtual reality in balance training in patients with spinal cord injury through the looking glass of a study which was my postdoctoral thesis during fellowship days at NIMHANS. This is dedicated to my guru, late Professor Dr. Ambar Ballab. Now, balance is the key to everything in life. How can the body be an exception? So how do you get a balanced body? It is through the coordination and the integration of the senses, the visual, vestibular, proprioceptive feedback, and the reflexive limb control. Now, patients with spinal cord injury have got that dissociation. They cannot integrate it that way. So they need to undergo balance rehabilitation to determine the key determinants of ambulation, which is balance, strength, muscle tone, and proprioception. Now, when I talk about balance, there are two kinds of balance. One is the static and the other is dynamic. The static balance helps you with the postural stability to do your day-to-day activity. And what is dynamic balance? It prevents you from falling. So basically, when you're walking, it's a series of gait cycles which are preventing you from falling. So that is dynamic balance. So before I move further, let's see if this video plays, and then I'm going to tell more about VR.
Left. By another, wait.
See, there is a patient,
Right side.
and there is a
Left
therapist
side.
behind the patient.
Itna shuru halka.
And if you see carefully,
Left side,
there is a screen
left side, right
with
side,
a representation on the screen and a camera below that.
left.
Okay, so this is the crux of VR. What happens? You are forming an interaction with the virtual environment, and you are forming a kind of real life scenario. So there is a camera which is capturing your image in whatever form and gives you an avatar on the screen. Now when you get feedbacks, like the therapist was saying, you move to your right and you move to your left, you follow your avatar, you manipulate your avatar and do certain activities. So this is the basic crux. So what is VR? It's an advanced form of human-computer interaction, and it allows users to become immersed within synthetic computer-generated virtual environment, simulates real-life scenario, and multimodal cues are provided, and the user will manipulate the object, and they receive instant feedback. So whether that is visual, audio, or haptic. I'll come into details. Depending on the extent of the user's isolation from the surrounding, during an interaction, you can divide VR into three ways: immersive, non-immersive, and semi-immersive. So immersive is, see the lady is wearing something like a headgear that is called the head-mounted device, where you're completely immersed into that environment. So for example, it's a construction work going on. It's a three-dimensional issue. You are inside that construction work, and you do not have any idea with the surrounding outside. Semi-immersive is where there is a three-dimensional image. However, you are not completely isolated from the surrounding. There is an avatar which you are manipulating, which is somewhat like the video I showed. And non-immersive is, it's more like video games where it's a two-dimensional image. So over the last 10 or I would say 15 years, there's been plenty of VR application in different areas of clinical medicine. Who's this lady? Anybody? Okay, she's the actress Radhika Apte. Why I put this is from the movie Phobia. And this was my first interaction with VR. And this lady had agoraphobia. So she was given head-mounted device where she was trained to shop inside a supermarket and so that she could face the real world. So this was interesting considering the age at which this movie was made. Coming to the study proper, this is a prospective, comparative, matched pre-post study done at Department of NR at NIMHANS, September to May 2017 and 18 with a sample size of 33 under the guidance of Professor Dr. Anupam Gupta. We included spinal cord injuries, both traumatic, non-traumatic, between 18 to 60 years, less than 6 months, all kind of AIS with a single insult, with NLI C5 or below, and the ability to abduct both shoulders at 90 degrees. This was purely so that they could perform in the games. And we excluded those with severe visual, cognitive, orthopedic, or progressive non-traumatic SCI. So we hypothesized that with the VR, the balance and, of the trunk and the postural stability should improve. So with that hypothesis, our aims were to evaluate the effects of a game-based VR training program for trunk postural control and balance, compare balance with a matched control group of SCI patients, and to assess whether motor completeness or incompleteness has any relationship with this. So the system that we used was a semi-immersive one called the Rhetoric, made by a Spanish company. So if you look at the picture, again, there is a camera. That's an infrared camera which captures the image, and the gentleman has an avatar on the screen. So the camera has a depth sensor as well as a motion sensor. Now you have to regulate the identical body part of your avatar. For example, you want to move your hand to the right, you stretch it out like this. You want to catch a ball, you hold it like this. And this is a picture of the Microsoft Kinect, which is a motion sensing input device for the Xbox, which is the key factor in this system. So 25 patients met our inclusion criteria. After the dropout, we got 21 patients in our experimental group. This experimental group got 15 sessions of VR therapy along with conventional therapy. Then the participants' demographic characteristics were stratified, and we divided them into 12 subcategories. Then we got 12 matched controls who were also spinal cord injuries, each representing one subcategory, and then they received conventional therapy alone. And what were the matching criteria? The NLI, cervical, upper thoracic, lower thoracic, etiology, severity of injury, whether it's motor complete or incomplete. We grouped them as group 1 and 2, and age categorized per decade. So to put it simply, let's say a 25-year-old traumatic spinal cord injury of Asia C was paired with, let's say, a 29-year-old traumatic spinal cord injury, Asia D. Okay, so this is how the matching was done. This was the gross matching criteria. So the experimental group received VR sessions, 30 minutes each, 5 days a week for 3 weeks. And if you see carefully, here, okay, that's me 6 years and 6 kgs younger. So there was a physiatrist who was regulating the entire session, and that physiatrist was me. There was a therapist, but the therapist was mostly for supportive. And what about blinding? The patients did not know about the outcome measures, and the initial and last assessment was done by a person who was blinded whether the patient received VR or not. Okay, so these are the games we included, like focusing on trunk control and bimanual coordination, dynamic balance, etc. And few things about the games. So initially we started with very simple games. Now once the patient could perform at least 80% of these games, we automatically upgraded them to a difficult level. What do you mean by difficult level? Maybe the stimulus was faster, or the angulation was more acute, greater joint excursion needed. So we just kept making it difficult on a patient-to-patient basis. So the outcome measures were Berg Balance Scale, the balance section of the Trinity Performance-Oriented Mobility, and Functional Weight Score. What is FRS? it is either you abduct your shoulder to 90 degree or this forward flexion to 90 degree, and then you reach out to catch the object. The distance that you have covered, that is your score. The average of that is your functional read score. Okay, so the statistical analysis was done by our software, and we compared the experimental and the control group, and there was no statistical difference. So it was a good comparable group. Now, when we compared the experimental group and the control group at pre and post therapy, we found that statistically significant improvement was seen in both the groups. Okay? However, when we compared with the completeness of the injury, there also we did not see much difference except a few things. Like in AIS C and D, in the experimental group, we found a steeper curve in the Berg balance scale, and in case of POMA B, we found a score, a p-value of 0.016. So the advantages and disadvantages, the participants were more responsive and they had the liberty to undergo training in any position. Any kind of neck pain, back pain that the patient has was also taken care of with the training. We did not come across much side effects. There was some orthostatic hypotension, which was manageable conservatively. So there are a lot of theories and mechanisms of actions of VR. Now, I have summarized them through multiple literature. One is, of course, the neuroplasticity. Any task-based approach is going to cause neural reorganization, motor relearning. It has been seen that there is dynamic structural brain plasticity when you see through spectroscopy. And what happens is when you're reaching out for a virtual object, probably the excursion of your joint is more. So the proprioceptive feedback is more. Again, your center of gravity is moving beyond your base of support. So you're challenging your body more. And this also leads to proprioceptive and neuromuscular stimulation, leading to muscle relearning. There are theories that it activates the mirror neuron system, prefrontal cortex, and parietal cortical area. There was a study where the hemodynamic aspects were studied in healthy objects using VR, and the oxygenation in PFC was found to be higher with functional infrared spectroscopy. And because you're giving a multimodal sensory stimulus, there's a lot of neural bombing at the damaged spinal cord. So these are grossly the mechanism on which you can explain how VR works. Now, you might ask, we also had motor complete SCI, then how come they improved, okay? These are our theories. 2 of the AIS-As had actually converted to AIS-C, and we had more of sensory sparing than motor sensory sparing, so the proprioceptive sensation might have helped. And we are not sure, there might be a lot of discomplete spinal cord injury, because now a lot of literature is there between complete spinal cord injury and discomplete spinal cord injury, where you can go for tractography, spectroscopy-based studies, and sensory evoked studies to see maybe the tracts are intact. Now, what are the advantages of a conventional training? You can manipulate, fine-tune, it's engrossing, motivating, and it can be combined with other technology. That's me with HMD at IIT Chennai. I was the first volunteer for their HMD. So the limitations of the study, sorry, one slide I think I've missed here. So what did we conclude from that study? That VR, we did not find it to be superior to conventional study. But however, considering the limitation and the increasing trend of activity, it might have more positive results based on certain factors, which are, our study was not randomized, it had small sample size, the long-term effect could not be assessed. At the time we did the study, there were no guidelines, no Indian studies available, and we are not sure whether our software was technologically advanced. There are better software available now. Now, coming to a bit of literature, this is one of the earliest studies and extremely well cited, where a VR was used in paraplegic spinal cord injury and compared with non-disabled people for a feasibility study. In 3 different atmospheres or virtual environments, the sitting balance was measured. Again, while we were doing the study at NIMHANS, this article came out. Probably this is the first Indian one. It came from Delhi, that virtual reality game-based training is better in improving balance and functional performance in individuals with paraplegia than real-world task-specific balance training. They used reach test and skim, etc. So even in our study, actually, we had used HADS, skim, and other parameters, but for the publication purpose, we stuck only to the balance parameters. Now, this is a very interesting study where 12 spinal cord injury patients, Can I take a minute?
Eating into interactive time.
I think I'll quickly finish it. So they were used for driving. And this is a newer study where force-sensitive application was used to measure the sitting balance. This is what I mean by haptic sensors. This is again a study where improvements 4 weeks post-training were measured. So VR has been single for a long time. VR mingles with BCI, FES, body weight supported treadmill training, and finds a good marriage in robotics. So a lot of systemic studies are, meta-analysis is coming out on this. We see there's a paradigm shift from earlier it was considered inconclusive, then COVID came, it was considered useful. Now it's more towards mostly promising, probably good when you look into systemic reviews. Our study was published in Asian Spinal Journal. This is another study we published, a case report with VR. And this is my current department of PMR and Neuro Rehab in Kolkata. It's just 2 months old. Please come to Kolkata, bless the baby, and give me suggestions. Thank you.
Thank you, Dr. Madhushri. Now there is time for a few queries or comments.
Thank you. Sir, I don't remember that. Probably Dr. Anupam Gupta will be able to say, because the instrument, I think it is somewhere in 4-5 lakhs. Something between 2 to 5 lakhs, I'm not sure. Gaurav, do you know the cost? We'll find it out, sir. Yes, sir. Sir, please. Yes. Thank you, sir. This is a very good question. There are a lot of theories on that probably you're putting the patient in a more virtual environment. It's not as real life as it is claimed to be. Again, see, if I go by our study purely, then I cannot comment, because we did not find any noticeable difference. Also, most of the studies on VR are with very small population size, 15, 20, 30. Long-term studies are hardly there. Just one study I think I mentioned where 4 months post-study they had seen, and where they found that the results were sustained. So frankly, I cannot say for sure, but yeah, I mean, if it is done consistently or periodically, it should remain. But then, of course, conventional rehab cannot be eliminated. That has to be there.
Thank you, Dr. Madhushri, for your presentation.
Thank you, sir.
And now I call Dr. Sindhu Vijay Kumar. She is Associate Professor of PMR in Amla Institute of Medical Sciences, one of my former colleagues at AIMS New Delhi, and she has worked in Canada also, and she would be talking on evidence-based use of assisted devices. Dr. Sindhu.
Thank you, Dr. Gogia. Good morning to all of you. It is an immense pleasure to be here, and I thank the organizers for giving me this opportunity. As opposed to my previous two speakers, a topic on assistive devices, it's not a single topic. Probably it's a heterogeneous mix of so many topics, and that's probably what I want to conclude by the end of this presentation. My objective was that the listeners should be able to have a basic understanding of the nature of evidence, especially the high quality evidence about the assistive device use, list maybe at least 5 broad areas of research in assistive technology going forward from today, and just a quick glance at the WHO priority assistive products list, as well as the national list of essential assistive products developed by the ICMR. They've had a panel discussion yesterday, and I've missed it. All listeners may initiate some steps. This is my hope, to create evidence for it to use in our own practice. We need some things for us. The outline, I'll be discussing a bit of the literature search and showcase some of the evidences. I'll be presenting a few very interesting articles from different research aspects or different views at research. The lists summarize, and if time allows, I would propose a classification system. I've looked at the guidelines and recommendations, so mainly searched for the keywords assistive technology, assistive device, evidence-based, and rehabilitation. So I've got 16 documents from IRAB, ABRSR, NICE, and Cochrane reviews, PubMed research, again, many articles, but then I have handpicked 28 articles. Scopus and Web of Science did not really yield anything. Just a quick glance. I'm sure we all know the levels of evidence, the hierarchy, and the recommendations. So the actual guidelines where I could, so there is no guideline for assistive technology use in IRAB if you use it. Like IRAB is the evidence-based review of acquired brain injury, moderate to severe acquired brain injury. So the guideline says in the topic of assessment of assistive technology, individuals with traumatic brain injury should be assessed to determine whether equipment or adaptations could increase the safety, independence, communication, as well as quality of life. It should be conducted by professionals who are proficient in the use. And key is it should be on an individual basis in which, and it should be in the environment in which it is going to be used. Again, some things that we forget sometimes in daily practice. A lot of recommendations for the prescription of assistive technology, the key points being take into consideration the cognitive, communicative, and behavioral deficits of persons. It should be provided as quickly as possible. It should not be delayed. Should be trained, person as well as the caregiver, the family, should be trained in the use of safe as well as effective use of the equipment. Clear written information for repairs, replacements, and future help, which is interesting. Have timely provision of an appropriate wheelchair and suitable supportive seating package. Again, something that we almost never give, the seating system. Walking or standing aids after a full assessment of the potential benefits as well as harms that for a cognitively impaired person, it may prove to be more harmful than useful. Then evidence was present in basically module 20 and module 18, which are dealing with cognitive communication as well as learning and memory deficits. So talked about text-to-speech technology offering a level 4 evidence. Virtual reality, I'll completely skip. We've had an excellent presentation before me. Voice organizers, micro-prompting, palm-top computers, PDAs. I think most of it are now replaced by the smartphones now. The IRAB guidelines are actually were reviewed in 2022, I guess. Again, text message prompts, computer-based software programs, VRs. I now move on to, sorry about that, evidence-based review of stroke rehabilitation, the 19th edition, the EBRSR. These two evidences, these two resources, IRAB and ABRSR, I think we all must go through their excellent practice guidelines and give a very comprehensive management strategies for us. Talks about a NETA uni wheelchair, which is a single upper arm controlled wheelchair with a so there is only one rim and maneuvering that can go to both sides. Cycle ergometer training, virtual reality, and defector training. It says mixed literature regarding the effect on functional ambulation and muscle strength. And defector assisted gait training may be helpful in improving functional mobility, but may not be beneficial for improving balance and activities of daily living. Exoskeleton systems may not be beneficial is the recommendation from EBRSR. FES may be beneficial. Arm shoulder effector robotics, mixed evidence. Exoskeleton, again upper limb exoskeleton, mixed evidence. So as you see, this is only regarding ATs, and there are many other guidelines available. From the National Clinical Guidelines for Stroke, people with limited mobility after stroke should be assessed for, provided with, and trained to use appropriate mobility aids, including a wheelchair, to enable safe, independent mobility. Cochrane reviews, many reviews, again, most of the studies, they've looked at many randomized control trials, but most of them no conclusive evidence or low quality evidence. And what they report is that all the RCTs have low methodological criteria. So that was kind of depressing because that was the first few things that I looked at. And after having 95 randomized clinical trials and then saying there is no evidence, and it is concerning, right? Nice guidelines, again, use of equipment, kind of on the similar lines as the IRAB as well as EBRSR. PubMed research review, impossible to cover in this topic, in this presentation. So a few important studies, translation of evidence-based assistive technologies into stroke rehabilitation from users' perspectives. In this study, interviews were conducted for both healthcare professionals and patients and their carers. And although most of the patients had not used an assistive device. So the healthcare professionals mostly said that most of the ATs they were using more frequently were evidence-based, which were like FES, CIMT, and virtual realities, and robotics. But only CIMT had evidence both by the UK guidelines and the EBRSR, and there was a mismatch between the strength of research evidence and the clinical use. I think that can be extrapolated into our setup also. We think that what we are doing is the best, but when we look at the literature, there may not be a high quality evidence for it. Another is on the display of AAC devices, where the visual scene display, the scene can be characterized and how it can be made more interesting by adding motion into the VSDs, categorizing them with photos relevant to the patient, and so on. An interesting aspect, probably we don't even look at AAC devices. Attila RCT, it was a large study with including 495 patients in the UK, aimed at establishing whether assistive technology can be useful. So a full package of assistive technology along with telecare, as opposed to a basic package where there was just a pendant alarm, a carbon monoxide detector, and a safe key, were assessed whether it improved the length of time that patients with dementia lived in the community, and they concluded that it was not useful, that a full package did not improve the length of stay in the community, which is huge from a perspective of public health expenditure. Another one on outcome measures. There are many instruments for measuring. So if we were to plan a study, there are definite AT outcome measures. Study on use after stroke, self-management of stroke. There was a 3-day exhibition of AT that was conducted, and then all the participants, 244 participants, interviewed, focus groups formed, classified them, and then data taken from that research. Again, many people felt they wish they had known more, and lack of knowledge, not knowing what to do, and lack of knowledge on the healthcare professional side were all cited as problems. CheckGate, why I've included this? It's on FES. So CheckGate is a pathway of FES prescription. It's a clinical pathway, which I thought was very interesting. And sorry, you may not be able to make out most of it, but essentially a 7 steps pathway where there is an initial assessment, all by a multidisciplinary team, led by 2 physicians, the referring physician or the PMR physician, physiotherapist, and an engineer, who would have periodic assessment. So after the initial evaluation and the basic assessment, the rehabilitation phase, and there is a loan phase where the person is given the FES device for home use. A 3-week period, comes back, reassessments, and only then the prescription is given, which is funded by the government, and interesting. So AT articles are there everywhere, but how strong is the evidence? My question is, do we really need that strong an evidence? There is a high geographical, psychological, and disease or condition-specific variations when we practice. There are preferences for us as well as for our patients. And maybe what we should be looking at is creating evidence for our own individual practice settings, probably district or state level recommendations and guidance, and of course, a national guidance. Quick look, the priority assistive products list by the WHO has got 50 items. The national list of essential assistive products, we have 21 lists. Most of them we are very, very familiar with and discuss in our, prescribe in our daily practice. So to summarize, only a few studies showing a high quality evidence, no studies in the Indian context that I could find. Remember, keywords had to be assistive technology or assistive device. Methodological inferiority reported as the reason for the lack of evidence in most studies, although there are many randomized control trials which, by reading, I personally felt they were quite good, and I didn't really realize what flow was in it. Okay, and lot of them talked about bias. Difficult to replicate these foreign studies and guidelines as structured programs and routine and early referral to rehab is almost non-existent in all our practices, although we do see a positive change in the trends. Indian studies are scant, heterogeneity of conditions managed, the rehab settings, the geographical and cultural variations. I personally feel with the 6 articles or so that I've shown here, that research in OT could be very simple, even the smallest rehab settings, if we go for more of qualitative studies. Yes, we may not have high quality evidence, but looking at the user feedback, the rejection rates, reasons for rejection, etc. Innovative qualitative researches may precede quantitative studies and then proceed to high. So we may need that transition slowly going on to quantitative studies. Increasing awareness is definitely the key. NLA EAP promises a shift towards evidence-based practices. I'll take one more minute, sir. Direct referral. Another problem that I want this audience to note is the direct referral to manufacturers and off-the-shelf purchase is detrimental to our practice and research in particular. Charity devices, they probably worsen the scenario. We must provide a complete prescription wherever possible, and a good classification and a coding system may be provided. It may provide better acceptance, and a sample program is the AMALA Assistive Devices Support Program, where we support patients financially if the prescription has been given by us, key being appropriate AT device. Okay, thank you. I'll stop here.
Thank you, Dr. Sindhu Vijay Kumar. Are there any questions, please?
Listen. Yes. Yes. I would say yes as my first answer. Again, this is from personal experiences and not from research. Personally, I really feel many a times, especially transfer devices, even wheelchairs, positioning systems, all that people say no, because it may be more, not just easier, but cost efficient to hire a person who would also do other things, right? Like if a device for transfer will only do transfers, but a person hired would do the cleaning, the feeding, and the transfers. So yes, that is a major factor. But then if we can, or if I can, put it into a study, I think it might make more a better answer probably.
Okay, thank you, Dr. Sindhu.
Thank you, sir.
And next speaker is Dr. K.M. Matthew. He has been one of my mentors at St. Stephen's, Delhi, and I have learned a lot from him. A glimpse of that would be included in my tomorrow's presentation, and today we will learn from him about immunocompromise in a spinal cord injury.
Hi, thank you. Basically, I am interested in clinical interventions and so on. So So if I come across a clinical problem, then I'd like to investigate it a little more. The reason why I'm saying that is I'm not like a regular professor who formulates a question and then tries to hunt for an answer. It's just that in my clinical practice, how do I manipulate this? It's not moving though. Oh. Yeah, but it's just, okay, thank you. So, greetings from Astor, that's where I come from. That's a real picture, it's not a made-up one. If you look at figures in the UK, that is 2013-14 clinical reference group data, you find that most of the spinal cord injured now are cervically injured. We had a set of figures in 2021 in Astor. We had 58 spinal cord injured. 29 of them were actually cervically injured. So we are not very different from the West in that sense now. So we come across similar problems too. I just want to talk to you about 3 or 4 patients. That was a 21-year-old who had a C6-7 fracture dislocation, rather severe. So you can see the lesion going all the way up to C2. He also had polytrauma, and one of those problems was contused lung. He was in the ICU for 45 days trying to get rid of a chest infection that he had. And he had urosepsis on 2 occasions, blood culture positive 1 occasion, and he had multiple urinary tract infections after he left us. This is a 32-year-old patient whom we discharged fairly recently, and you can see he had a lower respiratory tract infection 10 times, with a UTI twice, and so on. Multiple infections occurring all the time. We were just trying to firefight these infections most of the time when he was with us. It's a 70-year-old gentleman who came to us similarly. He was discharged with a tracheostomy tube, and he was getting multiple infections also. Just wanted to show you that picture where you can actually see the faint shadow of a collapsed lung, which is consolidated too. And eventually, after going home, within 6 months, he died of a chest infection. A 58-year-old man had similar problems, and you can see basal consolidation here and multiple infections in the chest. This is a 53-year-old patient who had ankylosing spondylitis, again, multiple bronchopneumonias, and so on. So I wanted to look at what constitutes this, and we know, we have read that these are caused mostly by immune compromise. So I just read up a little bit more, and I thought I'll share what I read. And we have many studies that show that pneumonia is the leading cause of death in all post-injury periods. There was a retrospective follow-up study of spanning over 70 years in the UK, and they found that 40% of deaths in all spinal cord injured patients was respiratory related. So now we have a fairly, looking at the literature, it looks as if we have a fairly settled view of what is happening. And the first thing among them is the fact that you have low-grade chronic inflammation going on in spinal cord injury. How do we know that? If you look at all these parameters, you see that they are all elevated, and which was indicative of chronic inflammation. The other thing that is going on is immunosuppression. We'll delve a little bit more into that. And we now know that sympathetic preganglionic neurons are situated in the intermediate horn of the gray matter. They seem to be activated much more than normal. We now know that there are interneurons that are glutaminergic. They are excitatory in nature, but GABA neurons that come from above usually keep it inhibited. In the absence of that inhibition, we have activation of the interneurons that are glutaminergic, they tend to activate the spinal presynaptic neurons, and eventually, when the circuit goes on for more and more times, the number of dendritic synapses that you get on this from these interneurons seem to increase. So we have now evidence that there is definite plasticity in the spinal cord with interneurons that are glutaminergic. What that does is to then stimulate the spleen, and the stimulated spleen puts out a large amount of norepinephrine. It also produces atrophy of the spleen, and we know definitely that the spleen size is reduced. Similarly, the number of cells, CD4, CD8, natural killer cells, all these tend to come down. So it was Brommer et al. Who did some more work on this. We know clinically that when you have a high spinal cord injury, you tend to be more immunocompromised. So Brommer et al. Was trying to find out why, and if it could be avoided or prevented. So we know that when you have a T3 level injury, a significant immunodepression, not so when you have a thoracic 9 injury. And in T3 injuries, you see there is significant reduction in the size of the spleen. It is significant. It has reached significance. So what he did was to try and see whether we can replicate this. So he took rats and he cut the spinal cord from the back, and that included the intermediolateral column and the funiculus lateralis, which actually synapse with the spinal presynaptic neurons in the intermediate horn. These tracks actually bring in inhibitory signals from above. So this was the experiment he did. We first cut the thoracic 9. We already know that T3 produces more immunosuppression than T9. So he produced this at T9 and then saw what happened to the spleen. The spleen was reduced in size. Then what he did was to actually cut the postsynaptic nerves that innervated the spleen, and he found that the spleen size actually did not change. The postulate, when you did that at a transaction at T3, was that the spleen sizes actually reduced significantly. But then what he did was to do the same thing again. Postsynaptic nerves were cut, and then found that the spleen sizes did not change appreciably. So this was the postulate finally that he had, these 4 columns. If you have high thoracic spinal cord injury, there will be functional spinal cord induced immune deficiency syndrome. If you have low thoracic ones, it did not cause it. And preganglionic injury caused functional SCI IDS. Postganglionic injury does not cause functional SCI IDS. So essentially, now we know that if you protect the spleen from the inputs of these spinal parasympathetic presynaptic nerve inputs, then you will not get any problem with the spleen, and the cells do not reduce in number. So we'll look at it again. The cortisol levels in acute spinal cord injury rises dramatically. 1 day post-injury reduces a little bit, and you can see the diurnal variation where it is really peaking a lot at 3 days post-injury. You can also look at the serum cortisol level and the splenic norepinephrine levels. If you did a sham, just a laminectomy, no problems. Contusion, some elevation at T9. T9 transection, a little bit more. But if you did a T3 laminectomy, similar here, T3 transection, it's way up there. And the same thing with the norepinephrine. And mind you, the more norepinephrine you have in the spleen, the less number of cells you get. So if you look at this again, the spleen weight is significantly reduced. the splenocyte count is actually significantly reduced. And then you look at the apoptosis of splenocytes, this is actually significantly raised. It's done through caspase 3, you can see that it's very large there. And you look at cell numbers, specifically B cells that are very severely depressed, T cells not so much, dendritic cells not so much. And the apoptosis of B cells is severe, and that can be actually seen by doing this annexin V. So, in short, after a cord injury, your natural killer cells decreased, your T cell function decreased along with T cell activation, your B cells decreased and B cell apoptosis increased, and ACTH increased along with urinary cortisol levels. So the same team, Professor Schwab's team, to which Brahma belonged, they did another test, because all these tests that were done were preclinical. And Professor Schwab's team were trying to do and see some experiments to see whether we could actually predict or look at immunocompromise by doing some blood tests. And they came upon this one, which is the monocytic HLA-DR test. What they did was to count the number of antibodies that stuck onto this, which was a measure of the level of immunity one had. If you had 15,000 of those, then you had good immunity. If you had 5,000 or less, you were immune paralyzed. If you're between 5,000 and 10,000, you had immunocompromise. And what was evident was the HLA-DR antibody counts was highest or lowest in Asia A T1 to T4 group. So remember, we want to recap this. Natural killer cells decrease, T cell functions decreased along with T cell activation, B cells decreased, apoptosis increased, and cortisol levels were high. The good news is this: with active rehabilitation, we have proof that NK cells increase. But unfortunately, they seem to actually drop off once you stop the therapy input. But T cell functions increase, and T cell activation also increased. Unsurprisingly, FIM scores were also up. But that is good news, isn't it? Similarly, there was more experiments, or not experiments, they were trying to see how we can inhibit the activation of the spinal presynaptic neurons. Is there any, okay. To cut it short, there are things you can do. TNF alpha, gabapentin can actually reduce the plasticity, and you can also change the chronic inflammation by changing the gut biome. That's the last one. The future is probably immune modulation with probiotic and gene blocking, and autonomic hyperreflexia could be prevented possibly with large doses of gabapentin or TNF alpha. Thank you.
Thank you, Dr. K. Matthew. That was an excellent presentation. Open for questions, if any. Well,
Thank you.
if there
There
are no
is
questions here.
no questions. Thank
Yeah.
you.
Okay.
Standard population to see whether it makes
Henry, I just told that I actually look at clinical problems that I face and then try to see what I can learn from it. No, the answer is I have not specifically looked into it, so I do not know. But possibly, if you already have immune compromise, then you are likely to suffer worse. Okay.
but then the point that the NK cells and T cells, B cells with physical activity improve is quite well proven. And
yes,
I
yes.
think that's the way to go forward.
I think so, yeah.
Is there any way of stimulating the spleen, in studies or anywhere, to avoid this?
The problem is splenic stimulation. with norepinephrine. That is what reduces the spleen size. It reduces
No.
B cells and so on.
I mean, do say suppress parasympathetic activation or do something else.
Well, that is already there. Vagus is not affected. So we know that that is not the problem. We know the problem is cutting off of sympathetic modulation.
No, but so if we were to stimulate the vagus, do you think we'll be able to counteract the effect? That is what I'm coming
I don't know. That has not been looked into because they know that the vagus is not affected in cord injuries. So,
Thank you. Thank you.
okay, thank you.
Next speaker is my friend from West Bengal, Dr. Kshetra Madhav Das, and he is a consultant in Fortis WEMES, and he would be speaking on rehabilitation of acute soft tissue injuries of ankle encountered in sports. Dr. Das, please.
Namaskar, Vanakkam. Good morning to everybody. Respected chairpersons, my senior, contemporary, and junior colleagues. Today, the topic of my talk is rehabilitation of acute soft tissue injuries of ankle encountered in sports. Basically, I will deal with some basic things after all these sophisticated things. And I believe that the 360-degree rehabilitation doesn't exclude the basic things. And I have specifically chosen this background because at the right bottom corner, there is a 360-degree circle which exactly matches with the theme of our conference, PMR 360-degree. At the outset, I would like to thank the organizing committee for inviting me and giving me this opportunity, rather. To start with, the basic things, components and tools of rehabilitation. All of us know that there are 5 components: the control of acute inflammatory process, the regaining full ankle range of motion, increasing muscle strength and power, improvement of proprioceptive abilities, return to daily activities, and that definitely includes the sports activities. And those 5 components come as a phased manner, 1, 2, 3, 4, 5, and they incorporate both generalized as well as individualized approach. And different component, different tools are being used. Some are used in the acute and subacute phases. I'm not going into the details. And some, like the task-specific functional rehab and the structured progression of exercise, falls under the subacute and chronic phases. And these two, that individualized approach and the task-specific functional rehab, are the 2 most important keys to open the lock of success as far as ankle rehab in the acute sports injury of ankle is concerned. Now, the phases of rehabilitation somehow goes hand in hand with the phases of wound healing. As we know, the days 1 to 5 is the inflammatory phase. There, our main target is to protect the injured tissue so that the secondary inflammatory response doesn't get inside it. And from the next stage, that means the post-acute phase, the 6 to 42 days, we usually start supervised and protected stress on the joint to promote the wound healing with the aim of full functional activity. And that is again divided into 2 parts. The days 6 to 21 is the, as you know, the proliferative phase, and the days 22 to 42 are the maturation phase. They are the initial of this ROM and strengthening exercise is given, and then the proprioception and task-specific training is introduced gradually in the maturation phase. And now some practical point to ponder. Rest, whether it is absolute or relative. The answer is simple: it is always relative, because the tensile strength of the muscle and tendons starts getting diminished as early as 24 to 48 hours. And that is the reason we should not wait up to the day 6 for instituting ROM exercise, and we should start it, but it should be within pain-free ROM and shouldn't create the re-injury. So we shouldn't overload the joint, and it definitely depends on a case to case. Now coming to the phase 1, that is, we know that depends on the price and other things, other NSAID and all those things. price means protection, rest, ice, compression, elevation. A few patients needs non-weight bearing, though most of them requires only partial weight bearing. Likewise, a few patients do need immobilization, but others, mostly stabilization. Stabilization is all the thing which is required. And the rest is always relative. And now coming to the ice, but this rest has been questioned by a new principle, that is the police principle, recently introduced, that tells about the protection, optimal loading, ice, compression, and elevation. They are questioning the necessity of rest, and they are actually arguing that rest is going to reduce the chance of proper healing of the tissue. So they are advocating about the optimal loading from the very beginning. And ice is given in almost all the cases we have seen in the sports injury arena. But again, this ice or cryotherapy has been questioned by a very recently introduced Peace and Love. Peace and Love stands for protect, elevate, avoid, compress, educate, load, optimism, vascularization, and exercise. I'm coming into that to the later, and then compression and elevation, as we know, it are very helpful. And in the pharmacotherapy, we can use NSAIDs, but as I was talking about the Peace and Love principle, there's an avoid. The third point is avoid. And they are telling about avoidance of NSAIDs and also avoidance of cryotherapy, because it is being believed and the evidences are coming that use of NSAIDs and the use of cryotherapy, including ice, is actually hampering the proper healing process, the natural healing process. And that is the reason, whatever the evidence is saying, we should use these two only judiciously in a very conservative manner, owing both the pros and consequences. Now coming to the second phase, the phase 2, range of motion, and the full range of motion is the prerequisite for full functional rehab. So this is a very important step. And as I have already told, that not only the tensile strength gets reduced, but the Achilles tendon gets shortened even within the 48 to 72 hours. So often the range of motion exercise is coupled with Achilles stretching exercises, and that can be done by the passive range of motion exercise or by the active range of motion exercises, which can be again single plane or multiple plane. And that single plane exercise may be in the non-weight bearing manner. It can be done in the weight bearing manner like this, and also with the help of the resistance, we all know. And that multiple plane, the so-called alphabet exercise, is very important as far as ankle rehabilitation is concerned, because it has a specific advantage of increasing the proprioceptive inputs, and that is the reason why it is often called the non-weight bearing proprioceptive input enhancement exercises. Coming to the phase 3, it is all about strengthening. Both the isometric and isotonic exercises are instituted, though there are only a little evidence behind the kinetic exercises, but some institute use that, and some evidences are also there. I'm not going into details of that, but the clinician or therapist assisted manual resistance is almost always preferred as far as the evidence are concerned. But when this is not available, this is not practical, only then the daily adjustable progressive resistant exercise or DEPRI can be instituted. Coming to the next phase. Oh, before going to the next phase, again, some practical point to ponder. These are very important, very basic, but very important. We shouldn't forget these things. The isometrics, to start with, it should always be submaximal, and to start with, it should be 50% of the full volitional activity, and then it should gradually increase. Otherwise, reloading or undue injury may happen, which will re-injure the already injured tissue. And wherever possible, the multiple angle exercise should be recommended, because it has been shown by the studies that the actual increase of strength occurs 10 degrees of either side of the particular angle against which the isometric exercise is being done. So recommendation is exercise at every 20 degrees throughout the full available range of motion. And regarding the isotonic exercises, we should introduce OKC and CKC both, though CKC is the definite isotonic exercise of choice of the initial period after the tendon and ligament injury. But as soon as possible, the OKC should be substituted, and those should concentrate not only on the concentric contraction, but also on the eccentric contraction, because eccentric contraction has tremendous effect, tremendous ability to control the different activities, especially the anti-gravity activities, and the ankle joint has plethora of anti-gravity activities. Think about jumping from height, running, jogging, dancing, walking. Okay, forget about all these high impact activity. I'm talking about just a low impact, very basic, the gentle pace walking. To make a single step, 1 foot forward at the time of heel strike, it has been calculated biomechanically that the energy produced inside the ankle or inside the knee are sufficient to shatter all the ligaments of ankles and knees, the most important static stabilizers of the joints. But this doesn't happen. This doesn't happen because of the quote-unquote negative work done by the eccentric contraction of the antagonistic muscles. So the coupling of positive and negative work done by the concentric contraction of the agonist and the eccentric contraction of the antagonistic muscles, respectively, is the all-important thing for the joint stability. So the recommendation is isotonics should be done at very slower pace so that the eccentric contractions of the muscles are properly achieved. Now coming to the phase 4, that is the proprioceptive and balance training. That can be started with non-weight bearing at the very beginning, at a very early period. And even the oval board can be used in the non-weight bearing manner like this. Then the oval board or BAP system can be used. That can be uniaxial, multi-axial, non-weight bearing, bilateral, unilateral, with open eyes, with closed eyes. Basically, with progressive challenges and progressive difficulties, we can use these. And the different surface walking can be instituted, manual PNF exercises with variable perturbation, and the random functional movement can also be introduced in the later phase. Now coming to the phase 5, the return to sports specific training. This is very important because our goal is to make that athlete able at least to the pre-injury level, or if possible, to the better level. And so this is the final phase. This is time consuming, but we should be very patient with our patients. And this is done in a phasic manner. At the very beginning, the functional exercise on different surfaces with variable resistances. And if there is no pain, no discomfort, then we progress to the second stage that constitutes of 50% walk and 50% jogging. And if there is no pain, we progress to the third stage, that is the 50% jogging and 50% running. That is the just before when the athlete is introduced to the actual sporting arena. And these two phases, again, done in a very sequential manner. Initial, the straight movement, straight line movement, forward movement, then sidewise, then backward, and only then the pattern movement, the curvilinear movement. And that too starts with circular motion, and then figure of 8 or other complicated or more complex figures, curvilinear figures. And the specific functional exercise is important to stress the healing tissue, because we know these depend on the SAID principle, the specific adaptation to imposed demand principle. And when I opened my third vision, in search of 360 degree, I found many other things in ankle rehabilitation. Those are a little bit of outside the basic arenas. And unfortunately, there is no conclusive, I'll finish now. Unfortunately, there is no conclusive evidence that minimally invasive procedures can be effective in the, at least in the acute injury, though they can be tried in the chronic cases, the failed cases. Orthosis has different, various positive effects. They can be used in the acute phase and as a prophylactic stabilizer or prophylactic support in the later phases. And when there is some biomechanical issues like foot malalignment, etc., they can be used for the all activities in all stages. And robotics also has different various advantages, but these two disadvantages are practically very important in real life scenario, at least for now. And these are the goals of ankle rehab, the 3 T's: treat the tissue, trigger the function, and terminate the cycle. Not only the pain spasm cycle, but also they terminate the CAI, chronic ankle instability, ankle injury, chronic ankle instability, this vicious cycle, because the chronic ankle instability is predisposed by neural, muscular, and mechanical malfunction, and the proper ankle rehab targets these 3 components to terminate this vicious cycle. And the chronic ankle instability, muscle weakness, inverter-reverter asymmetry, bipedal asymmetry, postural instability, all predisposes to ankle injury, and the ankle injury again predisposes to those things. So proper ankle rehab also terminates this vicious cycle. What can be asked more than this? A treatment, a management which treat the tissue, regains the function, and also prevent the future occurrence of ankle injury. So it's a wholesome thing, I guess. Thank you. Dhanyabad. Nadri.
Excellent, excellent talk. Any questions,
so much.
please?
Thank you, Doctor.
Welcome.
Excellent talk. My question is, you have explained about the duration for certain stages of healing and progressing with certain exercises based on that. So I would like to ask that I usually follow a criteria-based progression in ankle rehab rather than a duration-based progression, because the severity of injuries varies and the recovery process also varies in time between individuals. What's your thought on this?
Yeah, what you have told is absolutely right. And I thank you for the very pertinent question. There are 2 parts. I have mentioned both. Okay, I told often it goes hand in hand. So that was a time-based framework, but at the same time, I told that individualized approach and the case-to-case base, which depends on the case-to-case, and the task-specific activity are the 2 important keys to unlock the success. So as you formulate your program, there is no hard and fast thing, neither in time-based or the criteria-based. Okay, it depends on what you follow is absolutely right. This is for the framework. What may be the duration, what may be because I have to tell something about the generalized thing also. Okay, the individualized approach is very good, and you can take anything. Rather, it is better to take the criteria based as far as individualized approach is concerned.
You prefer the CKC exercise to begin with before the OKC exercise. I would like to know the reason, because what I would personally do is to start with the range of motion initially in an open kinetic chain position and then progress to closed kinetic chain, because there are various forces that act on the ankle when they do it in a closed kinetic chain position. So what's your thought on that?
Thank you for a very interesting question. Actually, I didn't say I feel or I opine, because I don't feel that I'm in a position to opine on something. What I am saying is absolutely evidence-based. I'm a learner. I learn from the evidences, because lots of studies are doing. I may have done 10 or 20 or 30 studies, but the evidence are based on the millions of studies. So there, in any kind of joint stability, be in the knee, be in the ankle, the CKC is the starting exercises. And when we talk about CKC and OKC, we are actually talking about isotonic exercises. ROM exercise, in range of motion exercise, it doesn't depend, it is not divided into CKC or OKC. In the range of motion exercise, you can start, I told, it can be started at the gravity eliminated position. So no question of CKC or OKC is there. That is purely range of motion exercise. When we talk about strengthening exercise, that is divided into isometric, isotonic, and isokinetic, and the isotonic exercises, again, is divided into two types. Number 1, the CKC, and number 1 is OKC. It is evidence-based thing that in all sorts of ligamentous and tendinous injury. You can recall that ACL injury. There is also the CKC is the initial exercise of choice.
Thank
Dr.
you,
Joy
thank
Singh
you,
has another
Dr. Das.
question, I guess.
I'm afraid.
Yeah. Okay, but I also practice that when isotonic exercise, as far as isotonic exercise is concerned, in my practice, I follow the evidence and I start with CKC. Okay.
Okay, thank you, Dr. Das.
Welcome.
We had an excellent workshop. Thank you. We had an excellent workshop on critical care rehab under my fellow chair, Dr. A.J. Rajendran. Part of that was on a video on ECMO that is being shared now, as two of the participants for this session, Dr. Amit Ranjan and Dr. Sahu, are absent. So Dr. Rajendran would be presenting the video on ECMO.
Good morning. This is me, Dr. Rajendran from MGM Healthcare, Chennai, and I'm into critical care rehabilitation. We have at least 1 or 2 transplants going on every week in MGM Hospital. Either it's a heart transplant or a lung transplant, and we have a large ECMO unit. We had promised to the critical care rehabilitation workshops participants that we will be able to share certain things which we were not able to do it on that day because of the technical glitches. Today I promised to deliver that, and we'll go into this. The first and foremost thing in critical care rehabilitation is early mobilization. And most of the time, this early mobilization, the barriers are there. The barriers could be they are on circulatory support systems. They are on left ventricle assist devices. They are on IABP, intra-aortic balloon pump. In spite of all this, we need to continue with the mobilization. Make them upright, make them walk. 100% it is possible. That's exactly what we would like to show here. Play the video, please.
Care at MGM Healthcare, and we have a very large ECMO program. I work in the same place as Dr. Rajendran, who is the speaker of this talk is. So he'll be in detail speaking about the ECMO and all, but I will show you some practical aspects about ECMO today in this video. So what is ECMO? ECMO stands for extracorporeal membrane oxygenator. So where does this come into use? So this comes into use when your patient has a very severe respiratory or a cardiac problem which you are not able to manage in a conventional way. Conventional way means inotropes, ventilator, balloon and all this. In spite of doing all this, if your patient is having a life-threatening situation, that is where you think of ECMO. There are grossly 2 types. One is called veno-arterial ECMO, that is VA. The second one is veno-venous, VV ECMO. So what you need to know is the veno-arterial ECMO or the VA ECMO is used as a support for the heart. It also supports the lung. Whereas the veno-venous ECMO or the VV ECMO is used as a support only for the lung. It does not support the heart, so it supports the lung alone. So how do we denote this? As we see the short form, you have VA or VV. The first part of it, that is V, is the place from where the blood is drained. First V stands for venous. Both in veno-arterial and veno-venous, the blood is drained from the venous side of the body. The second alphabet, that is A or V. In VA, the second alphabet is A. In VV, the second alphabet is V. So the second alphabet is the place where the blood is returned. So in a veno-arterial, you are returning the blood to the arterial side of the body. So that's why you are supporting both heart and lung. In a veno-venous, you are returning it to the venous side of the body, as the second alphabet also is a V. So here you are not supporting the heart, you are supporting only the lung. So the VA ECMO is used for heart patients, VV ECMO is used for lung patients with a normal function. So with this brief introduction, let us look at different parts of the ECMO. So this is what an ECMO circuit is, what you are seeing in the video. We will trace from the beginning to end. So this patient has a cannula in the leg. It is in the left side of the leg. So that is the cannula. and inside this dressing you have something called cannula, which is going through the femoral vein. It is positioned very close to the heart. So that cannula will be something like this, as you are seeing in this video. So most of it till this part is inside the body. Only this part is outside, which you are connecting with this circuit. So this circuit, as you trace and as you see, the initial part of the circuit is dark color. So this dark color comes here, and the next part, as you see here, is this is called as the pump. So this is the ECMO pump. So this is the one which circulates or propels the blood. This is a centrifugal pump. Why it is important? I'll explain to you a little down the line. From here, this goes to another part called as oxygenator, the one in the blue. This is called as oxygenator. Whether it is a VA or VV, these parts are same. So in the oxygenator, the blood receives the oxygen and carbon dioxide is removed. So as you see, the blood that is coming before the oxygenator, once it passes through the oxygenator, the blood that is coming out is bright color. This is very, very important. This you should know. You should keep a watch when you are carrying the patient continuously. Unless we put it off, this blood should always be bright color. So in this patient, you can see that the bright blood is returning back to the patient. For the return, we have a cannula. You can trace the tubing. It is coming here. It is coming here. It is going to the neck. You can see here. So this is given to the neck. So in this patient, we are draining from a venous side and we are returning through the venous side. This is a jugular vein. So this is called as a veno-venous configuration of ECMO. This particular patient is on VV ECMO. And this is the oxygen line. The green tubing is the oxygen line. So this is where from the ECMO receives its oxygen supply. And as you trace this, you are getting that oxygen supply from an oxygen flow meter. So what are the parameters of ECMO? You set only one parameter, that is this 3695, the number you are seeing. You can set it by rotating this knob either ways. It will increase or decrease based on that. Based upon the parameter you set, there will be some flow, whatever the flow of the blood in that ECMO circuit. This is that flow. So in this particular patient, this is the RPM what we are giving, revolutions per minute, and the current flow of the patient is 5.5. As you see, if I rotate this knob, the RPM starts coming down. So this is the only parameter I am controlling. As the RPM starts coming down, automatically the flow starts coming down. So this is one thing which we need to know. This is a very important thing when you need to know when you are handling ECMO. As I have said, all these pumps are centrifugal pumps. Why it is important? Why it is important? Because this pumps for the same rotations per minute. So this pump, the centrifugal pump, for the same settings what you have put, if there is any kink in the circuit, the amount of flow it gives drastically comes down. So that is very important. If you see here, you can see that the current flow is 5.2 here. Whereas as you keep seeing, if I mildly kink this circuit for some reason, the flows come down drastically. So this particular pump or ECMO is extremely sensitive to kinks. So that is very important to know, and we should ensure that in this entire length of tubings, there should not be any kinks anywhere, because if you have a kink, immediately your ECMO support or the flow will decrease. Okay. Other thing you need to know about is the emergency equipment. So every patient bedside, you will have something like this one and this one. These are called tube clamps. Why do you need the tube clamps? Suddenly if something gives away or if breaks, you just clamp it to prevent the blood loss. So this is one which has to be there by the patient bedside, and you should know this, that this should be there whenever you are taking care of patient. Okay, this is called hand crank. Hand crank is basically if the ECMO stops for some reason, you take it out, you put in this and then you rotate. So ECMO flows will be supported even if the power is off or even if the machine is off. So you need to know that this is very kink sensitive. You should have clamps by the side. Hand crank should be there all by the side whenever you are carrying an ECMO patient. Okay. So let us come to the point why it is important to have a rehabilitation or mobilization of an ECMO patient. ECMO support in these patients can at times extend for a longer time, 4 months, 5 months, 6 months, even longer than that also it can extend. Second, all these patients are critically sick patients. So when they are critically sick, they quickly become sick and they quickly lose their neuromuscular strength. So in order to maintain that strength and in order to see that the rehabilitation of phase of this patient, for suppose this patient, once he recovers, we are going to get him off the ECMO, then keep him on ventilator, then slowly get off ventilator and make them walk home. So to have that continuous rehabilitation process and not to lose the neuromuscular strength, you need to have a rehabilitation to be aggressively continued even when you are on the ECMO support. Along with that, you need that to happen because proning, which is a therapy for the lung disease or an ARDS, has to be done even if the patient is on ECMO. So for all these, you need a help of your rehabilitation team, that is your physiotherapy team. We take their help regularly, and it is an everyday job here that you mobilize your patient, you make them stand, you make them march, you prone them if required on a daily basis in all these patients. So what all things you need to know? To start with first, you need to know what is the type of ECMO, where the ECMO is. In this particular ECMO, as we have seen, we have used the peripheral vessels, that is the leg and neck vessels. If we have used the chest vessels or if we have used directly the heart, it is called central ECMO. Central ECMO also we can mobilize, but it will be little more difficult. You need more meticulous planning in central ECMO compared to a peripheral ECMO. That is one thing you need to know. Second is whether it is a veno-venous or a veno-arterial. Veno-arterial also we can mobilize, but again that you need to be more cautious because the cannulas will be more and the risk of decannulation is more in a veno-arterial. So that is the second thing you need to know. So with all these ideas, you start planning your mobilization or rehabilitation of the patient. So what all things you see? First, you have a word with your clinical team. You also have a full detailed assessment of your patient. See whether this particular patient is fit to be mobilized for today. Are there any issues from neurological perspective? Is the patient hemodynamically stable? Or is there any instability that you cannot do the mobilization today? Or he is too much drowsy that mobilization will put him at risk today. So all this you discuss. Then next you plan it with a group of people. Your group of people includes your doctor, your nurses, your perfusion team, housekeeping, along with your physiotherapy colleagues. With all these, you take care of the mobilization. So what all things you see? First and foremost is whether the cannulas are secure. So cannulas are, these are the one as I have saying before. So this is the cannula which is used for drainage. So if you see in this cannula, a good part of this cannula will be inside the body. For suppose if I put this cannula in a patient, so till here I fix this inside, this from here to here will be inside the body, only this part is outside. So this is reasonably stable and reasonably fixed. Whereas for an arterial cannula or a return cannula is the cannula which is there in the neck of this patient, only a small part of cannula will be in this body. So in this patient only this much is inside the body. Most of it is outside. So why is this a concern? One, short length inside. Second, long length outside. And this is in the neck where the patient can move a lot. If he is someone who is not conscious, cooperative kind of thing. So if this is not well fixed, accidental decannulation of the cannula in the neck is something that can happen. And if it happens, it will be a very dreaded complication which almost leads to loss of life or as bad as that kind of complications. So first and foremost thing when you plan to mobilize a patient is you want to see how secure your cannulas are. So for that you have this basic idea that neck cannula is always at a higher risk. So you need to secure them. The clinical team would have already secured it with stitches. Why it is important? Because all stitches will have necrosis usually after a week days. So you make sure yourself or you have a discussion with your nurse or your doctor that the cannula is well fixed and there is no loose ends of the cannula. So that you make sure stitches are good. Second way of making sure is watch the X-ray. You may not see it every day, but if you see the serial X-rays, you will see the cannula positions in the X-ray. If in the X-ray, the cannula position today is a little coming out compared to 2-3 days back, that means this particular cannula is loose and it is slowly coming out, and that particular cannula has a higher risk of decannulation when you are planning a mobilization of your patient. So what you will do, you discuss with your clinical team, address that issue, make sure it is well secured before you move your patient. So secure the cannulas, make sure they are in position, dressing should be good, then you should have an adequate length of tubing. This length of tubing should be adequate. So these tubings are usually fixed in length at the time of initiation of the ECMO. So if the length is short, if you are trying to move the patient, either they can get impinged into all of this or you can have a kink kind of thing. As we have seen in this video before, whenever you have a kink, you can have a fall in the ECMO flows. So keeping this, having a plan, like you have a chair or you want to make him stand or something else, you have it by the side. You have a set of people, you being leading the team, keep a close watch on the flows. Make sure that there is no kink or any disturbance in this ECMO circuit. Gradually mobilize the patient, bring him to the bedside. As you are doing this, someone, either a nurse or your colleague or a perfusionist, should be watching that this particular flows are stable. Along with that, it is equally important that this particular part, that is the oxygen tubing, is also well secured and it doesn't fall down or it doesn't get trampled by your legs or something else like a bed tubing or the ECMO wheels. All this should not get trampled. It should be well secured, and all along as you are doing, you have an eye on the circuit, making sure that the blood that is coming from the oxygenator is always bright. If you ever see it dark, that means an oxygen somewhere is a kink. You quickly go and troubleshoot. Along with that, you make sure there are no other obstacles in this entire thing. As you are seeing, this is quite a big spacious room, but at times you may have to do this in very compact spaces where your bed railings, the pillows, the other additional equipment like a foot trolley, ventilator, so many other things by the side of the patient may limit the space that is available to you. So you make sure that all these things won't come in your way, won't hamper the patient, ECMO circuit, and the ECMO kink should not be there. So this is how you plan a mobilization of the patient bedside. And once you put the patient into the position where you want it, make sure vitals are stable, make sure the flows what you want or what are said, and make sure your oxygenated blood is bright. This blood is bright always, and rest all things are patient is comfortable. They can have some hemodynamic disturbances when you mobilize them. So make sure those things are well taken care. So these are all the protocols you follow when you mobilize a patient who is on ECMO. Apart from this, you may have challenges because some of them will be volume overloaded, or they may be having a pressure source, or they may be hemodynamically unstable, which you have to handle in discussion with your clinical team.
We have a short video. Do you have that?
Hello, good afternoon. I'm Dr. Murali. Over the next couple of minutes, we'll see what is the importance of a balloon, impeller, and what all implications it have when we look at mobilization of these kind of patients. IAPP stands for intra-aortic balloon pump. That is one of the basic or the first step of a mechanical circulatory support for a patient having a failing heart. So where is it used? It is used in patients who are having a heart problem or having a cardiogenic shock. In those patients, it is used. So what is it like you see in this photo or in this video? What you see here, this is the balloon. How do you do it? You do it through the femoral artery approach. You go through the femoral artery, you position it in the descending aorta. So this part of it will be entirely inside. We don't see that. But how it works is inflates and deflates. So thereby helping the function of the heart. So but the access is through the femoral artery, and this is the balloon machine. So which will be by the patient side and should always be connected to the patient continuously. So what do we need to know about this patient? One, they are critically ill patients who are having a cardiogenic problem. So before we mobilize, we should know that whether this particular patient is fit to be mobilized or not. Second, this machine has to be there. This big bulkier machine has to be there and should be connected uninterruptedly during the entire process, including its power source and power supply. Third, as we see, the commonly used way of putting a balloon is through the femoral approach, that is the femoral artery approach. So mobilization of a patient who is having a femoral artery, we can do that, but that is more challenging. It can cause kink, thereby balloon functioning can be hampered. That's one. The second problem is regularly as we mobilize them, you see that the entry point, the hole in the skin will become bigger. So other way of doing it is, which will help in mobilization, which is practiced in some places, is putting a balloon through the subclavian. So if you see a patient who needs to be mobilized, but who are on balloon and whose balloon needs to be for the long time, just have a discussion with your clinical team whether they can convert it to a subclavian balloon. Subclavian balloon, as you can see here, this is through the hand rather than through the femoral artery. That is in the previous slide, you see that is coming from down here. In this slide, you can see this is coming from above through the subclavian artery. This patient's legs are free. So that you can use it for mobilization. The patient can get up, the patient can walk around in the ICU. You can push this balloon machine behind the patient with a long extension of power source. So that's how you can mobilize a patient on balloon or IABP. The other support what you have for heart is called impeller. This is a type of ventricular assist device. So what Impella does is, Impella, essentially the tip of the device will be in the left ventricle. So it sucks blood. As you see the right arrows here in the red, it sucks blood from the left ventricle and gives back blood in the aorta. So even if your left ventricle is not working well, this impeller works left, it does the job of left ventricle, thereby pumping the sufficient cardiac output. So this is a higher form of support. Like a patient sick, goes on inotropes, doesn't settle, goes on IABP. Even then it doesn't settle, then you have to think of impeller or like an ECMO, which we have looked before. So what is importance in this? In IABP also, the patient, the position of the balloon ideally should not move. But if it moves by 1 centimeter or 2 centimeters, at times it may not matter. But whereas as you see in Impella, this is where the blood will be sucked in. This is the aortic valve of the patient. This is where the blood will come out. So the position of the Impella should not move. That is extremely important when we, a point which you need to remember when you want to mobilize this patient. So if for suppose this comes out by 1 or 2 centimeters, so this will come to the aortic valve or comes to the aorta. So the function of Impella, it will not be able to work. On the other side, it goes in. As you see, this is very close to the LV wall there. If it goes in a little more, there is a risk of it perforating the LV wall, thereby causing a cardiac tamponade. So the Impella position wise, it should not move even by 1 centimeter in or 1 centimeter out. That is something extremely important you should remember when you are mobilizing this patient. Apart from that, like in a balloon patient, these patients will be in cardiogenic shock, they may be sick. You need to discuss with your team before whether they are fit to be mobilized. Second, they have big bulkier machines which always need to be kept in mind when you are mobilizing this. As you see here, this is the ECMO, patient is on ECMO. This is where the Impella is growing through the groin. Other way of doing it, like in the case of the balloon, is you can put an Impella through the subclavian approach, that is from the hand. So if you have a subclavian approach, you can mobilize this patient, but you should be careful while you are making them do hand exercises, because one, the limb can get ischemic. Second, this can cause a positional change. Third, that can lead to bleeding in that area. So these basic factors we should keep in mind when we are handling an IABP or an Impella patient. Thank you.
Thank you, that's it. And our main role is in keeping our patients upright and walking. And sometimes our patients are there with us for 30 days, 60 days, 90 days, and some, more than that also. So we cannot afford to lose the thing. The most important thing is ICU-acquired muscle weakness, which we need to counter and effectively make them mobilize. I end with a quote from Hiroshi Nakashima. Hiroshi Nakashima was the Director General in 1996 of WHO. He says, increased longevity without quality of life is an empty prize. So this is exactly what we are trying to do. We are trying to restore the quality of life. Thank you.
Thank you, Dr. Rajendran. May I also request you to share the video links at the critical care workshop group. Any query, comment? Okay, thank you. My second guru in this session, Professor Sanjay Vadhva, is currently Professor and Head of Department of PMR at AIMS. And he would be sharing his talk on short and sweet history of PMR, and I am sure, as always, his talks have been quite crisp and short, and it will also add to the history of PMR chapter that in the book that we released yesterday. So, Professor Vadhva, sir.
Thank you, Dr. Gogia. I think you are my guru rather than the other way around. I learn so many things from you. But thank you anyways. Good morning, all of you. I will be brief because I think we are running behind schedule to some extent. So the history of IAPMR is more than 50 years old or young. I don't know what term to use because we are still young and growing. And in the history of an association, 50 years is not a very long time period. But traditionally, the golden jubilee, the silver jubilee, the present times, and the future, these are important concepts by which we can discuss the history of an institution, association, or a monument, etc. So I will briefly organize my talk around these points. IAPMR is an association. We all know, we are all part of that. It has a genesis. It was formed in the year 1972 in the Lecture Theatre 1 on the first floor at All India Institute of Medical Sciences, New Delhi, when a few enlightened men and a woman met, and they thought that there is a need for this organization or association in India. And one of the reasons why they thought this way, they were all trained abroad. They had been exposed to these things, and they were men and women with vision, and they were willing to create something new because of the love and affection and passion for the specialty. Very soon they gathered, they drafted a document which is the memorandum or the rules and regulations. They gave it a name, Indian Association of Physical Medicine and Rehabilitation, and they submitted it for registration under the Office of the Registrar of Societies in India. And the registration was granted, a logo was developed and designed, and this is how we have been growing slow and steady steps. The membership has grown. Of course, one can always compare with other associations and feel unhappy that our growth has not been as rapid as some other associations, but still we have been growing. The rate of growth can be always debated, and partly for the slower rate of growth, we ourselves are responsible. Who is stopping us from increasing the membership and opening more and more state chapters? But despite my saying this at every platform, we are not opening more and more state chapters. And the sphere of activities has definitely expanded, and we have always risen to the challenges. And one of the biggest challenge in the recent times was the COVID-19 pandemic. And I'm very proud to say that Indian Association of Physical Medicine and Rehabilitation also responded in a very positive way to this challenge. And they continued the activities, although in a very different scenario, making use of the technology at that time, which was considered relevant and effective. And we could reach and we can send the messages across to the people, and we did not stop our activities. This was a very big challenge, and IAPMR deserves full credit for that. And by IAPMR, I mean its members and office bearers. I always like to share this photograph of the first executive body of Indian Association of Physical Medicine and Rehabilitation. This is what I printed in the first directory of our association. Dr. Mary Varghese was unanimously chosen as the first president of our association. Dr. B.P. Yadav, Dr. A.K. Mukherjee sir, Dr. P.B.M. Menon, Dr. S.K. Verma sir, and Dr. Mrs. V.V. Gujral. These were the other members. We have highest of the regards for Dr. Miss Mary Varghese. She was the first president of IAPMR, and she was herself a wheelchair user as a result of a spinal cord injury in a road traffic accident. And she is considered, without any doubt, one of the most respected pioneers of PMR in the country. She had the opportunity of being trained under Dr. Howard Rusk and some of the advanced centers, and she put into practice the skills and the knowledge and information that she acquired at those centers of learning, which are still considered the Makkah of PMR. And she was well connected, absolutely committed, and she touched millions of hearts, and she was conferred the Padma Shri by the then President of India, Shri V.V. Giri. And we all praise her for what she did for our specialty. But I have a different take also, without taking any credit away from Madam Mary Varghese, that the President alone cannot do everything. A President requires a very efficient and able and hard-working secretary. And I am very proud to say that a part of the success that our association deserves or gives goes to Dr. B.P. Yadav sir. And I was fortunate to begin my PMR career under the guidance of Dr. B.P. Yadav sir and then Dr. R.K. Srivastav. And I would like to name these two people for having done a lot for the growth and development of our association and the specialty. The other person whom I would like to name is Dr. W.G. Ramarao. He was another very dynamic person who used to travel a lot, and he had good friends in various other professional associations also, including Indian Orthopedic Association, Indian Association of Rheumatology, and you will be surprised to know that he was president of both these associations also, besides being president of IAPMR. And he was also president of Indian Association of Sex Educators, Counselors and Therapists. So a multifaceted person, very dynamic, very hardworking, traveling, and most of the time spending money out of his own pocket and savings. And other than conducting annual conferences and occasional CME programs, IAPMR was participating in various other academic programs also. And this is the proceedings and recommendations of one of the national level seminars on cardiac rehabilitation, which was held in association with Indian Association of Physical Medicine and Rehabilitation. The first directory of IAPMR was brought out by me in the year 1990 to precede the organization of an international conference at Delhi in 1991. And the genesis of this was when I saw the World Directory of Physical Medicine and Rehabilitation, which was brought out by Sidney Licht. And I was encouraged by Dr. W.G. Ramarao that you should work on this and you should develop and bring out a directory. And I was encouraged also by Dr. K.K. Singh, who was the head of the department at that time at AIIMS New Delhi. And this was followed by other and much improved directories of Indian Association of PMR. In the year 2000, it was brought out by Dr. Rajendra Sharma sir, and in the year 2006 by Dr. B. Ramachandran sir. They were with photographs of members and more rich in content. And now we have moved on to the electronic formats, and our membership and details about various other things are on our official website. Besides these directories and annual conferences and proceedings, the association also brings out official journal of Indian Association of PMR. The first editor of IJPMR was Dr. Ashok Agarwal from Lucknow, and he was very hardworking. He brought out several issues of the journal, and the flame or the torch was handed over to another very capable person, Dr. U Singh sir, who carried on the editorship of the journal for many years, and he gave it a different identity and shape and brought out regularly for many years. The next editor of the journal was Dr. Ratin Haldar from Kolkata, followed by Dr. Rajesh Pramanik, and now Dr. Mrinal Joshi. Newsletter or bulletin of IAPMR was also brought because it was felt by the association that there are a few things which can be better conveyed through the newsletter, which is smaller in size and perhaps with increased frequency. And the first newsletter was called the Rehab Talk, and this was brought out by Dr. S. Sundar, and he deserves a lot of credit. Taking a cue from the content and the trends internationally, I was given the responsibility and I named it to the Bulletin of IAPMR based upon the WHO Bulletin and Bulletin of Surgery. But due to various constraints and reasons, I could bring out only one issue, and then others have continued successfully, and currently also it is coming out regularly. Souvenirs every year, every conference annually brings out a souvenir which is very rich in content with many other facets and aspects related to the activities of the association. And proceedings I have already shared with you on one topic, that was cardiac rehabilitation, but there are several other topics also on which the proceedings have been brought out. The first conference was a landmark event in the history of IAPMR, and it was held at Delhi, and Shri V.V. Giri, the then President of India, was the chief guest. The Silver Jubilee Conference was held at Jaipur, and the Golden Jubilee Conference again at Delhi in the year 2022. And this is a photograph as a representation of the Golden Jubilee Conference at IAPMR. We had a logo of our association, but to commemorate this Golden Jubilee Conference, it was decided that we should come out with another logo specific to the Golden Jubilee Conference for that particular year, and that is also depicted in the middle of the two logos of the IAPMR. And the chief guest was Dr. Sahasra Buddhe, member of Rajya Sabha. And here in this photo, you can see to the right of chief guest is Dr. A.K. Mukherjee sir. He is one of the two surviving founder members of our association, the other being Dr. P.B.M. Menon sir. And this is another leaf in the history of IAPMR. Yesterday, the IAPMR textbook was released, and I am very proud to share that photograph, which I got through the WhatsApp group, and I congratulate Dr. A.K. Joy Singh and all others who have been associated with this. And it will, I think, encourage many more activities, because the book will last for much longer than a session in the conference or a lecture. But it is not that everything is going on beautifully well and we are growing by leaps and bounds. Still, there are several hiccups, challenges, roadblocks. So it depends on you whether you are a person who looks at the glass as half full or a person who looks at the glass half empty. My feeling is that we should be realistic rather than blindly optimistic or blindly pessimistic. Competition and comparison with other association in order to encourage us to do well and better should always be there. Instead of having an ostrich-like approach, nahi, hum sab theek kar rahe hain, we are doing great, we are the best, we are wonderful, we are on top of the world. So being aware of the challenges and preparing how to face those challenges is also very important, and we should not hesitate to do every 5 years the SWOT analysis as related to our association. What are our strengths? What are our weaknesses? What are the opportunities that we have in front of us, and what are the threats? It is a scientific way of moving forward so that there are no sudden surprises or setbacks. So this is what I wanted to very briefly share with you, and I am very thankful to Dr. Chellaswamy for giving me the time, and I am thankful to all of you for listening to me. Thank you.
Thank you, Professor Vadva sir. It has always been a pleasure listening to your talk, crisp and precise. I don't think there would be any comments, but of course compliments are invited.
But I can pose a challenge to the younger generation. What I have shared has been done by people who were senior to you. So you should not become complacent and just rest at the hard work done by them. Now it is your responsibility to carry the torch forward and ensure that it keeps on burning bright. That is my humble request and challenge to all of you. Thank you.
Sir, please stay on, and may I request all the speakers to come on stage for felicitation.
Chairpersons. Dr. Chairperson.
See, I could not say one sentence that one of the chairpersons, Dr. A.J. Rajendran, is one of the pioneers who specialized further and took off cardiac rehabilitation as an area of his interest. We are, most of us, confined to the locomotor rehabilitation, but he is one of the first persons in IAPMR who took off and further developed cardiac rehabilitation. And Abhishek took on neuro rehabilitation in a very big way. Thank you.
Sir, request the chairpersons to facilitate Dr. Partha Pratim Rai. Dr. Madhushri Sengupta. No. Dr. Partha Pratim Pan. Dr. Madhushri Sengupta. Dr. Sindhu Vijay Kumar. Dr. Sindhu Vijay Kumar. Dr. K. M. Matthew. Dr. Kshetra Madhavdas. And I call upon Professor Dr. Tinavkar sir to facilitate the chairpersons. Dr. Sanjay Varma. Dr. Abhishek Srivastava. Dr. Abhishek Srivastava.
Actually, I was. Being a chairperson, I was abusing my position and little bit. Dr. Abhishek, please stay on. Actually, we had a CME on stroke rehabilitation. Dr. Abhishek was online star speaker. His memento presentation was left.
Morning all. Welcome to the scientific session 9. So I welcome the chairpersons, Professor Dr. Tirunavukar sir, Professor Akojim Joy Singh. Welcome sir. So scientific session 9 starts from right now.
Very good morning to all here, and we are going to the scientific session 9 of this conference. I welcome all of the delegates for this wonderful session, and there are about six speakers. And since we are running short of time, I have the pleasure of inviting Dr. Ashanand Papalwar, the Assistant Professor of AIMS Nagpur. I will be talking on telemedicine-based pulmonary ablation. Welcome, Dr. Ashanand.
Thank you, respected chairpersons, my seniors and colleagues. After the exhaustive high-tech video of ECMO, starting with this telemedicine-based pulmonary rehabilitation. In pulmonary rehabilitation, telemedicine use is quite new, and a lot of new areas are there to explore more. So as you can see into the image, what's the difference between the lung capacities of these two people? One is I would say, climber, and another is a sedentary person with a sedentary lifestyle. So the question is that capability of high work performance can be attained by proper conditioning of body by regular exercises. So the question is that can you utilize these performance enhancing skills for the various chronic lung diseases? And the answer is yes. And this is the core of the overall pulmonary rehabilitation theme. So I shall be talking on the prevalence and pulmonary disease, then benefits of pulmonary rehab, then assessment for the telemedicine-based pulmonary rehab, then execution and setting up of a pulmonary rehabilitation clinic, especially telemedicine-based for the youngsters. So the idea of the presentation is that few of you may get the confidence after this presentation, and I believe that some of you can definitely start the telemedicine-based pulmonary rehabilitation setup. So WHO published the document, and it says that nearly 65 million people have various types of COPD with the 5% of death. If you see the Indian scenario, the situation of India is worse. It is significantly affecting health-related quality of life. And the recent meta-analysis says that 7.4% is the prevalence of the COPD in India. So to quickly, briefly summarize the pulmonary diseases, there's basically common two categories: obstructive pulmonary disease and restrictive pulmonary disease. In obstructive, we have basic simple 4 categories like emphysema and chronic bronchitis, asthma, bronchiectasis, and cystic fibrosis. And for the restrictive lung diseases, again the interstitial lung disease of idiopathic pulmonary fibrosis, sarcoidosis, scoliosis, and other neuromuscular conditions. So to find out this proper level of evidence for the pulmonary rehab, the 1A recommendation is it definitely reduces the dyspnea, improves health-related quality of life. 1B recommendation is beneficial for some patients with chronic respiratory disease other than COPD. Then 2B recommendation, it reduces the hospital stay or number of days spent in the hospital. And then it provides psychosocial benefits, again 2B recommendation. Then it is definitely cost effective, 2C recommendation. And the important is that there is insufficient evidence to determine whether the pulmonary rehabilitation improves survival of the patient. But definitely yes, it improves the quality of life. So broadly, pulmonary rehabilitation, it's basically divided into 2 categories: institutional-based pulmonary rehabilitation, where the patient visits the PR center, he does the exercise session, therapy sessions, and goes to home. And another newer coming up is a telemedicine-based pulmonary rehabilitation. So this was a study published in 2021. This is a study from the Iran. They explored this, what are the different barriers for the institution-based pulmonary rehabilitation center for the patients of COPD. And the findings were that there are barriers were divided into basically 3 categories related to the patients and their families, inefficiency of pulmonary rehabilitation services, and inappropriate organization in the context of pulmonary rehabilitation. They digged up a little bit more that what are the difficulties, why patient regularly doesn't come to the pulmonary rehabilitation center at the institute. There's many times there is a lack of knowledge to the patient as well as families. There is a heavy financial burden, lack of patient-centeredness, coordination with the PR team, inadequate professional competencies, limited access to the pulmonary rehabilitation services, ineffective PR planning, discontinuity of care, yes, and definitely transportation and other issues. Because a healthcare giver has to be accompanied to the patients of COPD with moderate to severe affected patient. So I believe that all these above barriers can be very well tackled by the meticulously designed, well-defined telemedicine-based pulmonary rehabilitation program, and it is very much essential, and the pulmonary rehabilitation program can be beneficial and survival in terms of the benefit to the patient. So the telemedicine-based pulmonary rehabilitation program, in 2020, in the middle of the COVID, Government of India has taken a very landmark decision and published this telemedicine practice guidelines 2020 for all types of specialties, with the various set of guidelines. What are the things, modes of communication we are supposed to use, like text message, video call, audio call, etc. What are the various types of consent we are supposed to take from the patient, the various digital technologies, as well as what are the drugs which can prescribe. There is nothing specific for the rehabilitation point of view in this guideline. So they defined telemedicine as it's a delivery of healthcare services where the distance is a critical factor by all health professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, and etc. So the telemedicine brings the healthcare service at the doorstep to the patient, to the common people, and it has removed multiple barriers like accessibility, transportation, time, money, and inconvenience. So the question is now, what is the evidence of telemedicine-based pulmonary rehabilitation for COPD and other diseases? So this P. Day, Roos et al., they studied this home-based walking program on physical activity, and then another study for in-home pulmonary tele-rehabilitation program. And all these two studies, they express that there is a domiciliary exercise-based tele-rehabilitation program under supervision of via electronic media is very much effective for the patients of COPD. Then in the COVID, there is one study, there's a review article regarding this proposal for multidisciplinary tele-rehabilitation program, and they also concluded that tele-rehabilitation offers a quick and effective option to respond to the specialist rehabilitation need for the patients of COVID-19. So now, how to execute the telemedicine base? There is some difference between the institution based and telemedicine based. The structure is the same, but the method and execution is a little bit different. So this pulmonary rehabilitation team, patient-centered team with the pulmonary medicine specialist, PMR specialist, and paramedical person like therapist, dietitian, and psychologist, etc. I believe that these are the protocol which I follow. The first consultation has to be physical one, where the patient has to attend to your OPD or your setup, and you are supposed to do the detailed examination or clinical examination. Then after the detailed thorough clinical examination, you are supposed to find out these indications and contraindication, which patients you are not supposed to enroll for the telemedicine-based pulmonary rehabilitation program. Then, as per the telemedicine guidelines, patient's written informed consent is must, where you are supposed to brief everything about the patient, what exactly you are going to do for next 6 to 8 weeks with the help of telemedicine as well as institution-based screening. This is a thorough outline of the pulmonary rehabilitation program, where you start with patient assessment, then patient education and motivation, patient exercise training, program evaluation, and maintenance. So this is a simple assessment program where you are supposed to take the relevant history, past history, then other vital parameters, then exercise in MMRC scale, St. George Respiratory Disease Questionnaire or Quality of Life Questionnaire, along with that simple vitals like pulse, BP, saturation, and to rule out any cardiac etiology, ECG, 2D echo, and other parameters. Then after assessment, we are supposed to calculate this targeted heart rate and rate of perceived exertion. Then contraindications, just like a institution-based pulmonary rehabilitation program, these shall be the same contraindications for telemedicine-based pulmonary rehabilitation program, basically angina pectoris, unstable angina, and other cardiac diseases, etc. Then the patient's goal, the goal of the telemedicine as well as institution-based pulmonary rehabilitation program should be realistic, in consultation to the patient, and after patient's assessment. Unrealistic goals you may not be able to achieve neither from your side, neither from the patient's side. Then exact execution, again the patient education, then optimization of medical management, the nutritional advice, secretion management, breathing techniques, nebulization, physical re-engaging exercises, and assessment outcome. They start with the patient education with the leaflets, then optimization of medical management, correct techniques of use of metered-dose inhalers and use of spacers. The nutritional advice is very much fundamental. The reason is that there is an increased work of breathing and there is an increased energy expenditure in the very act of breathing. So high protein, high carbohydrate diet is essential for the better recovery. Then bronchodilation before pulmonary rehabilitation, whether patient is at home or at institution, it's essential. Then secretion management, yes, before starting of the exercise session and other session, the secretion has to be removed for the better oxygen alveolar exchange, and these are all postural drainage, percussion, vibration, PEEP therapy, and airway clearance. And all these things we are supposed to teach to the patient as well as patient's relatives. Then again, breathing technique, when the patient visit at your center at the first session, then all the breathing techniques you are supposed to teach to the patient. This includes diaphragmatic breathing, segmental breathing, pursely breathing. Various breathing techniques have various indications, and according to disease pathology, you are supposed to taught to the patient. And again, the same thing, you are supposed to teach to the patient as well as caregiver. Then again, use of oxygen is very much essential. Then the physical reconditioning exercises, there is a vicious cycle for the reconditioning. The reason is that chronic respiratory diseases leads to dyspnea, leads to inactivity, deconditioning, worsening of dyspnea, disability, and ultimately death. So this physical reconditioning exercises break this cycle, vicious cycle. So again, the specificity of training, as we all know, strength training and endurance training. American College of Sports Medicine have given various guidelines, but we are supposed to little bit modify the guidelines in view of telemedicine-based rehabilitation program. So these are the various flexibility and warm-up exercises, beginning 4 to 5 minutes. This is a video of one of my patients taken a therapy session that suffering from the COVID-19 pneumonitis. So 2 to 3 days a week and supervised, and patient can do at home without any supervision. Then cardiorespiratory endurance training. There are various dynamic exercises of large muscle group. As patient is doing at home on the telemedicine or video call, the jumping, skipping rope, home treadmill, stationary cycle, or staircase training can be done. So this aerobic conditioning, simple jumping or marching exercises you are supposed to do. Frequency is again 6 days a week, 3 days a week on the video call, and 3 days patient can do at home, monitoring all the parameters. Then again, strength training, these are various group of muscle. Again, the accessory muscles of respiration we are supposed to strengthen for this better outcome of the patient. So these are various group of muscles which we are supposed to target at the beginning. Then at the home, if the patient doesn't have fancy equipment like dumbbells and all, simple water bottles can be used for the training program for the strengthening exercises. Again, the frequency will be 3 days a week, 3 days on the video call, and 3 days on the without any video consultation. So total duration approximately is 5 days a week. I personally follow 3 days a week on video call and 3 days a week on from the patient's side without any supervision, and 1 day rest. So this is our rehab protocol which we follow. We start with the patient education, then with breathing technique exercises, oxygen if required, and along with that warm-up exercises, activity training like various aerobic conditioning as well as strength training, etc. So I think 2 minutes more. Yes. So now the question is setting up of the pulmonary rehabilitation clinic, especially telemedicine based. So again, to set up, these are 4 things which need: infrastructure, manpower, equipments, and standard operating procedures. So this infrastructure-wise, you just need a good quality desktop along with good quality SD webcam and good quality internet connectivity. From clinician perspective and from the patient's perspective, they just need a smartphone. I personally believe that only PMR doctor is essential. No need of requirement of any paramedical staff or therapist. If you have competent enough and if you have time to do all these rehab sessions. Then from the equipment, from the basic point of view, from the incentive spirometry for the patients, then pulse oximeter to monitor the pulse as well as oxygen saturation, then simple set of the dumbbells, or simple, if the dumbbells are not available, you can simply start with these water bottles.
Dr. Harsa, please conclude. You have, how many slides you have?
No, sir. 2 minutes are there, sir. The first buzzer is for the...
Let's finish up. Okay.
2 minutes or more, sir. 1 and 10. No, sir. I am exceeding? Okay, thank you, sir. All right, sir. So these are 4 or 5 slides, sir. So the practical tips, I would say that that's a technology platform. I generally use the Google Meet. Then for the patient point of view, mobile stands are essential. Then initial peer assessment has to be there under your supervision. Then you can take her to this therapist. Initial session should be 1-to-1, and after that, with the group sessions, you can conclude. So these are standard operating procedure. And this was a study we did at the Safdarjung Hospital for COVID-19 pneumonitis. Yes, yesterday Dr. R.K. Srivastava sir as well as Dr. Sundar sir has talked about this advancements in artificial intelligence. So I believe that the future is that there shall be various artificial intelligence based various apps, various therapeutic exercise based apps, and this can be very well utilized for the telemedicine based pulmonary rehabilitation program. So it's a new telemedicine is going to give a new dimension to the healthcare structure of the India. It's very much effective, and this is the opportunity we must grab it. Thank you, sir. Thank you for exciting time.
Thank you, Dr. Harsha, for covering two important problems like pulmonary rehabilitation and telemedicine. And you made it like giving the service to doorstep in the form of telemedicine is a good thing. So we don't have time, but I'll invite one question if you have any. Yes. Please be brief.
Thank you very much for your very nice presentation. One question simply.
Yes, sir.
Whether you see exercise recommendation for obstructive lung disease and you see restrictive lung disease is same?
No, sir. The overall protocol for the restrictive lung disease is totally different, sir, where we are not supposed to give more emphasis on the aerobic conditioning exercises because the lung capacities are less. There may be a desaturation incidences we can encounter. The total protocol is different, and restrictive lung disease rehabilitation program has to be more supervised rather than telemedicine based. So I definitely discourage the telemedicine based rehabilitation program for restrictive lung diseases. Yeah. Thank you, sir.
Thank you so much. Thank you, Harsha. Thank you so much.
Thank you, sir. Thank you.
Next, I take this privilege to invite one of the very eminent physiatrists, Dr. Navita Purohit Vyas. She's not only a physiatrist, but also a renowned interventional sonologist. So I'm happy to invite her to give her talk. Please, Navita. So she will be speaking on evidence-based approach to cancer pain. Please.
Thank you so much. Very good morning to all. And without wasting my time, I'll start straight away with my talk. I'll be talking about cancer pain management. A lot has been talked about cancer rehabilitation yesterday, and one of the most important and most common complications of cancer is the pain. So looking about the incidence, we have seen that there are, WHO says that around 2 to 2.5 million cancer cases at any given point of time in India. And by 2050, this will be around 17 million new cases in developing world. What is the prevalence of pain? Around 64% of patients with cancer have pain when they are in metastatic or advanced or terminal phases of cancer, and around 59% those who are on anti-cancer treatment, and those who have finished their treatment, around 33% still have pain after their treatment. So most of them, around 50% are undertreated. Inadequate pain relief is seen in 56 to 82.3, which is a huge number. 40% die with severe pain, and 28% they receive, only 28% receive pain and palliative care, which is a very lesser number. What are the common symptoms in terminal cancer? Pain being the most common. 70% of the patient have pain and all the other symptoms. So what are the causes of the pain? Due to the cancer itself, due to tumor infiltration, involvement of the nerves and the plexus, bony metastasis, or it can be due to the treatment, due to the surgery, radiation, chemo, or immunotherapy, or there can be pain which is coexisting or due to other diseases. The types are visceral, somatic, and neuropathic. Why do we need to know it? Because the pharmacotherapy or the intervention, what we do, we need to know what is the type of the pain. So always the patient suffering with pain, they always have this question, why me? They are in a denial, no, I don't have cancer. Why should I go for the treatment? And why should I bother my relatives and suffer on my own? Family is in guilt because they are helpless, they are not able to treat the pain, and the patient is suffering along with the family. What does it impact? It impacts on the quality of life of the patient as well as the caregiver. How do we go about with pain management? It can be done with pharmacological, non-pharmacological, or interventions. So we begin with the WHO step-ladder pattern, starting with non-opioids, weaker opioids, and stronger opioids like morphine and fentanyl. These are the opioids which can be used. We don't have hydromorphone and oxycodone in India, but we have all the other weaker and the stronger opioids. Adjuvants used in neuropathic pain, we use in all kinds of neuropathic pain, can be used in the cancer pain as well. TCAs, SSRIs, SNRIs, gabapentinoids, and benzodiazepines. Also, when the patient, when they have edema, so steroids, they help in reducing the pain as well as the disease and the edema. Bisphosphonates, if they have skeletal meds, they should be used monthly, and nowadays denosumab 120 milligram monthly is being used. A slide about morphine, fact and myth. There are lots of myths associated with morphine, because even not only the patient but even the doctors, when they refer patient to us, they say if we start morphine, it is the end stage of the disease. No, we should relieve the patient of pain, so morphine can be started at any stage of the cancer, and the side effects and sedation, and mostly they are bothered about the addiction. And believe me, when we are treating cancer pain, the addiction is very less. It is because they live for they don't live for a longer period of time, so addiction should not be bothered when we are treating cancer pain. Radiation can be used when they have skeletal meds, and it has been seen that there's a complete pain relief at 1 month in only 27% of patients, and out of this, additional 42% have some pain relief. But what about the rest? What happens if they are not getting this pain relief? Sometimes in prostate cancers, radioisotope can be used, strontiums, and we should also have this thing in our mind, cancer pain emergencies like cord compression, withdrawals, and also bony metastasis, where the surgeries can be used, should be done. Now what next? If still they come, we have used our pharmacotherapies, we have used radiation, but if still the pain relief is not there, how do we go about it? So don't give up the hope. Pain can be managed, and there's more than one ways to treat pain. So that is where the role of interventional pain medicine comes into role. So I'll discuss few cases, and then we see what can be done what interventions can be done in cancer pain. This was a case of multiple myeloma. There we can see there's a compression of L4 vertebrae over there, with causing compression on the L4, L5 nerve root. He was undergoing chemotherapy, radiation, but the pain was not, there was suboptimal relief of the pain, and conservative management was given, fentanyl, morphine was given, but still he was complaining of pain. So we went ahead and did an ultrasound assisted, fluoro-guided L4, L5 transforaminal block, and we can see the contrast spreading in the transforaminal area in the caudal, in the epidural space, and he got a good relief, and the pain, quality of pain till the radiation started working, this block worked, and we didn't, the need of a repeat block was not there. This lady, she came with advanced cancer, with multiple meds everywhere, and she was complaining of severe pain, surgery, chemo was all done, but she was admitted for palliative pain relief. We started with IV fentanyl and all the other neuropathic adjuvants, but the pain relief was optimal. So we went ahead and talked about ultrasound-guided celiac plexus block, and they agreed for that, and we did a diagnostic block in this. This is where we do the celiac plexus block with ultrasound guidance, and that's what the injected is spreading, and that gave relief for her. When the diagnostic block worked, then we went ahead and did a phenol neurolysis of the celiac plexus. We gave a follow-up, and she lived for four months. She went, her last wish was to go to her village and spend her rest of the life, which she did, and the need of the opioids reduced, and the pain relief was very good, and the suffering and the quality of life was better. A very unfortunate 19-year-old female with advanced metastatic breast cancer and lung cancer with skeletal meds, humerus, affecting the humerus and the whole spine. She had taken radiation for the humerus bone, but still she came back after 2 weeks, and she was having severe pain along the shoulder and along the arm. So we started with analgesic, suboptimal relief. She could not sleep. It was bothering her like anything. Fentanyl, morphine were not working. And then she became allergic. She started vomiting with fentanyl, and so opioids were not working. We had to do something. So we did a suprascapular nerve block, which gave a good relief, followed by phenol neurolysis of the suprascapular. And then she got a very good relief. She has gone back to her home. We know that the life is limited, but at least the pain is under control. This is what they wanted, she and the parents. Now, this gentleman, he was a 76-year-old from Nairobi. He came with advanced cancer prostate, and he had pain in the rectal area and also in the back pain. So he started with, he was already on IV morphine, high dose of IV morphine when he came to us. When he was referred to us, he was having the neuropathic painkillers, The rectal pain was bothering, he was not able to lie down, he was not able to sit, and he was so frustrated that the the family was depressed and helpless, and they were feeling of guilt that they are not able to do anything. If you see that there are so many lesions in the spine, he was undergoing radiation therapy for the same, and in the PET CT, there's an enhancing prostatic mass which is infiltrating the anorectum and the pelvic nodes. So we went ahead and we started all these medications, but the pain was not getting better, so we spoke about ganglion impaired block, and they were ready for that. We did a diagnostic block, and we can see this is where the ganglion impaired is. That's the good contrast spread over the ganglion impaired, and then he got a very good relief, and then we did a phenol neurolysis of the ganglion impaired. And the pain reduced, and he went back to his country. He was very happy. He was able to stand, walk, and first time he asked for food. So this is a very small things, but it makes a huge difference. As we say ADL, if they are not able to eat on their own, as rehab physicians, we know what is the importance of this. So this is also very important. If the pain is being taken care of, and they are able to eat and then walk on their own, this is what we as physiatrists and doing pain, we are making a big difference in the life of these patients. Now the last case, he had lung cancer, and he had undergone thoracotomy, and 1 month post-surgery, he was on fentanyl, but was not getting 50 micrograms of fentanyl, but not getting proper relief, and he had pain along the scar. It was a burning pricking, so it was a neuropathic pain. We did a diagnostic intercostal nerve block, and he got good relief with the diagnostic and therapeutic. We used a little bit of steroid, but then he came back. This is where we are doing the intercostal nerve block. He came back after 2 weeks, and in the emergency, and then we had to do a phenol neurolysis of the intercostal nerve, and he responded very well. So the pain relief was very good, and the chemo and radiation went off very well, and now he's free of disease and also free of pain. So what are the other procedures which can be done? We can do a stellate ganglion block in head and neck cancer patients. We can do a lumbar sympathetic block for the lower GI cancers. Peripheral nerve blocks can be done, and followed by RF or ablation or phenol neurolysis. So we don't, I'm talking only on the physical pain, that the symptoms and the iatrogenic, which is caused by that, but there is so much. When we have to treat the total pain, because we are rehab physicians, so we do not just treat the symptoms, but we have to deal with these things also, because along with the pain comes the anger, the anxiety, and the depression. What we see is the iceberg, tip of the iceberg. What these things are also should be dealt with. When the pain reduces, then these things should be dealt with. So we need a multidisciplinary approach and a multidisciplinary team, which we all have. So the spiritual counselors, medical workers, the home caregivers, the physical therapists, and occupational therapists. So good rehab, and not only rehab, but the spirituality, and that also should be spoken about when we are talking to these patients. A brief idea about what happens in the end of the life, because they have pain. Now we cannot do any blocks, so we have to talk about sedation, because that is what is a therapeutic option at the end of the life when they are at home. We can use opioids, we can use benzodiazepines and propofol if they are admitted. Otherwise, benzodiazepines, they do a very good role. And a continuous assessment is very important, because the suffering has to be reduced. And to conclude, comprehensive approach to a patient with cancer pain is important. The patient and family should always be included, whatever management we are doing, whether pharmacological or non-pharmacological. And also the interventions, they can be included at any step. It can be the first step, we can de-escalate or we can escalate the treatment. And being rehab physicians, practicing pain and palliative care, when we talk about quality of life and adding life to whatever years or whatever the weeks or months the patients have to live, we can also improve the quality of death of the patient, because that is also very important for each and every patient who is undergoing cancer pain treatment. So I would end my talk with this quote: when the world says give up, hope whispers, try it one more time. Thank you so much for listening.
That was a very nice quote, Doctor. That is as well as always wonderful to listen to your lectures. And you are brought about one more part of the cancer pain, the pain intervention programs. And the floor is open for any questionings from anybody. Please, sir.
quality of death. Okay, but as you have mentioned about the use of bisphosphonates and denosumab in the bone mets, pain due to bone mets, I just want to know what is your experience or what is the take of uses of those agents in osteoblastic versus osteolytic mets?
We have to use in both osteoblastic and osteolytic. If there are skeletal mets, it should be used.
And do you find similar results?
Yes, but we have to tell them that there can be osteonecrosis of the jaw, which is very, very common when we use bisphosphonates. So the safer one is the denosumab.
And also atypical fractures of
And
femur and all
yes,
those things.
yes.
Yeah. But efficacy-wise, both are equal.
Efficacy-wise, both are equal.
Thank you. Thank you for your answer.
Thank you very much, ma'am. Your very nice presentation. Simple, I want to ask you one question regarding the non-pharmacological management in case of carcinoma pain. So, is there any role of repair system, that is virtual reality, to control this pain?
Virtual reality is coming in a big way in chronic pain management, non-cancer chronic pain management, but we still need some more good papers. I think so AIMS Rishikesh has it, and Rajkumar can follow up with that. We still need good studies for the virtual reality.
Okay, thank you.
Logically speaking, it has. Hypothetically, yes.
Thank you, Dr. Navita, for
Thank
the
you so
wonderful
much.
speech, and
Thank you.
it's really a nice lecture on you. I now call upon Dr. Sumalata from Aster CME Hospital, Bangalore. She is going to talk about DCS and hope for spinal cord injury. Is one another dimension of management, and I welcome Dr. Sumalata to speak. Please.
Yeah, good morning, everyone. How many of you have heard about DCS or ESCS? Can you raise your hands? Okay, what is it? Yeah, it's dorsal column stimulation. So is it a hope in spinal cord injury? Let us see. So recently, just the 30th Jan, we in the newspaper links, we saw that Neuralink has been tried by Elon Musk, which is a brain chip that he's put in the brain, and a human trial, first time human trial has been done. So it is not far that we will soon be able to help the paralyzed people, and we as physiatrists should grab this opportunity to be ready to explain to the patients, have our protocol set, and do what is required. So in spinal cord injury, the neuronal control of locomotion depends on the complex dynamic interactions between the spinal circuits, supraspinal structures, somatosensory feedback, and biomechanical properties of the musculoskeletal system. Complete spinal cord injury abolishes neuronal communication between the brain and the spinal neurons controlling the legs or the hind limbs. So my today's agenda is what is ESCS or DCS, rationale of DCS, the principles, the clinical applications, and the experiences. So what is it? It's spinal cord stimulation, and more specifically epidural spinal cord stimulation involves the surgical implantation of a small array of electrodes into the epidural space. So these are the different types of electrodes that you can see here, but the most common electrode which is used to implant is this, which is 5, 6, and 5 pattern. So it's basically a 16 paddle lead which is typically placed between the vertebral levels of T9 to L1. Although positioned epidurally above the lemniscal tract, the posterior roots entering the spinal cord at a given spinal segment are targeted. As we can see, this is the posterior part. This part is where the lead is placed. This is how it looks in the X-ray between T11 to L1 upper border. So the rationale for its use, like it started with the pain management. First used in 1967 at the thoracic level for treating cancer pain. Later used in neuropathic pain, extremities, failed back syndrome, and CRPS. And suddenly they started seeing some positive effects in spasticity in multiple sclerosis. And later, in late 1990s, they started seeing suddenly that there are some motor improvements in the spinal cord injured patients. So then the research started and the publications or the trials started. So this study shows that epidural electrical stimulation to facilitate locomotor recovery after spinal cord injury. Hind limb locomotor recovery is possible in various preclinical models such as mice, rats, cats and dogs because of a network of neurons called the central pattern generators. Like in this, they have explained why the recovery is or movements have been seen. So it is basically the central pattern generators in the spinal cord which helps in doing that. This spinal locomotor CPG can work autonomously without inputs from the brain and the periphery. After complete SCI, the locomotor CPG retains the ability to generate the basic locomotor pattern and interacts with the somatosensory feedback from muscle, joint and skin afferents that enter the spinal cord, caudal to the lesion. So ESCS raises the level of spinal excitability close to generating motor output, which is reduced in people with SCI due to the severely impaired descending spinal pathways. By this increase of spinal excitability, stepping movements can be generated during ESCS even in people with complete lesions. In people with clinically complete lesions but some preserved descending fibers, which is called discomplete lesions, supraspinal voluntary adaptation of stepping movements can be achieved during the ESCS. The improvement of coordinated movements during application of ESCS is most likely not based on structural changes such as the axon regrowth, since return of voluntary leg movements has been observed in some patients after just a few stimulation sessions, and no long-term recovery of voluntary function without the application of ESCS occurs. So this is how it is. When there is a complete lesion and there is an electrode which is placed which helps to just stimulate the motor neurons in the lumbar enlargement, and that helps in motor unit recruitment and the movements. So the central pattern generators again explained like how it helps, but in this again the limb movement or the displacement which causes the afferents from the 1A, 2 and 1B afferents which go and give signals to the spinal cord helps in a proper regulated movements. So electrical spinal cord stimulation must preserve the proprioception to enable the locomotion in humans with spinal cord injury. So initially they said that only the central pattern generators is enough, but later they found that the proprioception is necessary for them to get the adequate movements. So and in that proprioception also, so the type of stimulation also matters. When they are just giving the tonic stimulation or the phasic stimulation, what is the difference is what this study explains. In rats and mice, the antidromic, the spinal cord stimulator induced antidromic activity is around 20 to 100 beats per second, but in humans it is 0 to 60. So whatever signal is coming from the afferents, it can get cancelled and there can be no movement or a reduced movement. So properly placed electrode matters like how the movements are generated. So they also saw that electrophysiological mechanisms underlying cervical epidural stimulation in the adult rats. It has also found to not only have the motor recovery, but also autonomic function recovery after the chronic spinal cord injury. They tested around 25 patients with chronic motor complete spinal cord injury. And in this series, it was found to be safe and achieved numerous benefits on motor and the cardiovascular regulation. In one of my patients also, the patient themselves told that the patient never used to feel when they used to pass the bowel. But after this implantation, they have started feeling some autonomic changes and they realize that, okay, they are about to pass the bowel. A scoping review of epidural spinal cord stimulation for improving the motor and voiding function. So they have also tested whether it helps in the voiding function. In my experience, I have not noticed any voiding improvement, but the studies have shown that 5 and 2 participants respectively demonstrated improved supraspinal control of volitional micturition with the spinal cord stimulation. So it has also been studied that because the spinal cord works in a multiple ways, maybe some gene therapy or the additional medication therapy like serotonin intake will help in enhancing the movements in them. So this study for the first time employs a combination of EES facilitated locomotor training with intrathecal administration of the transgenes, and obviously these are preliminary studies. They still have to have a final conclusion. So there are predictors of volitional motor recovery with the epidural stimulation. Like not every patient will get the same movement or the same type of movement. So, but what we have seen is the time since the injury doesn't matter. So even after 10 years or 16 years also they have tested and they have found to have some improvements. So the aim of this study was to understand whether the individual's neuroanatomical characteristics or positioning of the epidural stimulation electrode were important factors which would influence the movement. The results suggested that greater coverage of the lumbosacral enlargement by the spinal cord stimulation may improve the motor recovery prior to any training, possibly because of the direct modulatory effects on the spinal networks that control the lower extremity. So even if other parameters are not working, like there is some atrophy at the higher level, spinal cord atrophy at the higher level, but if they are able to cover the motor enlargement in the lumbar area, so they measure it through various means by 3D reconstruction of the MRI, and the CSF volume, which is more in those areas. They have their set protocols to assess this, and they place the stimulator around the maximum motor enlargement in the lumbar area. So they studied that when they place it a little millimeter or a micromillimeter above and below, the results were not good as compared to the exact place that they are supposed to do it. So the targeted selection of stimulation parameters for restoration of motor and autonomic function in individuals with spinal cord injury, they concluded that the tonic interleaved functionally focused neuromodulation targets a myriad of consequences from spinal cord injury. This approach indicates the sophistication of the human spinal cord circuit and its important role in the regulation of motor and autonomic functions. Like these are what you see are the electrodes, what I told, no, 5, 6 and the 5. So total 16 electrodes are there. Say it is a bipolar electrode that we have to keep, that is one positive and one negative. So depending on what electrodes that we are selecting, the movement pattern changes. So in various types, and which one suits the best to the patient, it is decided on the operating table and also post that in the clinical trials. This is one of the few of the videos that I would like to show. Like without the stimulation, the patient cannot walk. This is with the harness that we are trying to see if there are movements. This is a complete spinal cord injury post bullet injury at around D10 level, and the patient is able to walk very comfortably. This is a soldier from Iran, so he has very good endurance, and he takes around 10 rounds in the parallel bar without a break. In fact, even if it is at this stage at the exercise level, even a movement or the activity like this would encourage them more, and maybe in the further in the future, with the better protocols and guidelines, we will be able to achieve a proper movement pattern. This is one of the other patient. In the initial stages, we used to get only one-sided movement. The other side was assisted by the therapist. And the movements were very slow, but a proper stepping pattern was achieved. Later, with repeated training or the different types of protocols or the electrodes that we targeted, the movements were slightly better, but both were coming together, so we had to restrict the other leg. Other thing that we noticed is, so can I take 1 minute? The position change matters in such patients. When they are sitting, the spinal cord or the electrode, how approximate it is to the dorsal column or the spinal cord, it matters. When they are lying, it is more approximate. So even say we are stimulating at 5 volts current. So when in the lying down position, the movement that we see are different when in the sitting and when in the standing. So in the standing, the distance between the implant and the spinal cord is far away. So the voltage requirement may be more, and also we cannot fix it directly to the spinal cord. So it will have some movements. So that also matters, like why we don't get the same movements in the lying, sitting or the standing position. So the limitations is like we are able to achieve with the harness, only walking, standing we are not able to achieve. So it again needs more number of trials and studies which will tell us what programs will cause both standing and walking. So the spinal intelligence and consequently neuroplasticity within the spinal cord to regain motor function is still limited. So the contraindications is like any other surgery, there is no other specific contraindication only for this. So when we recommend epidural stimulation to patients, so like mutual funds, it will come with a clause that voluntary control outcomes will vary from patient to patient. Thank you for the patience.
Thank you. Sumala, thank you very much. Actually, you have added a new dimension of neuroregeneration, neurorehabilitation, and pain management. It's a good, very evolving science. We would love to see more results out of this. So we have one more minute. We invite questions from the audience. Please, sir. Okay, from the same institute.
Thank you. Thank you, Sumalata, and well done for starting off something like this. So my question is simply, have you seen any of your patients coming out of body weight support and walking on their own with spinal cord stimulation?
So still not.
What is the cost?
So maybe the programming that or mapping we call it, that we are placing the electrodes or choosing the electrodes may be the cause.
Yeah, but that's a learning curve. I think eventually you might hit the right one.
Yes,
What
yes.
is the cost of the implant?
So the cost initially when it started at CMI, it was around 20 lakhs, but now it has come down to 9 or 10 lakhs.
Thank you.
But post-implantation, one of the patients that I have has been very diligently coming to me since 2.5 years. So it takes longer. Because in between she had pressure sore because of the long sitting. So
Dr.
it
Abhishek,
takes
please.
time.
You've done couple of patients. One simple two things I will tell you. The same system is now available in the transcutaneous form also. What you're doing, injection, epidural inside, there are machines available to do it now, even from skin. The system called as transcutaneous stimulation of spinal cord for CPG. Second point, people think with this machine, they will start moving their legs. No, it just a central pattern generator stimulation. You can't move your leg, but you can walk with the harness. Third thing, all patients with D8 below can be trained to walk with conventional therapy and KFOs only. So it's only useful if it can make a person walk from D1 to D8. The Zurich group has shown 4 patients with Asia A, C7 and C8 who are able to walk 10 steps. But take my word for granted, if this machine can make a person walk from D1 to D8, it's of any use, because D8 below, all patients can be trained in 3 months' time with conventional therapy.
So one of my patient was actually a cyst with long-term, long cord involvement with triplegia.
Okay.
So that lady also showed a good improvement and good trunk control when sitting.
Thank you. Thank you, Dr. Abhishek, for sharing your experiences, and thank you, Sumalata, you have covered so well. Thank you so much.
Sir. Thank you.
So next is we have another lady physiatrist, Dr. Gita Handa Thukral. Okay, she will be speaking on this is a very important topic for her, foot rehabilitation, the role of orthotics. So, Dr. Gita, please.
Good morning, respected chairpersons and dear delegates. Today I'll be speaking on foot rehabilitation and role of foot orthotics. This is almost always the last point in anybody's slide when we talk about foot rehabilitation or any condition of the foot. And it made me think about what can we do about it and how can we improve our prescription. So coming to the slides, once I started my journey, there were questions like when to prescribe, who will prescribe it, how to prescribe, where to get it from, how to use it, follow-up and maintenance, change in prescription, and when to stop using it. So these are the questions which we always face while dealing with the patient. So mostly when we prescribe, apart from the diabetic foot, which you have seen, and there are workshops also conducted, there are other conditions like foot pain, foot malalignment, there is foot muscle weakness, there is foot instability, then foot movement restriction is required or any assistance is required, or we need to alter the weight bearing or the limb length and there is a deformity which needs to be accommodated or modified. So foot orthosis, as we know, there are stock available orthoses which are over the counter. There are prefabricated like silicone insoles in different sizes are available. There are custom made orthotics. Example like specific measurements based fabrication is possible where you just give the shoe size and you can get it accordingly modified. And prescription based custom orthotics, that is which is custom molded after taking the patient's foot impressions by different ways. So there is a consensus key statement, and they have said that prescription custom foot orthosis may be medically indicated and essential, or may be useful, or may have some adjunctive role, and may not be useful at all. So accordingly we can prescribe, and we accordingly work on prescribing the foot orthotics. How to assess the foot and the footwear? We all know history and examination, which already many speakers have talked about, is essential. We do static assessment of foot, weight bearing and non-weight bearing. We do dynamic assessment of foot and gait analysis, and it can be instrumented with use of various machines and devices. You all know quite a lot about it, and I'll be touching in brief some points in between. So for examination, it is important to do the range of motion assessment, position of the ankle joint, rear foot complex, forefoot, rear foot relationship, do the muscle strength assessment, do the evaluation of the stance position, do the clinical evaluation of the limb length, do the gait evaluation either clinically or with some instruments, and assess the position, range of motion, and quality of spine, hip complex, knee complex, fifth ray, first metatarsal phalangeal joint, other MP joints, cons, callosities, ulcers, etc. So we keep a note of it, and we can make a chart and note down the important points. So for footwear, footwear assessment is also important. So we have to look for wear and tear of the outsoles, look for deformations inside the footwear, look for the preferences which the patient has and why they have those preferences, and changes over a period of time which the patient has experienced. Who will prescribe it? A wide range of available off-the-shelf devices are available. Off-the-shelf customization is also available, and custom-made orthoses are also available. And there is no data available who will prescribe it, but it is essential for us to know who has prescribed it earlier and why they have prescribed it so that we can give our prescription accordingly. And prescription points are orthosis type, correction type, arch fill technique, cast modifications, any shell material which needs to be modified, shell modifications which needs to be done, and cover material which can be used. So minimal prescription requirements are, first is functional orthosis, where we need to know the type of material to be utilized, the cast balancing techniques which we use like intrinsic correction or rear foot or forefoot posting if it is required, and depth of heel seat. And we can also give accommodative orthosis when we don't want to mobilize or correct the foot. So there also we need to choose the material. We have to see the location of the lesion or areas of pressures to be accommodated or off-weighted. So modes of modeling of feet for the category 1 are that modeling of the foot is done in the subtalar neutral position. That is, the subtalar joint is manipulated in a way that you maintain it in a neutral position and then take the cast. And in the category 2, the modeling of the foot is done in a natural position, which is weight bearing, and we try to accommodate whatever is there, and we try to accommodate the deformities or try to redistribute the weight when we want to offload it. Here we are not trying to do the subtalar neutral position. So for the subtalar neutral position, that is trying to correct the foot, we hold the foot in a position where we put our hands on the side of the sulcus area on the 4th and 5th toe, and the cast may be obtained either in a supine or a prone position. And we can also similarly do this in the same position only, the computer imaging, and take the cast accordingly. So this is in detail describe the subtalar joint neutral position where the task can be taken, and we put our fingers along the sinus tarsi on one side and navicular tubercle and try to correct it so that the foot is aligned with the rear foot. And accordingly the patient is given the cast. In the accommodative casting, there are different varieties available. Weight bearing and semi-weight bearing casting can be done, and computer and mechanical imaging systems are there which reproduce the actual foot shape and contour in a weight bearing or semi-weight bearing position. And there are many common customizations which you all know. There are forefoot extensions, post-flaring, flanges, lens, cutouts, cast fill and accommodations. Location of the lesion also affect the different modifications. And there are different patient informations which are needed, like shoe size and width, heel height, heel lifts, etc. And there are biomechanical data which also affects our material choice and the footwear choice, like weight, age, activity level, occupation, and diagnosis. And previous orthotic use is important, and systemic diseases and habits are also needs to be ascertained. So relevance of prescription has been questioned. There are no defined clinical guidelines. The initial reliance on root model of foot assessment and biomechanics was not considered sound basis for prescription. Personal experience and experience-based prescription is most often practiced, and therefore logical understanding and prescription of foot orthosis is to be practiced. So here, relevance of technology is there. We have 3D foot scanning, we have foot pressure analysis system, there are foot paid index available, which is more used than complicated biomechanical systems like foot posture index, and newer technologies are in pipeline to assist in different stages. So custom foot orthosis, which is most commonly now in use, is foot orthosis, which are the pieces, inert pieces, which work either psychologically, that is by a placebo effect and comforting, or mechanically by altering the reaction forces at the foot orthosis interface. And mechanically they can alter the kinetics and the foot orthosis interface by virtue of 3 variables, that is their superior surface geometry, their load deformation characteristics, and their frictional characteristics. And there are biomechanical considerations which are given by the Kirby, where they say mainly the main thing is the pressure principle, where force divided by the area of application defines the pressure, and we can redistribute the pressure. The more the area available, the less the pressure, and accordingly we can modulate the different modifications. So there are different types of inserts which can be used to balance the joints of the foot in the most desirable position for weight bearing, and it compensates for any malalignment caused by deformity between the leg, foot, and rear foot, and it should be placed in a subtalar neutral or a position of maximum external rotation of the foot or eversion at the mid-tarsal joint. So there are different prescription modifications available which I'm not going into the detail of. We should be knowing about it, about different modifications, but grossly, which you can see in this table, most of the modifications are focused around the pronation correction. For example, press planus, there is pronation correction required. Metatarsalgia, there is more of accommodation required. In Morton's neuroma, there is again pronation correction required. In tendinitis also, there is initial immobilization followed by pronation correction. Then posterior tibial tendon dysfunction, there is again pronation correction is required. In patellofemoral joint syndrome, there is also pronation correction required. So most of these things which you see require the foot to be in a better biomechanical space so that there is less loading on the foot and there is less dysfunction of the foot. Similarly, for the iliotibial band syndrome, pronation correction required. For limb length discrepancy, we give heel lift and correct the pronation. And inflammatory arthritis, we do accommodate the whole foot, but we have to give it in a proper supportive posture. In the pes cavus, though, there is a custom arch support required as per the arch of the foot. And in the plantar fasciitis also, we give pronation correction, and here we give some deep heel cup also. So these are the basic guidelines which help us define what kind of a prescription orthosis we need to give. And there are different modalities like pedobarography, which is available. There are traditional ways of taking the measurement, and then there are other ways of taking the measurements, like we have custom molded foot orthosis using molding platform and thermal molding. This is the material which we, the machine which we have in our department, where one of the, this is used to take the measurement. This is used to thermomold the insoles, which are prefabricated like this, and then we cut it around and fabricate it as per the patient's foot. Similarly, we have a mobile-based approach also, where we take photographs with the mobile. So this is the project which we did with the DBT-funded project with the startup, where they had developed this mobile-based program, where we used to take the photograph and then advise for any modifications, and they used to 3D print that. So this was the way the things were progressing with the mobile-based approach. And the user flow was there so that the patient, when comes to us, gets the thing made and delivered to him, and which can be repeated as per the requirement. And it was using computer vision, machine learning, surface remodeling, and 3D printing technologies. So in the custom orthotics, we have a bottom 3D printed TPU and upper layer, which was EVA, Poron, or Plastazote, depending upon the requirements. And coming to different materials, we had blue Poron, Spenco, Pro Poron plus Plastazote if required, and there are other materials also, and EVA is the most commonly used material for making the foot orthotics. So these are the other type of equipments which are used for making foot orthotics and measuring the foot parameters. And these are some other companies which have come out with new innovative foot type insoles which are available in the market. So coming to the end of my topic, establishment of foot rehabilitation clinics can help in better management of patients needing foot orthosis. It is a time-consuming, dedicated process, and the results are evident instantly. Physiatrists can do a great work with dedication, and excellent results are guaranteed. Availability of basic equipment such as foot scanner, mobile phone acquisition images, 3D printer, or thermoforming machine, custom moldable insole material is needed for setup. Repeat orders can be executed in 3D printed modules. Most of the modifications can be done on the desktop with suitable softwares. It helps in serving the patient better and provides instant satisfaction of service delivery. And pain relief is mostly 80% with proper custom molded footwears, and recurrence, it prevents recurrence also as per our study at AIMS. Thank you so much.
Oh, thank you, madam. Thank you for a wonderful talk. There is always a difficult talk for the students to understand, analyze the biomechanics, all the issues with the foot, and you made nicely presentation. One questions from the audience, please. I mean, there are two hands up. Okay, Ganesh.
Namaskar, madam. It was a very nice presentation. Just wanted to know that you have compared the custom-made foot orthosis. Wanted to ask that in your practice or in literature, what does it say that if ready-made foot orthosis or insoles are taken, how much of the patients does it relieve? Is it 20%, 30%, or it's you prescribe custom-made 100% to your patient?
Yeah, actually, as per my practice, I've seen that patients who take over-the-counter silicone insoles are never comfortable with it, and they don't like it. So most of the time, I change them over to the custom-made orthotics, and they feel much better after taking the customized insoles. That's my personal, and we did the study also. So in that also, we found that they are much more usable, and much more patients' improvement is seen in case of customized insoles.
Thank you, madam. Thank you. Okay, sir, please proceed.
Thanks for your comprehensive presentation. I just want to know a small thing. In neuropathic foot, which is the material of choice for insole?
Poron is the most important, because Poron is the one which is, a similarity to the microcellular rubber which we use, and Poron has a much better quality, much better than even microcellular rubber. So poron is the most commonly used, and if we want to give stiffness, we can add other layers. So we can make it multi-layered if we want to add stiffness, otherwise poron is the best.
Thank you for the wonderful talk,
Thank you
Dr.
so
Geeta.
much.
As Dr. Geeta and as to go for the next session, to start the session, this program is almost complete in the other gallery, so I request to receive the honors from the chair. Please.
Thank you, Dr. Gita. We have another very interesting topic, and it is coming up, Evolving Science Regenerative Therapy in PMR by Dr. Sudhir Mishra, Additional Professor, KGMU, Lucknow. Sudhir Mishra, please.
Thank you, organizer, to giving me opportunity as well as a topic to present myself. And this topic will be based on more of practical thing and based on my patient feedback and what feedback I got from the other societies. As I'm presenting this type of topic in last 6 months, third time in different platform and with different society. So, good morning, all of you. My topic is regenerative medicine, regenerative therapy. This is the ideal regeneration, which is given by the nature. Thing which is there anatomically as well as physiologically, it should be regenerated. That is ideal regeneration. So this image itself clear the thing. This should be the future of our medicine or rehab medicine. There are three three things we have to remember. Regenerative medicine, it seeks to replace tissue or organ that has been damaged by age, disease, trauma, or congenital issues. Then regenerative therapy is a therapeutic application of regenerative cell like stem cell, PRP, dextrose, prolo, and other regenerative therapeutic agents. And then regenerative rehabilitation, where we are working, is integrate regenerative technology with rehabilitation clinical practice to restitute function and quality of life of individual with disability, which was otherwise irreparable. From first regenerative medicine, our target is regenerative rehabilitation, but path is through the regenerative therapy. So my topic is regenerative therapy. These are the, as previously slide, you can see regenerative medicine treatment include PRP, prolotherapy, liposomes, and stem cells. Few mechanism action of regenerative therapeutic agent, which has been used. Bone graft, it has osteoinducive, osteoconductive, or osteogenic effect. It stimulates new bone formation, but it does not affect regeneration of muscle as well as tendon. Then autologous blood, PRP, autologous condition serum. They are my highlight of my presentation. Then they deliver the growth factor and stimulate the repair. And stem cell, which is becoming very popular, and it is believed that they replace the dead or dying tissue by improving the regeneration capability. PRP, I think this was already been discussed in first session of today's first session. So any question will be related with that. I'll go in speed in this thing. Why PRP? It has many growth factors. When it is called PRP, when your platelet concentration is 5 to 7 times or 1 billion platelet per microliter. There are 3 type of PRPs, being platelet derived group available PRPs. Pure platelet rich fibrin, then leukocyte rich and leukocyte poor. Difference between leukocyte rich and leukocyte poor is this filter. This is a filter which can convert leukocyte rich to leukocyte poor. This is a method of preparation. There are two methods, gel method and means gel method, single times centrifugation and twice double soft and hard spin method. We can discuss it later on also. Then it has clotting. The platelet get activated, release the growth factor. Approximately 70% of growth factor get released within 10 minutes and remaining in 1 hour. This is the thing which has been, I was very interested in this thing, autologous condition serum. This is the orthokinetic therapeutic serum, therapeutic method. In this, in PRP and this method is almost same, instrument is same with slight difference. It includes collection of 50 ml of blood in chromium sulfate coated glass beads. It should be there. Then it is being incubated and heated at 37 degree for 12 hour or 24 hour. If you don't have incubation machine, you can store at 24 hour. It will automatically get heated. What this does, it produces interleukin 1 receptor antagonist by WBC, which is pro-inflammatory. So once the receptor antagonist get generated, inflammatory effect get reduces. Then centrifugation at 12,500 revolution per minute for 10 seconds. Then after that, same, it is separated. Supernatant serum is separated. Like in PRP, we take the Buffy coat. In this, you collect the supernatant serum and then filter it by 0.22 microfilter, and that is been injected over the musculoskeletal pain area. This is the slide showing the difference in PRP and orthokines. In orthokine we use serum, in PRP we use the Buffy coat. This is in previous study, it is found very effective in lumbar, mainly in the radicular pain or related with the spine. And one more article is being published last month that tried this in ONE also, but I have yet to be do more research. Then come to the prolotherapy. You know that dextrose prolotherapy is being used more commonly, and there are many prolotherapeutic agents are being used, but dextrose is most commonly used, and it is thought that it increases the growth factor. But we had done 3 studies in our institute with this prolotherapy, and in ONE, plantar fasciitis as well as tennis elbow. This is effective, but effect doesn't last more, and you require a multiple injection compared to the PRP. This is a study, and you can see the prolotherapy has been used on TM joint arthritis, knee osteoarthritis, back pain, sacroiliac joint pain, and so many things. Then we come to the stem cell. What is a stem cell? Stem cell is had capacity to differentiate multiple type of cell, and it itself get help in regeneration of the damaged tissue. But what is the problem with stem cell? Stem cell to collect in adult patient, we required the stem cell from the bone marrow, and that is pain to collect a bone marrow required hospitalization as well as a painful procedure, required anesthesia, and all those things are required. But once you collected the bone marrow, there are three methods, three places from where you can collect the stem cell: the bone marrow, then lipoaspiration, and isolation from the tooth pulp. I have experience with, not myself, but with the other colleagues, bone marrow as well as liposuction. Method is almost same as we used in centrifugation and other things. In bone marrow aspiration, you collect the bone marrow, then centrifuge it. You can see there is a two tubes in two number. One is double spin method, and which is on your left. Another is single spin method. Single spin method means they had used the gel to separate, as similar to the PRP. That is, gel is known as Ficol gradient centrifugation. Then after the collecting the stem cell or that buffy coat, you have to culture it, expand it, and after what is the criteria when it is told to be stem cell is matured? There is the image is not that clear. The CD4 count, there 2-3 CD4 count, there should be present in that. Similar thing is with the liposuction also. In that you collect the fat, then clear it by separation. The upper adipose tissue is been again collagenase 1 digestion is done, and then centrifugation, then stem cell get collected, and same method, expansion and characterization, means once the marker developed, then you can administer over the required site. When you should not do the stem cell? When there is a systemic or uncontrolled infection, poor functional capacity, end organ damage, psychological affecting the ability of patient, and melodoplasia of bone marrow. Then autologous blood injection. This was used in the past, not in being used present time. In this, you have to collect the blood, infuse over the site. It causes a lot of pain. So the thing is not being used, obsolete. To conclude, understanding the principle of regenerative medicine is essential, and incorporate them into the rehabilitation medicine with the help of regenerative therapy is critical in order to deliver validate science into the clinical option that will allow you to build a model of care that can have potential to change the word care to cure. It should be remembered, we have to convert our care service to cure, and the way is regenerative therapy. Thank you.
Thank you, and right on time, sir. Thank you for finishing right on time, Dr. Sudhir Mishra. Is wonderful. And really, the end point to the patient, I'm all right. That's what he wants, whether you give whatever the therapy he wants. That rehab medicine, really nice. The floor is open to question.
Very nice presentation.
Thank you, sir.
Simply, with the help of regenerative therapy, stem cell, how many patients is cured?
Sir, stem cell is being used used for CP patient, stroke patient, SCI patient. But as far as my experience is concerned, and my experience with other person, the other society person is concerned, they had not been helpful in stroke and TBI and other things. They have been used and found successful in musculoskeletal disorder as well as in the osteoarthritis and other degenerative. In the degenerative, not in the neurological condition.
Thank you.
No, No. Failure rate, my main focus is use the thing for the musculoskeletal disorder at present. Whatever comes in the future, we'll see at that time.
Thank you, sir. Dr. Navita?
Yes, ma'am.
Thank you, Sudhir. So,
Yeah.
my question is, you have very well elaborated all the regenerative therapies. So, in your practice, or what is your experience, which is the best for regeneration, ONE? What would you prefer?
Ma'am, regeneration of ONE, we had doing the study as well as done study with the PRP as well as this prolotherapy. At present, prolotherapy is giving good response, but the other association where I had delivered the lecture and discussed the things, stem cell is found more superior in cases of OA, but I had not have my own experience. By next year or in 2 years, I'll come to know what is it there. But even if we do the PRP properly, we can have better result with PRP also, because stem cell is painful. That thing is that main.
So, what is, when you say BMAC, when you say stem cell, and you say expansion, and then go for the CD4, do you do that? Do you really do that, or is just the BMAC which you are the BMAC?
Actually, few companies are there. They are promoting. You give the patient, you withdraw the bone marrow and give.
Are you doing it? Are you really going for that CD4?
No. This is the method. We are not I had not used also, but this is the method by company people.
We're running short
I
of
don't
time.
know they are doing or not.
Thank you, Dr. Sudhir. Thank you, Dr. Navita, for this wonderful talk and a brief overview of the regenerative medicine. Now I call upon Dr. C. Ramesh, Professor and of the Department of Sports Medicine, Chettinad Medical College, to give a topic on cardiopulmonary exercise testing. Dr. Ramesh.
Good morning, respected chairperson, delegates. Thanks for opportunity. This is my contents of the talk. Cardiopulmonary exercise testing has emerged as an important clinical tool for assessing exercise capacity and predicted outcome in patients suffering from heart failure and other cardiac condition. It is a non-invasive dynamic physiological test that permits evaluation of peak exercise capacity and submaximal exercise capacity. It evaluates integrative exercise response between pulmonary, cardiovascular, and skeletal muscle system. CPET application in patient management is growing due to inability of the resting pulmonary and cardiac function testing to predict the exercise performance and functional capacity. Current clinical implication, evaluation of undiagnosed exercise intolerance for the objective determination of functional capacity and impairment. CPET machine involves the measurement of respiratory oxygen uptake, carbon dioxide production, ventilatory measures during symptom limited exercise test. This is a cardiopulmonary exercise test machine using a cycle ergometry. A non-rebreathing valve is connected to the mouthpiece with a continuous ECG and blood pressure monitoring. Resuscitation apparatus in hand. Physiology of exercises. Peak exercise capacity is defined as the maximum ability of cardiovascular system to deliver oxygen to the exercising skeletal muscle and the exercising muscle to extract oxygen from the blood. This system delivery to the oxygen and to the metabolizing cells, then get back the waste products in order to maintain the physiological milli-interior. Consequently, the exercise tolerance is driven by the following factors: pulmonary gas exchange, cardiovascular performance, peripheral vascular disease, and skeletal muscle system. This is aerobic energy system. It resides in the mitochondria. Oxygen-dependent glucose metabolism. The glycolysis is a central metabolic pathway in which glucose is converted into various metabolites. And in what happened in aerobic energy system, the glycolysis occurs, pyruvate enters into the Herb cycle, oxidative phosphorylation occurs, electron transport chain. Advantage is more ATP production. What happened in the absence of oxygen, the aerobic metabolism takes place when the production of lactic acid. Pyruvate is converted into lactic acid. Factors determining the exercise capacity: pulmonary factors, cardiovascular factors, metabolic factors. Pulmonary factor, tidal volume, respiratory rate, and minute ventilation. Minute ventilation is equal to tidal volume into respiratory rate, whereas alveolar ventilation is equal to tidal volume minus dead space into respiratory rate. Heart rate maximum is achieved just prior to total exhaustion and physiological end of the individual. The heart rate linearly increases with the VO2 max. Predicted maximum heart rate is 220 minus age. Cardiac output, stroke volume into heart rate. Stroke volume is the difference between end diastolic volume minus end systolic volume. Resting cardiac output is approximately 4 to 5 liters, but during exercises can reach up to 20 liters. Systolic blood pressure, this is normal below 25 and diastolic normal below 85. This at rest, 15 to 20% of the cardiac output is distributed to the skeletal muscle. During exercises, 80 to 90% of the cardiac output is selectively delivered to the working skeletal muscle. This is normal. Skeletal muscle releases only 100,100 ml, but here exercises 20,000. So the myocardial blood flow increases 3 to 5 times with the exercises. Then come to VO2 and VO2 max. The most widely recognized measure of cardiopulmonary fitness is aerobic capacity is defined as physiologically as the highest rate of oxygen transport, that is normally 3.5 ml to 4 ml per kg per minute. Maximum exercises it went up to 20 to 97 ml per kg. Carbon dioxide production normal 2.8 ml per kg per minute, at rest up to 35 ml per kg per minute during maximum exercises. This is an anaerobic threshold. Ability to exercises 80 to 90% of the aerobic capacity normally occurs 60 to 60% of the VO2 max. This see the curve. This is x-axis represented as VO2 max. This is lactate concentration. This is yellow is untrained. This is red is trained. See, trained, what happened? The lactate threshold occurs when the maximum attain maximum VO2 max here. What happened in untrained? See, lactate threshold occurs even below 50% of the VO2 max. Metabolic factors, lactase plus bicarbonate is equal to carboxylic acid, lactate, and water and carbon dioxide. Normal blood lactate level is 1 millimole per liter. What is ABLA? ABLA, onset of blood lactate level exceeding 4 millimole per liter. ABLA is also defined as a point at which the minute ventilation increases disproportionately with the VO2 max. This is ABLA, this is the minute ventilation. See, at the reach of ABLA, the minute ventilation is disproportionately increases. Respiratory exchange ratio, the ratio of carbon dioxide produced to oxygen consumed, quantifies the macronutrient. Average is 1.0 per carbohydrate, 0.7 for fat, 0.82 for protein. Oxygen pulse is equal to VO2 bar HR, normal 2.5 ml to 4 ml per beat. At exercises, 10 to 15 ml per beat. Fick equation states that oxygen uptake is equal to cardiac output times the arterial oxygen and venous oxygen content. VO2 is equal to SV into HR into CaO2 minus CvO2, and one metabolic equivalent is the resting uptake in sitting position equals to 3.5 ml per kg per minute. Fick exercises at maximum exercises. VO2 max is equal to SV max into HR max into CaO2 max minus CvO2 max. VO2 max provides a quantitative measure of person capacity per aerobic ATP resynthesis. Maintains intensive activity longer than 4 to 5 minutes. High VO2 max represent the integrated high-level response of diverse physiologic support system that is involved pulmonary ventilation, hemoglobin concentration, blood volume, cardiac output, and peripheral blood flow. This is VO2 plat occurs at near exercises healthy human, and it is recognized as the best evidence of VO2 max. However, in clinical setting, a clear plateau may not be achieved before symptom limitation of the exercise. This is an indication for a testing. This is a contraindication for a testing. Proposed criteria: ventilatory function, pulmonary artery pressure, aortic dilatation, arrhythmia, saturation with exercise. Exercise testing protocol: exercise testing usually done on submaximal intensity. Various studies have been conducted using step and ramp protocol. Traditionally, cycle ergometer and treadmill have been used. depending on the equipment used, there can be variation in testing parameter. 85% achievement are predicted 220 beat per minute per age. RPE more than 7. This is a Norton protocol, asked and do's. In an athlete, we follow a treadmill boost protocol. Then if patient has got mild or congestive cardiac failure, we preferred a Norton protocol. This is a optimum cycle functional assessment bicycle between 8 to 17 minutes. Bicycle work is quantified in watts. Monod principle, initial workload patient with congestive cardiac failure 20 to 25 watts. Increase 15 to 25 watts per every hour. Variable depending on protocol used. So this is an indication for a termination test. So maximum and sub-maximal exercise tests are conducted periodically in athlete for Department of Sports Medicine. My team of doctors train in sports and exercise science. Thorough history and clinical evaluation of both general and systemic examination with the history focus in American Heart Association cardiac checklist. So this is a reason for test is functional aerobic capacity, national level swimmer, age 26, 170 centimeter, 65 kg. ECG, spirometry done, normal. There's no obstructive and respiratory. Restrictive menoric cycle protocol is used. Participant was able to exercise 7 stages out of 10. VO to max predicted is 41 ml per kg, but he achieved 42.7 ml. RER achieved 15 minutes. RER achieved 15 minute. Workload is 176. And maximum heart rate is 221 beats, which is 113% of predicted maximum heart rate. So this interpretation, cardiovascular fitness reflects maximum amount of oxygen consumed during each minute. The individual value can range up to 10 ml per kilogram per minute in a cardiac patient to 90 to 80 to 90 ml per kg per minute. This is a average general population, improves with training and decreases with age. This is Paralympic Games or world second largest sporting event. An athlete of different eligible physical impairments are allowed to participate. There are 27 different sports on Paralympic region. Some of them, this athletic event include 100 meter, 200 meter, shot put, discus, high jump. Sporting events, wheelchair, basketball, wheelchair, rugby, adapted tennis are being popularly played in Paralympic event. World Para Athlete classification categories according to International Paralympic Committee: impaired muscle power, impaired passive range of movement, limb deficiency, leg length difference, short stature, hypertonia, ataxia, athetosis, vision impairment. Athlete visual impairment participate in sports like para-archery, para-athletic, para-cycling, para-equestrian, judo, para-rowing. Intellectual impairment, athlete with intellectual impairment will compete athletes like swimming and table tennis. Physiological profile and correlation between VO2 max and match distance running performance of soccer players with visual impairment. The aim of studies were to determine the differences in VO2 max between soccer players and sedentary men with visual impairment. The running performance of soccer players during matches were measured. The results of this study showed players with visual impairment have significantly greater value VO2 max than sedentary men. Becoming a Paralympic champion, analysis of the morpho-functional abilities of disabled female athlete. An exercise test to exhaustion on a cycle ergometer was performed 3 times a year on a cross-country disabled female skier over 10-year period. The morpho-functional level, when enabled the athlete to compete for gold medals with Paralympic Games, best reflected in the results obtained by VO2 max test. So this is my take-home message. The ability to perform exercise involves the integration of multiple physiological systems. Cardiopulmonary exercise testing remains a valuable modality in clinician evaluation. Measurement of maximum oxygen consumption provides an objective and reproducible indices of maximum exercise capacity. CPET helps in determining a high individualized training intensity zone in elite sports person for prescribing a structured exercise program. My references. Thank you.
Thank you very much, Dr. Ramesh, for keeping time, number one. Number two, okay, you have covered in depth about the CPET, cardiopulmonary exercise testing. That is the backbone of exercise prescription, especially in PMR and sports medicine practices. You have covered so well. Actually, everybody, every physiatrist, every responsibility specialist must learn doing by themselves and prescribing based on that. That's very important thing. Now the floor is open for questions. If you have any or comments. Microphone, please.
Thank you, sir.
Our ejection fraction is 45%, and having the dilated cardiomyopathy, she wants to take part in the working sports. Is it possible for her? How you do test?
Sir, I got experience in athletes, sir. I don't have experience in existing cardiopulmonary disorders, and also in the old age group, especially the ejection fraction is 45 more. I don't have any experience, but the opinion should be obtained, pulmonologist's opinion should be obtained, and this cardiologist's opinion on resuscitation apparatus, everything by the hand. If this test is mandate, then with equipped all things we can proceed with the test.
She participate.
I don't have that. I am working in a sports institute, sir. I think the pulmonologist. I think the pulmonologist and the cardiologist department, I will do with this type
Thank
of.
you very much. Well, okay, Abhishek, please.
To answer your question, we can do a limited testing for people who have low EF. It's been recommended by American Heart Association.
Thank you very much.
Thank you, sir. Thank you.
Thank you very much.
Thank you.
So, thank you, Dr. Ramesh. May I invite all the speakers of the session 9, Dr. Harsanan, Dr. Nabita, Dr. Sumalatha, Dr. Sudhir Mishra, Dr. Ramesh, please be on the stage to please come to the dais for the felicitation, please.
So, next, Sir, thank you, sir. Next, I request Professor T. Jayakumar, sir, to come over the dais to honor the chairpersons, Professor Tirunavukarasu, sir, and thank you, Professor T. Jayakumar, sir. Thank you, chairpersons. The next scientific session 11, I welcome Professor Edmund D. Cotto and Dr. T. Ranganathan to come on the dais. Welcome, sir.
Good afternoon and welcome to the session 11 of the IAPMRCON. This session is mostly related to neurorehabilitation, and I think neurorehabilitation is an area where most of us face a lot of difficulties and even frustration in managing these patients and in getting good outcomes. So we'll start off the session now. The first speaker, I call upon Dr. Sandeep Dole, Associate Professor, All India Institute of Medical Sciences, Bibinagar. He'll be giving a talk on neurofunctional interventional approaches in neurorehabilitation.
Thank you, sir.
Dr. Sandeep.
Good morning to all of you. Today, I will be speaking on neurofunctional approaches in neurorehabilitation. So we all know that these approaches are play important role in management of various neurological conditions to improve the function after the impairment and activity limitation. There are some approaches like PNF, NDT approach, Roots approach, Bernstrom approach. These four approaches are basically old sensory motor approaches. And there are some task-oriented approaches like motor reordering program, CIMT, bilateral training program. So in order to understand these approaches, we should know what is motor control, how movement is get controlled. So there are some motor control theories that explain the motor control. So first, there are some like reflex theory, hierarchical theory, motor programming theory, dynamic systemic theory. So in reflex theory, they said in early 1990s, Charles Sherrington said every movement is due to the stimulus or sensory stimulus. If we touch any hot object, we'll withdraw the limb, hand, because of the withdrawal reflex. So reflexes are the building blocks of the complex VRL, but he doesn't explain how spontaneous or voluntary movements acts, or how single stimulus cause variety of those responses. Then hierarchical theory comes. In this theory, they explain that lower levels are controlled by the higher levels, and there is a strict vertical hierarchy. Like brainstem and spinal cord control primitive reflexes, which are over the period get integrated in the CNS, and cortex then control various fine motor activity or voluntary controls. If there is a dysfunction in the higher functions, there is a return of these to more reflexive and primitive movements, but they doesn't explain how sometimes lower level dominates higher level, like in withdrawal reflex. Then then comes motor programming theory. In this theory, they explain that motor movements can be possible without reflexive action, and there are some spinal neural networks. They can cause locomotor rhythm without any sensory or any feedback or any CNS control. And they introduce the concept of central pattern generator that can able to produce movement like walking and running. These can be modulated with sensory stimulus. And this theory emphasizes on the capacity of relearning, and the therapy should be include training of key movements rather than focusing on muscles. And then comes dynamic system theory. It's basically any movement is depend on the three factors: individual, environment, and task. Like there are individual constraints like cognition, action, perception. Like it's also depend on the task, what kind of task, like stability or mobility or environment. There are some regulatory, non-regulatory factors, like shape of the object is a heterical model. If you see these theories, most of the old like NDT approach, Brainstorm approach, and all the old approaches, roots approach, they are primarily based on the reflex hierarchical theory. But task-oriented approach, like motor learning and other CMT, they are basically based on dynamic system theory. So in roots approach, he uses various facilitatory and inhibitory stimuli to increase the tone or decrease the tone, like eyes brushing over the muscles. Then proprioceptive stimuli like manual joint compression, quick stretch, tapping, and to decrease the tone, slow rhythmic movement, neutral warmth, maintaining stretching. In NDT, they emphasize on to normalize the muscle tone and inhibit the primitive reflex, and by to facilitate the normal postural reaction. They uses various inhibitory techniques like weight bearing over the affected limbs and use of various positions. In PNF, they describe various mass movements that are diagonal in nature, and they use this diagonal movement to facilitate normal movements. They uses, if you see, we do various kind of movement in which are diagonal in nature. So they use unilateral always and bilateral movement also. In Brainstorm, she explained various stages of the recovery after the stroke, from flaccidity to isolated coordinate movements, and she uses this synergy to get isolated coordinate movement with along these stages. In CMT, there is a forceful use of unaffected hand, and there is constant on affected. There is a use of unaffected hand and constraining of unaffected hand, and there is a modified version also. Then in that there is a decrease in duration. Then bilateral training technique, we have to practice the same activity with both upper limb simultaneously, and there is a proposed hypothesis that activation of intact hemisphere will activate the damaged hemisphere, as there is a connection through corpus callosum. So one of the most important approaches is motor relearning approach. It's a task-oriented approach, and basically there is a relearning of motor control. In this approach, there is a training of most real-life activities like walking, sitting, standing, and there are 4 stages. First, we have to analyze the tasks, like in standing, we have to observe the patient, we have to analyze, we have to see is there any missing component, like if the patient having quadriceps weakness, then we have to practice that missing component, and then practice the task. And there is a transfer of learning in 4 stages. 4 stages means we can change the environment, we can change the self-monitored training we can give, we can give advice relative to train, so we can include the relatives. So, and important point to consider, that we can do entire task, or we can broken down task into various components to make the motor to practice. We can give visual or verbal feedback and instruction and manual guidance, but this should be decreased over the period, and passive movement should be limited, and we can alter the speed to increase the variety. They have given the guidelines for various for 7 daily function like upper limb function, orofacial function, sitting, standing and walking, but they have not considered spasticity and severe cognitive deficit patients. So practice doesn't make perfect, rather it comes to motor engram. Perfect practice makes it perfect. So this activity, overhead activity, using pulley should be avoided instead of having the spasticity. And instead of that, rock the baby, that abduction and adduction movements can be done. If you see the literature, there is one review, systemic article showing that Bobat is not superior approaches in stroke, not superior to other approaches, and no evidence is available to superiority of any approach. And there is one article showing the NDT was not effective in care of stroke patients. So, and there is one review article shows task-oriented approach based on systemic model is proposed and contrasted with traditional NDT approach in CNS dysfunction. So in this, another systemic review article shows task-oriented rehabilitation is more effective, and it is feasible also for nurses and other in the ward and home. So, and if you see the recommendation by American Stroke Association, they mainly recommend that for ADL, therapy must be based on functional. It should be appropriately challenging, and there should be that therapy should allow repeated practice. And the training of ADLs and instrumented ADL, they have recommended, both have class 1 recommendation. CIMT for adequate activation have class 2A recommendation, robotic therapy, and NMES have for more moderate to severe cases class 2A, mental practice and strengthening class 2A recommendation, bilateral training class 2B recommendation. If you see for motor impairment, there is no superiority of any specific approaches in neurorehabilitation such as NDT, Bovath, Bunstone, PNF has not been established. So we should, finally, we should use it or lose it, and our therapy should be task-oriented, goal-oriented, and that should be, repetition is important. Thank you very much.
Thank you, Dr. Sandeep. That was a good, you took us all through all the neurophysiological approaches. The floor is open for questions. Any questions from the audience? Thank you, Dr. Sandeep.
Thank you, sir. Thank you.
So our next speaker will be taking us on a journey into what's new in the advances in neurorehabilitation. We welcome Dr. Abhishek Srivastava, Senior Consultant, Gokilaben Hospital, Mumbai.
Good afternoon, friends. Thank you, Chairperson, for the introduction. It's a big topic. I will cover in 13 minutes' time if possible. See these scans, people with very bad brain injury or intracranial hemorrhage or strokes, how do you think they are at 1 year post-strokes or post-injury? So in the ICU or home care, I show you how they are if you use advanced neuro rehab to help them better. Can we change the brain? We were told it's not possible in studying medicine. Now there is enough evidence to show brain can change in response to a stimulus. Our job in rehab is to make that change to happen. What has changed in the last 20 years? All these things have changed, which have made a difference We'll short one by one. Some basic facts, what we all know. Neurological recovery is of two types. One is swelling comes down, changes will improve in for 3 to 6 months' time. This can also be modified now by new interventions. Second is functional recovery, primarily based on rehab, also can be modified by new interventions. Same way, neurological rehab is of two types, remediational rehab and compensational rehab. You can't walk, you give a stick, compensation, nothing new in that. But can you minimize the impairment after stroke or brain injury? That is what the current topic is. See example of a person with stroke, an infarct, we have a penumbra, we thrombolize to reduce the clot burden, we remove the clot, we all know that stuff, first 8 to 10 hours possible. But in India, 3% of patients in hospital after stroke for these procedures, primarily rehab. Also, there are some medications which start very, very early, can improve function after stroke or brain injury. But what happens in the first few weeks and first few months after TBI or stroke is brain recruit additional areas to perform new function, or other part of brain takes over function. This ability of brain to change in response to a stimulus is called neuroplasticity. What are doing in rehab is primarily treating that plasticity. It happens in two ways. You can do intensive training, something told about task-specific training. That will called experience-dependent plasticity, or second, newer treatment like drugs, neuromodulation or robotics, which can cause further change. New concept second is continuum of care concept. We have ICUs, we have intensive care units, we have stroke units, we have inpatient rehab. Very few settings have a full content setup. We should be able to provide in our own hospital full concept. Patient who is neurologically unstable is in the intensive care unit, neurologically stable, has tubes, go to HDU, tubes are removed, go to inpatient rehab. He can take some steps now, daycare, he can take care of himself, might remember home care program. You should be able to provide all this in the hospital to provide a better quality for your patients in long term. Second, third is team model. My model of care doesn't work in rehab. Should first we have full team possible. The nurses, physical therapists, occupational therapists, speech pathologists, psychologists, social workers, orthotists, nutritionists, neurologists, neurosurgeons with us are a part of a team which works towards the patient. On these two models of care, at least either a pyramid or a matrix model are important in our settings. Then what is the prescription? What we should know as a rehab physician providing patients with stroke and brain injury care, first 5 things. We should be able to provide continuity of medical care to these patients. They have diabetes, they have hypertension, hyponatremia, infections, tubes. Second, we should be able to prevent and treat medical complications, contractures, pressure ulcers, aspiration pneumonia, spasticity, sleep, pain, so on. Third, provide them training for sensory-motor deficits. Fourth, training for cognitive, communicative, and social deficits. And fifth, provide psychological, social care. If you're able to train ourselves in all these 5 things, then you can run a successful rehab program to help your patients. If you can do that, you can make all these things with help of a therapy team to help your patients. Next we say is intensive therapy concept. We call it 6-6-6 in a hospital. Our patients get therapy 6 times a day, 6 times a week for at least 6 weeks. The golden period for rehab in first few months use the opportunity to provide an intensive therapy to these patients. Then you want to start some drugs. We go to ICU, wow, I got a reference. Before starting a medication, always look for these things. These are detrimental drugs. They destroy brain function. Remove them or shift to better alternatives. Also, amantadine is being approved in an NEJM article to improve function after TBI. Start the person with DOCs as soon as possible if patient doesn't have seizures. And then what's coming in a big way is HBOT, which can reduce brain edema, improve cerebral pressure, perfusion pressure, inhibit apoptosis. One of our studies we have shown in patients with severe brain injuries and severe stroke and decompression surgeries, 2/3 of patients were at GOS level 3 or more than 3 at discharge. We also know we have more sicker people coming into rehab, more older people with simultaneous CKD, CLD, advanced interventions. So So these patients will have a lot of medical complications. And mortality acceptable is less than 3% in inpatient rehab, transfer back to ICU less than 5%. You should be able to provide these goals for your patients. And pick up all these complications. It's a big list. You're able to identify them, help to treat them, so the patient can go for rehab. If it's these complications, he can't go for therapy, you're missing the time, the opportunity. Then technology is helping us. We used to do ultrasound, we used to do toxin injections earlier, anatomy. Now use USG, you would E-stim or EMG, what you are trained for, it helps your patient. And don't forget the bladder. We have shown 80% of patients with stroke at discharge and neurogenic bladder. So at least do a PVR before they are sent home. We forget cognition, focus only on mobility. People have supernumerary phantom limb, people have depression after stroke and brain injuries. Simple tests available. MMSE is not enough for stroke and TBI. At least use a MOCA scale or a ACE test, two are commonly used. They also cognitive rehab concepts coming now. You should have a trained psychologist in your team, which you can start cognitive retraining. Medication also helps, especially donepezil and rivastigmine in people with memory deficits. Depression, analysis says that paroxetine is now most safest for patients with stroke, and duloxetine has rapid option action. So start these medications early. People have death, depression, better participation in rehab, better outcome. Aphasia, speech therapy is not enough. Other things are also possible. But one thing to come from Cochrane review, that caregiver, trained caregiver provided speech language therapy is equally good in long term. Train the caregiver, meet them 7-15 days, give next level of training, they can impart into the patient, it works equally in long term. Also, music therapy is now coming in big way, along with MIT in patient with aphasia. And medications, yes, donepezil works very well in sensory and Wernicke's aphasia, and memantine works very well in motor aphasia. You can start these drugs 5 mg OD and go to 20 mg if possible. Dysphagia, there's a GUS test, we know all that, to screen these patients. We have our own format now to be able to screen their oral function, pharyngeal phase, esophageal phase, and then start solotherapy techniques. We train solotherapists for that. But proper decannulation protocols are very, very important. Don't be afraid of tracheostomy. You can easily manage them. Do a simple dye test, give colored liquid, check it's coming in suction or not. If it's not coming, deflate the cuff. Put a simple valve called a specimen or speaking valve. People can speak with tracheostomy, people can eat with tracheostomy, both are possible. If you can do that, gradually increase the time, and all our x-rays have fluoroscopy units. Do simple tests called as swallow study. You can see where food is going. If it goes straight in the esophagus, comes in front, it's aspiration. And then people with posterior circulation stroke, something called a vital stem, that is a good device to improve swallow function in these patients. Technology helping us in not only in motor, also in speech and swallow systems also. There's a fixed protocol available now for decannulation in most of your patients. Follow the simple protocol, and you can get all your patients successfully. Even GCS 8, you can decannulate, follow this protocol. Sensory motor function, when to mobilize. So early verticality is very important. Second day, you can mobilize any stroke patient out of bed, no problems. You can see nice guidelines not to mobilize it out and only. Spoke about the different approaches, we all know that. Are there any drugs for pharmacotherapy to improve motor recovery? There are 4 big trials. A FLAME trial, fluoxetine has failed in long-term study in acute stroke. DAS trial, dopamine in chronic stroke has also failed. TALOS trial has showed citalopram. It is now being approved by European Academy of Neurology to start 20 mg of citalopram in all stroke patients with severe involvement to improve motor recovery. They are approved now. This is also approved. CAST trial has approved cebulicin, mainly for hand function. These 2 drugs are now approved by European Academy of Neurology to help motor recovery for your stroke patients. Now, beyond that, multiple technologies have come in the last 20 years which can help. Most commonly are lower limb robotic systems. Different types of robotic systems are available now. Most commonly used is Locomat, which is a bodyweight support system on treadmill. You can start this training, and what does the Cochrane review says that every 4th dependency in stroke can be useful, avoided if you have these patients on Locomat training. This is only useful for non-ambulatory stroke patients. Don't use Locomat for ambulatory stroke patients. Only for non-ambulatory patients. Same the opposite robotic systems, multiple have come, anti-filter, after only for wrist, only for hand, only for shoulder. All technologies are available now. We have 3 systems called as Armio concept. We have Armio Power, Spring, and Nemedio for shoulder, elbow, and hand function. Cochrane review says that it helps these patients with stroke, improving the ADL and hand function. Those who can walk want to walk better, analyze their gait in gait analysis laboratory, train them in a balance system to walk even better. We have published long back. It helps in stroke and TBI patients. FES, useful for distal, mainly for ankle movements. EMG biofeedback, useful for wrist and ankle movements. Virtual reality is the in thing now. Cochrane review says that it mainly improves hand function and the walking speed at present. Circuit training, underutilized thing, like a gym concept, train them for endurance training, strength training, works very well in the inpatient setting and the outpatient setting, helps you improve the function. CIMT, we spoke about that. Mental practice, you all rehearse our talks, rehearse your task before going for any therapy session. Mirror therapy, very useful for motor function and neglect. Adjunct to rehab. Also remember, we are physicians. It is proven long back that physician supervised programs have better outcomes than non-physician supervised programs. Just a couple of minutes. So my last slide to show, we all know this. We can reperfuse the brain in first few hours. Our neurology guys do that. Our job starts here in first few days. Swelling will come down by first 2 to 3 weeks time. Brain try to change itself by 3 months. That's why we say there's no recovery 3 months. That's actually wrong. If you start training intensely in first few weeks, first 4 to 6 weeks, get something new. That's called as new organization, new neuroplasticity. Don't die down very soon. So always remember, rehab is not disability management. We forget the impairment caused for the learn non-use. Rehab is impairment-based approach. Treat cognition, speech, language, swallow, bladder, bowel, sphincter, mobility, spasticity, pain, sleep, all the comprehensive way, better outcome in long term. Same was for first 4 patients. A bad TBI, walking at 6 months. Chronic TBI came to us 2 years, walking at 4 years now. Big ICI stenosis, global ICI MCI infarct, walking at discharge without tubes. Big hemorrhage in the brain, independent. People can change if they get better care in neuro rehab. This is our team. Thank you very much. It's the opportunity to invite you to all of you for the next IMS&R that's happening in South India only, in Chipmar, Pondicherry. Mark your dates, 12 to 14th April. You all are welcome in IMS&R conference also. Thank you very much.
Thank you, Dr. Abhishek. The floor is open for questions. Mike?
So we have using for last 12 years. We've done more than 3,000 patients. We have no seizure till now. Why? You don't give this for these patients who have seizure in last 1 week. Second, it is postulated by having hypoglycemia. So check their sugar levels at least 110 before they go into the machine. Normally 20 to 30, it'll come down. So check their sugars before that. If they have seizure in last 7 days, don't use it. If you have to use it, give them a tablet clobazam before using it.
Thank you, Dr. Abhishek.
Thank you, sir.
Our next speaker will be Dr. Sri Kumar, Additional Professor, AIMS, New Delhi. He will be talking on neuromodulation in neuro rehab.
Respected chairpersons and dear delegates, we will be talking on a brief overview of neuromodulation and rehabilitation, specifically neurorehabilitation, and also in pain management. And the details of which will be delivered in subsequent lectures, like there is a separate lecture for stroke, and then for spinal cord injury, I believe was already finished in the previous session. And I owe my acknowledgement to the Pain Research Lab, Department of Physiology, and the professors there inspired me to look into this new intervention, how it can be used in terms of PMR. So the definition of neuromodulation is that alteration of nerve activity through a targeted delivery of a stimulus. The term, the targeted delivery using a stimulus is the most important, because neuromodulation can also be done by drugs also. But here we're talking about targeted delivery, so there has to be targeted stimulation, or in fact targeted chemical agents, which means under this broad definition, in fact intrathecal baclofen for the use of spasticity also falls broadly under the category of neuromodulation. So when we come to brain neuromodulation, we have basically, I'll be talking about the non-invasive. I will not be touching upon the invasive modalities. So the non-invasive brain stimulation broadly is classified into three. That is the magnetic stimulation, and then the ultrasound and electrical stimulation, of which with the magnetic stimulation, the most commonly that is used or studied in research purposes is the repetitive transcranial magnetic stimulation and the theta burst stimulation. And transcranial ultrasound is very little research is available. It's still not that much used. And so we'll be a little touching upon the transcranial direct current stimulation. So what is transcranial magnetic stimulation? All it has is the coil, which is placed tangentially or at an angle to the skull, and an electric current is passed through this coil. And there is an electromagnetic field which is formed perpendicular to this coil. This electromagnetic field is able to pass without any problem, without any resistance, through the skull and the scalp into the cortical tissue, that is the brain. And by the Faraday law, current is developed inside the cortical tissue, which is parallel to the coil but in the reverse direction. So this is what the transcranial magnetic stimulation does. And depending upon how you pass the current, it can be passed in pulsed frequencies. So depending upon in which frequency you pass the current, correspondingly there is a activity or the different outcomes are seen. See, these pulses can be given at their low frequency known as at 1 Hertz, which means there is just 1 pulse every second, or at 5 Hertz, that is 5 pulses every 1 second. Then it is known as, and depending upon that, it will either be causing an inhibitory effect or a excitatory effect. Again, the theta burst stimulation is a patterned form of transcranial magnetic stimulation, in which the current research is all, and also clinical application is focusing on theta burst stimulation. The reason being, in transcranial magnetic stimulation, the duration of intervention is quite long, for 20 to 30 minutes, and this duration is drastically reduced in theta burst stimulation. The theta burst stimulation is a pattern stimulation in which 50 Hertz impulses are passed over a 2-second period. Then there is a 8-second gap, that is over a 10-second, and this is repeated. That is intermittent theta burst stimulation, and this can also be continuous theta burst stimulation. The continuous theta burst stimulation has an inhibitory effect, whereas the intermittent theta burst stimulation has an excitatory effect. So how you see that the stimulation is occurring is by putting electrodes on the contralateral abductor pollicis brevis. So it is just like an EMG. The electrode will pick up the stimulus, and thereby you will know. And from that, the resting threshold is calculated, and using the resting threshold, the stimulus is provided as a percentage of that resting threshold. So there are different types of coils that are used for transcranial magnetic stimulation. The one, the picture before was a circular one, but in the circular one, the stimulation is totally broad. So the most commonly, the figure of 8 coil, also called the butterfly coil, is mostly used. This is because in this coil, the stimulation is focused in a particular area, and thereby you can get the stimulus at a particular area without the effect radiating into other parts of the cortex, thereby decreasing the side effects. And depending upon the diameter of the coil, the depth in which the penetration occurs also varies. And the most commonly used is around 70 millimeter coil diameter coil is used. So where is this placed to cause this focal stimulation? This is usually placed either in the motor cortex, that is the external landmark for the motor cortex or the M1, and this is identified as 5 centimeter lateral from the vertex and 2 centimeter anteriorly on the contralateral side of the brain, or on the part of the brain it needs to be stimulated. In some conditions, the dorsolateral prefrontal cortex is also stimulated, and the anatomical landmark for that is superficially is from the vertex, it's 5 centimeter laterally and 5 centimeter anteriorly we get the point. And after you get to that point, you give the stimulus and see if it is appropriate, stimulus is seen. But better devices are also coming up, what is known as the neuronavigation system, in which the picture or the functional MRI of the patient or the MRI of the patient is superimposed on the image that is picked up by the camera, And also this camera picks up the image of the head and also that of the coil, and it superimposes on the functional MRI, and it helps to navigate the system. That is like stereotaxic effect. So the other form of non-invasive brain stimulation that I was talking about is the transcranial direct current stimulation, in which 2 electrodes are placed, around 5 centimeter sized electrodes, which are soaked in saline and are placed on the, one electrode is placed over the cortical region or the anatomical area of the scalp, which needs to be stimulated, like the motor cortex in reference, just as I said before, over the M1 region or wherever you want it. And the other is placed on the contralateral side on the supraorbital region. And either of them can be changed into the anode or the cathode, like the anode usually is excitatory and the cathode is inhibitory. And therefore you can change whether you want to stimulate that aspect of the brain or inhibit that aspect of the brain. You can change the direction of the current and thereby give the stimulus. Again, low duration intensity is given, that is around 1 to 2 milliamperes current is passed, again for 25 to 30 minutes. The advantage of this setup is, as the stimulus is given, the patient can do some activity or a therapy, for example, hand therapy. So there is a synergistic effect of the physiotherapy, that is the movement therapy that the patient performs, as well as the direct current stimulation. In fact, this is the modality which is most commonly used in many of the PMR groups in the United States, whereas the TMS is mostly under research, since there is not much evidence has still been generated. Is there any difference between the two? Yes, there is a minor difference. One, here the weak electric field is formed, but it has a deeper effect, that is the current, direct current stimulation. When compared to the TMS, it has a strong electric field, but it only has a superficial effect. But what is happening inside the brain? The mechanism of action is through the long-term potentiation or the long-term depression. This depends upon the type of receptors that are stimulated, but not exactly the type of receptors. Even with the same receptor, you can see glutamate, NMDA, or for example, the dopamine D1 and the dopamine D1. Both are the same receptor that is stimulated, but the outcome is different. And this happens because there is a post-synaptic calcium influx, which can be either fast or slow, depending upon how you are stimulating the brain. That is, whether it is intermittent, continuous, or theta burst exactly. And depending upon whether it is a rapid influx it reaches, if there is a rapid influx of the post-synaptic calcium, it then goes in contact with the C terminal of the calmodulin complex, and thereby activating the kinase pathway, and thereby potentiating the increase in the AMPA receptors, and leads to long-term potentiation. And whereas the reverse is true for long-term depression. The mechanism same for TMS as well as direct current stimulation. Are there any adverse effects? The adverse effects are mostly minimal and also temporary. And in direct current stimulation, as expected, some itching is seen, irritation is seen, whereas in the TMS, it's mostly headache, neck pain, cognitive effects, etc. But no significant seizures have been affected. This was a study that was planned in a research lab. Unfortunately, I do not have the results of this study. Probably in the next conference, I will to share it. And in which we planned in chronic low back pain patients, the TMS intervention in the first 4 weeks, and we are looking at what it changes in the corticomotor excitability, thereby changing whether it is crossing any neuroplasticity effects in a patient with refractory chronic low back pain. I will briefly touch upon the spinal cord stimulation because this has been dealt in detail in the previous session by Dr. Sumalata. Basically, it has an electrode which causes stimulation. The stimulation parameters vary depending upon whether you want to use it for pain or you want to use it for locomotion. So what exactly for the pain? You are aware of the gate theory. It happens by the gate theory. And this was brought up by Dr. Abhishek also when the lecture was going on. The transcranial stimulation is now coming into more and more research, and in which the cathodes are placed at the C3, C6 level or at the T11, L1 level, and the anodes are placed at the anteriorly at the iliac crest level. And transcranial stimulation, how it works is that here the intensities are larger, and thereby when the dorsal root horn is stimulated, and through the interneurons, the motor neuron is also getting stimulated. And also these interneurons move up and down, and thereby it helps in spreading that electrical current all along the spinal cord. So this was one of the first few studies which found that when a stimulation of the spinal cord is occurring at the T11, L1 level, this kind of rhythmic contraction of the muscles through the EMG, this was just EMG pickup, not the movement exactly, in a spinal cord injury patient. And even though the stimulus was constant, why the rhythmic pattern is happening, that was what led to the discovery of what is known as CPG, or the pattern generators, or the locomotor pattern generators, or the central pattern generators. And this is the theory behind the use in spinal cord injury. So the parameters will vary for transcranial magnetic stimulation. Basically, there are two different types of frequencies, that is unmodulated and modulated. The modulated has a carrier frequency so that it brings about the same effect of stimulation, that outcome, but at a lesser amplitude, and thereby the patient will not be able to perceive the pain, or rather will be able to tolerate the pain. The adverse effect is that when you stimulate it along with locomotion or any stimulation of the muscles, it can also cause voiding, and if the patient is susceptible for ADs, then he may also have some symptoms of ADs. The clinical application, now coming to how we use the neuromodulation clinical application, it is used in stroke, which is seen in the subsequent topic. We have to be careful about the patient selection criteria, whom to include, whether they are able to participate in the rehab, whom to exclude, like for example, pregnant patients, those who have cardiac pacemakers, etc., will help you to identify the patients. Then in chronic pain, just as that, we also studied the different parameters and the location are used depending upon the condition for fibromyalgia, headache, low back pain, chronic pain, or trigeminal neuralgia. Depending upon the location and the intensity, again, I said the resting membrane, resting threshold, Motor threshold is used to calculate what stimulus needs to be applied. These are based upon the previous studies. None of this is the indication for clinical use presently. This is what the previous studies had used, which we can further study further to see whether they are actually useful. Again, in spinal cord injury, it has also been studied. This is one study we did. We used neuromodulation of the tibial nerve by using just a TENS machine, and we compared it with oxybutynin, in which we found comparable efficacy. To summarize, presently the TMS is indicated and approved for uses like tremors in Parkinson's disease, and in many psychiatric conditions like depression and also. And only the epidural spinal cord stimulator is presently approved for use in pain. A lot of research is being done experimentally for the improvement in motor function, sensory, memory function in cases like stroke or traumatic brain injury, and also in disorders of consciousness. Thank you.
Thank you, Dr. Srikumar.
Thank you, sir.
The floor is open for questions. Yes? Mike, please.
Sir, thank you, sir.
I would like to know for the pain conditions using TMS, for regional pain conditions.
Okay.
If you have been using for how long?
No, we are not using it. As I said, this is being used for only investigational purposes. We are not giving it as a treatment for the patients. We are only using it as a research. For example, in fibromyalgia, we have one project going on. In chronic low back pain, we have one project going on, which is almost finished. Soon we'll be able to publish it. And also one in spinal cord injury is going on, but I am not handling it. It is under Professor Geeta Handa. We are just studying the investigational use of this.
All right, the duration, I would like to know
the duration ranges, that is what I was saying. The
Sessions.
duration is up to, repetitive TMS when you use, it goes up to 20 to 30 minutes. If it is theta burst, it can limit it to 10 to 15 minutes.
Sorry, I would like to know the number of sessions.
Number of sessions, yeah, we usually give it multiple sessions over a week, like up to at least 4 weeks period, up to 6 sessions.
How many sessions per week?
Yeah, up to 6 sessions per week.
Thank you.
Yeah. That is for study purposes again.
Coming to Dr. Nurul's question, I think TMS right now has been established in a lot of psychiatric conditions. So if you look at the pain conditions which are being advocated, most of them have a psychological component of depression and like fibromyalgia, and most of these conditions have a psychological component. And probably that is one of the mechanisms through which TMS works in fibromyalgia and myofascial pain.
So how we go negate it is by doing a proper study design.
Yeah.
So we have the study design, we randomize control, and we also manage the patient similarly, and we yet see it is only a proper study design that can answer this question, whether it is having only the study.
Exactly.
Thank you, sir.
Thank you. Thank you, Dr. Srikumar.
Thank you, sir.
Our next speaker will be Dr. Mohit, Associate Professor, All India Institute of Medical Sciences, Kalyani. He will be talking on the role of RTMS in cerebrovascular accident rehabilitation.
Thank you very much. My topic is role of RTMS in stroke rehabilitation. This is my institute where I am working. As we all know, stroke is ranked the second most leading cause of mortality worldwide, and it causes severe morbidity in its survival. So, the number of patients with severe upper limb hemiparesis has been declining with the introduction of rehabilitation, but even with the rehabilitation, less than 50% of the patients are able to use their hand properly. So RTMS is a upcoming treatment method which is applied to bring out the potential of brain reorganizations by directly stimulating the cerebral cortex. RTMS has been widely adopted as a treatment strategy in mainly psychiatric conditions like depressions, OCD, and some neurological conditions like stroke, Parkinson's. Low frequency RTMS leads to lasting reduction in cortical excitability in the motor cortex. Strategy being, we applied in the unilateral stroke patients targeting the primary motor cortex contralateral to the affected cortex spinal tract based upon the interhemispheric inhibitions. I am not going to details as my previous always speaker. So basic principle is the Faraday law of electromagnetic induction. When we applied this figure of 8 coil, during the electric conduction, the electromagnetic waves are generated just perpendicular to it, traverse the scalp, cerebral cortex, and a eddy current is generated just perpendicular to it, which ultimately leads to stimulation of the interneurons and corticospinal tracts, which ultimately leads to brain plasticity. If he uses the high frequency RTMS, it causes long-term potentiation, and on the other hand, if he uses low frequency, it causes long-term depression. And this is mediated by the GABA. So, activation of glutamate system enhances the brain plasticity, and activation of GABA decreases the brain plasticity. Now, what are the effects we expected? Conventional low frequency RTMS can lead to modest to short-term benefit on motor functions of the paralytic hand, and complex motor skills such as those performed by the hand and wrist improve significantly with the low frequency RTMS. And in case of lower limb, there is studies found that reduction in the spasticities. As per studies, it is shown that RTMS increases the brain plasticity, and that to be optimal if combined with the intensive rehabilitation. So the combination of RTMS and intensive rehabilitation enhances the beneficial effect of each intervention procedure. Now, details of the procedure, we are using the figure of 8 coil, stimulation site being the primary motor hand area. We are using the low intensity RTMS. In the unaffected side, we given the each session for 20 minutes for 2 weeks. So before starting the RTMS, we first initially have to check what is the MEP for the patient. So with the use of this figure of 8 coil, we are generating the what is the MEP for the patients. So we have placed this figure of 8 coil in the cerebral cortex. Impulses are generated. We are observing for the any contraction in the first dorsal interossei, but we are not observing. We have initially given for 10 pulses. We are not seeing any contraction in the first dorsal interossei. As no contraction are seen, we gradually increases the intensity by 5%. Now, after a certain time, we are observing the contraction in the first dorsal interossei. So we have, by titrating, we have set the what is the MEP for the patients. So after deciding the MEP, we now place the value in the machine. We first set to repetitive mode. We first set the frequency to low frequency. We set it to 1 Hz. The MEP is already set 57%. We set to 1 Hz. Then we set the gain of frequency. we set to 60. Now our machine is ready to run. After setting all the value, we start the therapy. Impulse is generated and transmitted to the cerebral cortex. Patient is getting the stimulation in comfortable position. The session is run for 20 minutes. We are giving 5 days in a week for consecutive 2 weeks. We start from Monday to Friday, Saturday, Sunday break, then again Monday to Friday. So total 2 weeks therapy was given. Apart from RTMS, we continue the physical therapy for the patient, both active and passively by the physiotherapist. We also treat the caregiver. We continue the occupational therapy for the patients. We assess the patient with Figelman assessment score for both upper limb on time of admission and after 2 weeks of therapy. We observe there much reductions in the spasticity and increase in the range of motions of shoulders and elbow. But we have not observed much improvement in the lower extremities. So, this is the gait pattern of the patient before starting the therapy. We are seeing the much spasticity in the upper limbs and the lower limbs. She barely able to manage her gait. After 2 weeks of therapy, the spasticity in the upper limbs much reduced. He was able to manage his gait. And this is the gain of the pattern just here 2 days back. We observed that the same is persistent even after the therapy. As per literature support, apart from the major seizure side effect, some patient experiences headache and fatigue, but no serious convulsive seizures are reported. It is found that low frequency RTMS is superior than high frequency, and the main thing is that the effect is mainly depends upon the site of stimulation, the method, lesions, and interventions time. If you come with the RTMS with a lower limb, the basic two difference. First is the difference in the localization between the lower and the upper limb region, as known as pain-filled homunculus and the nerve fiber that does not cause the obstruction. As in the picture, it is obvious that the repression of the lower limb, it is much deeper in the cerebral cortex, so we require a special type of coil for the approaching the lower limbs. Now, RTMS in aphasia, as per literature, the therapeutic window for rehabilitation intervention is much wide. So we can approach the patient with even 1 year, 2 year post-stroke. So chronic aphasia, for several even after stroke, there is a possibility that language function will be recovered by conducting appropriate rehabilitation. So the recommendation therapy is again low frequency RTMS reduces the interhemispheric innervations of the left hemisphere by inhibiting the effect on unusually high activation levels of the right frontal lobe. So, as per study, Nisa et al. Applied the low frequency RTMS for 10 days in the inferior frontal gyrus of the right frontal lobe. As a result, it was found that the patients are able to recall the name of more objects than before the treatment. So, this is the patient with history of repeated stroke, reported to our OPD. Her main concern is the speech. So, given the RTMS, we observe much improvement in the speech, and as she is Anganwadi worker, she can able to take the classes with better speech. To conclude, neurorehabilitation through RTMS is a treatment modality by evidence-based guideline regarding the use of post-stroke motor impairment, hand and wrist motor recovery, and chronic non-fluent aphasia. RTMS has shown benefit in stroke rehabilitation, but with limited evidence and a high degree of protocol heterogeneity. So more core studies are required to assess the effect of RTMS. These are my references. Thank you.
Thank you, Dr. Mohit. The floor is open to questions. Mike, please.
Thank you, sir. Sir, can you please speak the mic, sir?
Patient, hemiplegic,
Yes, sir.
variety.
According to literature, there is evidence that it can reduce the spasticity even with the cerebral palsy patient. But question is that patient should able to sit in the instrument, able to bear the stimulation. Because it has a special sound. So some studies show that if the CP child, the child is too small, not mentally adequate, then create problems. And main thing that we have to further titrate the dose, the MEP. Otherwise, there is chance of convulsion. So that patient has to cooperative. So that is the main problem with the CP child.
Okay, thank you.
Sir.
Are you using it part of a study protocol or purely for treatment?
Sir, we are giving the treatment and also it is a part of studies, sir.
What is the current level of evidence for motor and aphasia post-stroke?
Sir?
What is the current level of evidence of RTMS for motor recovery and for speech language
Sir,
recovery?
I'm not sure, but some studies have found that in the aphasia there is much improvement. So this patient that was shown is reported to us, and she has a history of 2 or 3 times the strokes. So when she came to us, her main complaint is the speech problem. So we tried this, and there's a much improvement in the speech. So as she is an Anganwadi worker, she has to talk with the child. So she was.
It's not approved for treatment. Please use the investigative protocol only, right? That's what I'm trying to say.
Dr. Mohit, have you encountered any complications? And
No,
are
we
you
have not.
following any prophylaxis for seizure?
We have used a midazolam spray as a prophylaxis, but we have not encountered any complications.
Thank you.
Thank you, Dr. Mohit. Actually, just a quick addition. We have been using RTMS in Royal Care for past 3 months, and we have been not as a research, but for patients. We have completed nearly 300 patient sessions. So from the whatever we have done, I understand that it is a really promising stroke in stroke, and we have had good results in even chronic stroke for spasticity reduction. And even I have tried for patients with S1 stimulation also, which has increased here, increased the sensation of the patients also. Third is regarding aphasia also, I have had 2 or 3 patients with better speaking ability after RTMS. And then pain management, my experience is that the post-stroke pain, that is the patient doesn't even allow you to touch the hand, it is significantly reduces with RTMS. So what I say is, I feel is, though we say that there is no much evidence it's coming up, surely we will be able to bring up more evidence, and we are working on the multicentric trials now. So it is a very good addition. That's what I'm saying. And we are doing it for traumatic brain patients also.
Thank you very much. Even the patient that I have shown here, there's a much improvement in the cognitive function also. We are checking with the software.
So one comment about Nurul asked about CRPS, right? So it is moderate evidence for using it in CRPS on contralateral cortex, and the mechanism is it causes NMDA receptor. It acts as an NMDA receptor antagonist, and it causes central desensitization. This is how it works in CRPS in pain. That's what I wanted to add. Thanks.
Thank you. We thank all the speakers for having taken us to a journey on neurorehabilitation, right from the basics of neurophysiological approaches to the new promises in neuromodulation. I request all the speakers to please come to the stage. Dr. Sandeep, Dr. Abhishek, Dr. Sri Kumar.
So thank you, sir. Now I request Senior Physiatrist Ramachandran sir to honor the chairpersons, Dr. Edmund Digato and Dr. T.J. Ranganathan sir. So thank you, Dr. Ramachandran sir. Thank you, Dr. Edmund sir. Thank you, Dr. T.J. Ranganathan sir. So it's time to break for lunch and reassemble in the same place at sharply at 2 o'clock, 2 p.m. Thank you.
Hello, hi. Hey, hi, can you hear me? Good evening. Yeah. Yes, yes, I can hear you. I can hear you. Hello. Or is it on the other side? Maybe the mic is on the other side. Hello, hi. Okay, sure, sure. So the Q&A is after the video, right? Okay, thank you. I can see the. No, actually I sent over my slides already. Yeah, yeah. Oh no, I think can you guys play the video that there's audio with the PowerPoint slides that I previously sent over. Do you have that PowerPoint slide? Hi. Because I don't have the slides over. I don't have the slides here with me right now, so I can send that email again to someone. Let's see. The slides unless I send the slide. Oh. Let me try. Hmm. Yeah. Hmm? Oh, okay. Okay. So, okay. Sure. Sure. Send it. Right. Right. That's on my laptop, right? My laptop. Yeah, very hard. Very hard. I don't think we can get the description to send. It's a very big file. you have to. I think I'm not on mute.
I've been interested in ultrasound of musculoskeletal system for 4 years now, and I'm an active member of USPRM of Turkey. I also
Good afternoon, everyone. We are starting the scientific session 13 for the day. Welcome chairpersons Dr. Abhishek Srivatsava and Dr. Anand Verma to chair the session.
Hello dear colleagues, thanks for having me here. My name is Burak İnce. I'm a medical doctor and specialist of physical and rehabilitation medicine. I work at İzmir City Hospital in İzmir, the third largest city of Turkey. I also conduct my clinical research as an associate professor at the University of Health Science of Turkey. I've been interested in ultrasound of musculoskeletal system for 4 years now, and I'm an active member of USPRM, Euromusculus, World Musculus, and Türk Musculus groups. Today,
Can you close the voice,
I would
please?
like to talk about some examples of detailed sonoanatomical ultrasound applications and their clinical relevance. Advances in
Can you close the
ultrasound
sound,
technology
please?
have allowed us to see some details that are not
This is a live Zoom session. Presenter is Dr. Lee Iding, consultant rehab medicine. Dr. Bugra.
Can we start? Can we
Yes,
start?
yes, sir.
Good afternoon, everybody. Welcome to the post-lunch session. We have 3 speakers in this session. The first speaker is Dr. Lee Yaiding, consultant in rehab medicine from Changi General Hospital, Singapore. He'll speak on TMS, principles, and future directions. It's a Zoom talk. Dr. Lee, please.
yet at İzmir City Hospital in İzmir, the third largest city of Turkey. I also conduct my clinical research as an associate professor at the University of Health Science of Turkey.
Please let Dr. Lee's talk first.
I've been interested in ultrasound of musculoskeletal system for 4 years now, and I'm an active member of USPRM.
Is Dr. Bugra, PMR Associate Professor from İzmir City Hospital, Turkey. The title of the presentation is Change Your Perspective, Acrobatics with Sonoanatomy. We are now connecting the speaker on live Zoom session, followed by question session. Thank you.
Euromusculus, World Musculus, and Türk Musculus groups. Today, I would like to talk about some examples of detailed sonoanatomical ultrasound applications and their clinical relevance. Advances in ultrasound technology have allowed us to see some details that are not demonstrated in classical anatomy or clinical textbooks. So, This opens the way for new approaches that broaden our horizons in the diagnosis and treatment of some disease. I would like to start with an example of the detailed sonoanatomy of the rotator cuff. This is an image we know from the textbooks of musculoskeletal ultrasound. This is the humerus, this is the cartilage, this is the greater tuberosity, and this bird beak-like structure is almost always referred as the supraspinatus tendon. However, it's much more complicated. The modern anatomical studies have shown that the rotator cuff consists mainly of two layers. The superficial layer consists of the tendinous part, which originates from the supraspinatus and infraspinatus muscles. The capsuloligamentus portion is located deep the tendinous portion and directly over the humeral head. And as the name implies, it consists of fibers that originate from the coracohumeral ligament, the superior glenohumeral ligament, and capsule itself. The structure is called superior complex due to its superior position. And this is an image. The layers are separated from each other. This is the tendinous portion, and this is the deep portion, the superior complex. And some areas of the superior complex form a rounded, fibrillar, and cable-like form. This structure is rotator cable. The rotator cable has three limbs, which presents an anterior insertion on the lesser tubercle and intermediate insertion on the anterior superior edge of the greater tuberosity, and a posterior insertion to the inferior edge of the infraspinatus tendon. As long as the cable and its insertions are intact, the rotator cuff fibers can maintain shoulder strength and full range of motion, even in the presence of a full thickness tears of the other parts of the rotator cuff, like a full thickness tear in the rotator crescent. It's not a big problem. Moreover, the intermediate limb of the rotator cable, which localized just lateral to the bicipital groove and below to the supraspinatus tendon, is the most important portion of the rotator cable. So let's check the structures now. We're looking to the rotator interval. So this is the biceps tendon, this is subscapularis, and this is the supraspinatus tendon. As you can see, the most anterior portion of the supraspinatus tendon is well organized and round shape. And the other structures that can be visible on the image is the superior glenohumeral ligament, which lies under and lateral to the biceps tendon and causes the tendon, makes an angle with bone. Superiorly, the coracohumeral ligament, and coracohumeral ligament and superior glenohumeral ligament binds and forms the reflection pulley. And this structure is responsible for the stability of the biceps tendon in the rotator interval. And also you can see that some fibers of the coracohumeral ligament migrates under the superior bundle of the supraspinatus, anterior bundle of the supraspinatus, and they form the superior complex. And the most anterior portion of the superior complex, sorry for the light, the anterior portion of the superior complex is also a rounded structure.
Hello.
This is the intermediate limb of the rotator cable. So these two structures, the cable and supraspinatus, are still distinguishable in the long axis. Let's see the long axis now. Cable, supraspinatus, elongating them. And the greater tuberosity comes in the rear, cable, supraspinatus. And yes, much more clear now. Sorry for that, yes. This is the cable and this is the supraspinatus. So this bird beak-like structure is not totally supraspinatus tendon. Only the superior portion is supraspinatus tendon. The deep portion is rotator cable, and rotator cable is much more important in terms of the stability of the joint and outcomes of the ruptures. So, examining these details in the rotator cuff may provide important interactions in the clinical applications. Another example of a detailed sono-anatomical examination is the fascial layers and associated structures. Using high-resolution ultrasound, we are able to examine the structures of the fascia in detail. This image shows all the structures: the epidermis, dermis, superficial fascia, the superficial and deep adipose tissues, the deep fascia, which has multi-layered structure, and muscle. The fact that these layers have become distinguishable has provided some insights into the treatment of a very common disease. This disease is myofascial pain syndrome. Historically, blind intermuscular needling of the trigger point has been the most commonly used method for treating myofascial trigger points. However, as the name of the disease suggests, other structures like epimysium, the deep fascia and the superficial fascia all are known to be involved in the pathogenesis of the disease in addition to the muscle. So, our current research question is therefore whether it is better to address all these fascial structures in addition to the muscle tissue when injecting trigger points, rather than just treating the muscle. In this particular example, we're looking at the myofascial layers of the upper back. This is the trapezius, this is the levator scapula muscle, and this is the rib. And this is the fascia between the trapezius and levator scapula. So what we do in our study is like this. Assume there is a trigger point in the trapezius muscle, in the deep portion of the trapezius muscle. We apply one of two types injection. One is the classical method. We insert the needle into the trigger point, which is located in the muscle tissue. And the other injection method, on the other hand, covers all myofascial layers. We first put our needle into the intermuscle fascia and infiltrate it, hydrodissect it, and then or is it an extensor? The answer is both. The medial portion of the tendon, the ischiocondylar part of the muscle, is mainly an extensor of the hip and contributes to the stability of the hip joint in standing position. This part is also known as the hamstring portion of the muscle. The adductor part, on the other hand, lies more laterally and adjacent to the femur. It's obvious that we are targeting the adduction function of the muscle when we're treating a hip scissor. So let's take a look at what these compartments look like on sonography. We're just proximal to the adductor hiatus. The adductor magnus is a thin muscle in this level, lies just above the femoral artery. This is the gracilis, this is the semitendinosus, and this deep one is the vastus medialis. So moving cranially, the semimembranosus wanes quickly and replaced by the adductor magnus. So this extremely superficial part of the adductor magnus seems very easy to inject, but it's not our target area. This is the hamstring portion of the muscle. This portion goes vertically and binds to the ischium. And how can we localize the adductor part of the muscle? The semimembranosus muscle in the proximal thigh will help us in this issue. This muscle has a unique comma shape in the proximal and emerges medial side of the semitendinosus muscle. And the end tip of this muscle, there is a fascia lying deeply and separate the adductor muscles into two pieces, the hamstring portion and the adductor portion. The adductor portion is our target area, and you see how deep it is and adjacent to the femur. So the adductor part injection should be quite deep, and the use of a long spinal needle will be necessary. So this is the end of my presentation. Detailed sonoanatomical examinations seem to change our clinical perspective and open up new horizons in many areas. I hope you enjoyed the presentation. Thank you very much for listening to me. I wish you a productive conference. Thank you.
Thank you, Dr. Buga, for a kind presentation.
Hello, dear colleagues. Thanks for.
Any questions from the audience? Okay. So next talk is by Dr. Lee Yideng on RTMS, Principles and Future Directions. He's from Rehab Medicine team at Changi General Hospital, Singapore. Dr. Lee, please. Also a Zoom talk. Is he available? We're trying to connect. Just wait for a few minutes. Can you start the next talk in the meantime? Yeah. Third speaker is Dr. Sopan Kumar Mishra, Professor Nachuri, Calcutta Medical College. Topic is the in thing, AI in rehabilitation. Dr. Mishra, please.
Come here. Just come. Next.
You want to take a question for this last talk?
Hello? Yes. Now I can hear you. Okay. Oh, okay. So you see the presentation already, I understand, right?
Yeah, Dr. Buga, we have seen a
Oh, okay,
presentation.
okay.
Yeah.
Okay.
It's open to the floor for questions. Any questions, Dr. Buga, please? One question by Dr. Navita, please. Yeah. Give us a microphone, please.
Hello. Yeah, Dr. Gurga, I'm Dr. Navita, and thank you so much for an excellent talk. My question to you is, what is the significance of rotator cable? You have you have showed us the rotator cable. So what?
I'm sorry, I couldn't hear you.
What is the significance
some
of a
sounds
rotator
in the
cable?
background?
Can you hear me now?
Yes, but it's not clear. I hear some other voices and disturbing your sound.
What is the significance of rotator cable? Rotator cable.
Significance of the rotator cable, yes. The rotator cable has an three insertion on the humerus, and as long as these parts are intact, the rotator cuff can maintain the shoulder strength and full range of motion. The other parts of the cuff is not so important. As you know, the other parts is called the rotator crescent, and in the presence of a full thickness tear of, even a full thickness tear of rotator crescent, it's not so important. If the rotator cable and its insertions are intact, especially the intermediate insertion, just lateral to the bicipital groove, just under the anterior bundle of the supraspinatus, is it enough? And it changes the outcomes of the ruptures. So if a rotator cable is intact, the outcome is very good. So evaluating these details on the ultrasonography changes our perspective. If the rotator cable is intact, maybe you can choose conservatively treatment. The surgical treatment maybe not be necessary. For example, just in case.
Yeah, thank you so much. So the surgery can be avoided. The outcomes will not be better if there is a rotator cable tear. Yes, thank you.
Thank you. We have one more question, Dr. Buga. Which part of the adductor magnus is injured more, the adductor part or the extensor part in the common sporting injuries?
Could you repeat? Yeah. The sound is not clear again.
So you spoke about the two parts of the adductor magnus muscle, the adductor part and the extensor component. So in common,
extensor adductor part. Yeah.
So in the common sporting injuries, which part is most commonly injured?
Which part? Yes. In sports injuries, the hamstring part also is commonly injured. Yes, my example is was for the botulinum toxin injections for hip scissors, especially for spastic patients, But of course, in the sportive injuries, the hamstring part is much more involved, and you can also think for the interventions of the hamstring part, and it's obvious it's quite easier than the adductor part because it's so superficial.
Okay, thank you. Any more questions, Dr. Buga? No, it's okay. Thank you very much for being online. Thank you. We move to the next talk, please. Next talk is by Dr. Swapan Kumar Mishra. Dr. Mishra, please come back on stage.
Yeah, Dr. Lee Eding is online now. Thank you, Dr. Bugra. Thank you for joining.
Thank you. I wish you a productive conference. Thank you very much.
I think Dr. Lee is online now. We go to the first talk again by Dr. Lee on RTMS. It's an online talk. Yeah.
Yes, Dr. Lee, you can unmute yourself.
So hi, my talk is a pre-recorded talk. Sorry, I don't have the slides with me right now. Do you guys have the file that I sent? Yeah. Okay, thank you.
Hello, and thank you for attending this talk. First off, I have no financial disclosures. This is an overview of the content that we will be covering. In his experiments, Michael Faraday discovered that there is a close relationship between electricity and magnetism. When an electrical current travels through a coil, it creates a magnetic field, and this magnetic field in turn generates a secondary electrical field in a nearby conducting material. Using this principle of electromagnetism, Anthony Barker developed the first TMS device in 1985. By passing an electrical current through a circular coil placed tangentially on the head, it is able to induce a magnetic field that penetrates the skull and in turn creates a secondary electrical field within the brain that leads to neuronal depolarization. So when a single pulse is given to the M1 motor cortex, it leads to the depolarization and activation of the corticospinal tract neurons. And when this signal eventually reaches the muscle, it can be picked up by electrode, and this is called the motor evoked potential, or MEP in short. TMS can be basically given in three ways: single pulse, paired pulse, or repetitive TMS. Repetitive TMS in particular has been shown to produce neuromodulatory effects. Currently, we still do not know how the exact neurophysiological mechanism behind this, although it likely involves changes in synaptic plasticity. Furthermore, such neuromodulation of brain activity and its associated behavioral consequences can outlast the duration of TMS stimulation. This forms the basis of therapeutic utility of TMS in a variety of psychiatric and neurological conditions. To effectively use TMS as a treatment tool, we need to understand its parameters. This is important because different parameters may produce different physiological and clinical effects. This study shows a clear relationship between the MEP amplitude and different frequencies of RTMS stimulation. A higher frequency of repetitive stimulation generally results in a larger MEP amplitude. The change in MEP is thus an indirect physiological marker of the neuromodulatory effects of RTMS. This research group applied 20 Hz versus 1 Hz frequency RTMS to the posterior and inferior parietal cortex. In this picture, red equals to increased tracer uptake and metabolic activity, and green is the reverse. The star indicates the area of TMS stimulation. The pictures clearly demonstrates different pre-metabolic activities in response to different frequencies of stimulation. To add on to the complexity of the effects of TMS treatment, the relationship between TMS treatment parameters and their physiological effect is not linear. This study shows that for the same treatment frequency, by increasing the duration of stimulation, it can lead to the opposite physiological effect as measured by MEP. This leads on to the idea of homeostatic neuroplasticity or state dependency. We believe the brain avoids excessive states of stimulation or inhibition to maintain within the physiological range of activity. This basically means that high level of neuronal activity favors depression, whereas low level of neuronal activity favors facilitation. This study elegantly demonstrates homeostatic neuroplasticity and state dependence. At the same time, you might also have noticed that common neuron rehabilitation conditions, such as stroke, acquired brain injury, Parkinson's disease, are not FDA approved. So, either TMS is ineffective for the treatment of these conditions, or TMS is potentially effective, but the current research is too heterogeneous to prove it. If we just think about all the different types and permutations of TMS treatment possible by changing TMS parameters, and the different effects of TMS with state dependency and homeostatic neuroplasticity, it is not unsurprising that treatment strategies are response to treatment can be extremely varied and heterogeneous. The good news is that by gathering evidence from increasing numbers of studies, we are starting to observe trends and patterns of treatment that work for specific conditions. The European evidence-based guideline published in 2020 has identified strong levels of evidence in the use of RTMS for several neurorehabilitation conditions. Still, many questions have to be answered to unleash the neuromodulatory effect potential of RTMS and to maximize its effectiveness as a form of treatment. The important question is, where is the target? The brain is a large organ, but the direct effect of TMS on neurons is very focal and localized. If you want to promote neuroplasticity in a stroke patient with hemiparesis, or aphasia, or any other specific impairment, where should we stimulate in order to promote maximum neuroplasticity and recovery? This is definitely an open-ended question, but I think a lot can be learned from the history and development of TMS treatment for depression. Using functional imaging technique, which is able to measure blood flow or glucose metabolism in different locations of the brain, research groups compared the brain activity in depressed patients versus normal control. In addition, they also investigated the change in brain activity when patients with depression recovered from their condition. These studies consistently showed an association between depression and abnormally low-level activity in the dorsolateral prefrontal cortex, or DLPFC. However, this can mean two things. DLPFC hypoactivity could either represent a dysfunction, or it could be an adaptive or protective response. These studies demonstrate an association between depression and DLPFC hypoactivity, but cannot prove a causal relationship. Naturally, the next step is to investigate if there is a causal relationship between DLPFC hypoactivity and depression. If DLPFC hypoactivity is causally involved in the pathogenesis of depression, then damage to DLPFC would confer vulnerability to depression. Studies done in stroke, head injury, and neurosurgical patients showed that patients with DLPFC lesions indeed had significantly higher level of depression compared to patients with lesions in other parts of the brain. This, thus suggesting causality relationship between DLPFC hypoactivity and depression. This makes DLPFC a potential target for TMS neuromodulation. One can hypothesize that increasing DLPFC activity via neuromodulation may improve depression symptoms. Indeed, many studies set out to test this hypothesis using DLPFC as a target for TMS neuromodulation and have demonstrated significant clinical efficacy. This multi-site RCT of around 300 participants is the original paper that led to the first FDA approval of RTMS in depression treatment. The graph shows significant clinical improvement in depression compared with control group across different measures of depression. Following the original study, another large-scale RCT with approximately 400 participants tested a different treatment protocol, but still using the DLPFC as a treatment target. When compared with the original study, there is non-inferiority in treatment efficacy as shown in this graph. This new protocol led to the second FDA approval of TMS treatment in depression. Recently, another research group tested the more accelerated and intensive RTMS protocol. The target is still the DLPFC. To go one step further, individualized stimulation target within the DLPFC is determined using patient's own functional MRI scan. The result from this study demonstrated an even greater efficacy for depression treatment, and this led to the third FDA-approved TMS treatment protocol for depression. Given the ability of TMS to modulate neural activity and promote neuroplasticity, and with increasing understanding of how the brain works and interacts with TMS, there is a very exciting potential to expand and enhance its therapeutic use. As we move ahead, it is worth keeping in mind the strategies used to establish our existing TMS treatment protocols. Thank you.
Hello, thank you, Dr. Lee. Dr. Lee online? Can you hear us?
Hello, and thank you for attending
Hi.
this talk.
Yes,
First
I can
off,
hear you.
I have no financial disclosures.
Hey, good afternoon.
Yeah, Dr. So we have a very simple question for you regarding RTMS. Among the motor...
This is an overview of the content
Can you hear
that
me?
we will be covering.
Sorry, I can try. It's a little bit muffled, but I'm getting some
These
sound from your
experiments.
side.
So are you personally using RTMS for research
Yeah,
purposes or for treatment purposes right now?
Right. So I think in Singapore it's being used for both. RTMS is being used for treatment mostly for depression, and research in for different kinds of physical impairments such as in stroke patients. So we do have a few centers in Singapore with some experience in RTMS.
And among your experience regarding stroke patients with motor, cognitive, and speech language, what do you think is the best indication for TMS in stroke? Is it the speech language, the motor function, or the cognitive dysfunction?
Okay, so thank you for the question. So what's the question again? Just to confirm. Yeah. Right. I think the strongest evidence right now is actually in terms of motor impairment. So, but there is also some evidence right now to show the use of RTMS for language and cognition as well.
And for the motor dysfunction, which one is better, the high frequency ipsilateral or the low frequency contralateral stimulation?
Yeah. So exactly. Yeah. Yeah. So that's a very good. I can hear you. I can hear you. Yeah. So I think that's a. Thank you for the question. Whether high frequency or low frequency, right? Yeah. Yeah. So I think that's a. It is still a very currently it is quite an open-ended question. The European guidelines in 2020 recommended for low frequency stimulation to the contralateral side of the brain for recovery. But essentially, I think there are many studies out there that has tested different protocols, be it high frequency or low frequency, ipsilateral versus contralateral. So I think the verdict is still out as to which side is the most effective. Yeah, but it is really about personalizing and selecting the right target for the right individual to maximize the recovery.
Okay. Any more questions for Dr. Lee from the audience? No. Okay. Thank you. Thank you, Dr. Lee, for your time. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you. Now I request Dr. Sapan Kumar Mishra to come back on the stage and present his talk on artificial intelligence in rehabilitation. Yeah. We are very sorry for you going back and then coming back again.
So international, then national. So, okay. Thank you, Chairperson, and distinguished friends. Actually, this presentation, I'm thankful to its organizer for giving me this opportunity to present on this topic. My disclaimer that I don't have any financial or other issues with this presentation, and I'll cover these points. So my point is, this rehab is basically a need or luxury. WHO has already been mentioned in his document, recent document, that it's neither a luxury nor an optional care. It's a need and preference, and should be person-centric and need and preference based. And it also expected there is demand will increase because of higher expectancy of life, causing high level of elderly, more than 60. And 2050 there will be double of the number, and nearly 20%, 25% of the population will be in the world will be around this elderly. So, but the fact is there is unmet need in the rehab, causing mostly in the middle and low income countries. There is a lack of accessibility, paucity of healthcare workers, rehab workers, and higher cost of service, causing 50% only accessible to rehab service. Therefore, WHO launched a program, 2030 Rehab, is in 2017, and they also focused on use of technology in rehab. So what are the limitations of current rehab practice? Basically, it is centralized, access-based, and inadequate access to post-discharge home and community care, poor data management, healthcare data, causing there is maybe inappropriate keeping or loss in the transit in transfer. So there is a need for preference-based is lacking. So there is one size fit approach in rehab, causing all a similar format sort of things. Therefore, the loss of data is being important. So benefit of AI, therefore, it can, in healthcare data management, they can collect good number of data quickly, gather, interpret quickly, faster than human being, facilitate assessment and improve the precision decision making, and enable quicker pattern generation, causing less medical error and quick problem solving and logical conclusions. Other benefits, like it can offer tailor-made program for specific disability and specific rehab program, and ML machine learning algorithm can be automated and evaluated regularly. All these can be offered need and preference-based person-centric rehab. Telemedicine in AI also help for inaccessible area can be covered by rehab services. So thus all these design a customized treatment protocol. So AI is basically human intelligence is acquiring ability to knowledge, skill, learning, understanding. Artificial is the mimicry of human intelligence, and it is an umbrella concept. It is basically two branches. One is informatics, another is robotics. Informatics is collection of informations, like in the form of and assimilation and analysis all, and application through robotics or maybe other ways. So therefore, the prediction automation become faster. It has got several components: machine learning, deep learning. Deep learning is basically deep means the depth of the artificial neural network. It is like human neurons, is statistically modeled artificial network, and neural language processing is the ability to computer understand the human knowledge, human language. So basically difference between deep and machine learning is nothing is a volume of data and complexity of data. Machine learning lesser data, deep learning is more data and complex data here. And this artificial network, as I said, it is statistically modeled just like human neural network. So it can be applied in various areas. Neuro rehab mostly, Abhishek sir has already been described in his talk. So there are various tools and programs. Virtual assistant can reminder and support, and it can be used in stroke virtual system, and motion recognition technology can be used in hand or lower limb also. MS Kinet is a device which can be used movement recognition and movement sensing device for data collection, which can be done from further far areas for tele-rehab. Biomech VR is a stroke rehab for lower extremity. So all the, and exergaming is another low cost alternative. Balance posture, facial paralysis, gait, all these things can be, AI implemented devices can be used. Proprioception, neglect can be rehabbed by virtual reality model. Upper extremity in stroke, Gentronics on system that can be used. And in TBI also, there are physical, cognitive, intellectual domain has been damaged. So that can also be AI technology can use. Brand project is very interesting project which can helpful in TBI cognitive rehab. By this way, it is actually post-discharge program. There are various tools are used: sensor, lower extremity, upper extremity, and inertia measurement unit also being used. So all this can be fit to the person or can be area, surrounding areas also. AI wheelchair is development which can be used by without any caregiver by AI programming, AI this technology. So robotics is another advancement in, as I said, another branch of AI application. So this is an intelligent device with human movements and etc. positioning can be done. Robots is basically physical equipment which do some change in the surrounding, both physical and mental. Effective, robots can do some effective support also. It just got various degree of autonomy. It may be fully automatic, may be fully controlled, may be mixed. Most of them are mixed. And medical robots are very much helpful in geriatric care and other. It may provide physical, cognitive support in either way. Physically assistive robot mainly support in recovery, movement, transfer, etc. in neuro rehab. And socially assistive robot mainly social support. There are various forms of robot. RoboKind Milo is a small robot which can help in autism, young persons, this is Toyota human robot, various forms of robot. Toyota human robot is helps in ADL, elderly. Animal robots in companion robot, like it can help alleviate loneliness and depression. Tabletop robot helps in cognitive support to autistic and dementia patients, and mobile telepresence in pre-rehabilitation support. Exoskeleton is already discussed, so this is very important in AI implemented, designed AI algorithm can be helped in good rehab protocol. tilt table also associated with programming. Upper limb robotic rehab also can be done. Finger rehab is important here. Assessment of ROM force spasticity, movement therapy can be done by program. Sensitivity training can be done. Serious gaming, and all done by surface electromyography. In MSK rehab, diagnostic as well as therapeutic protocol can be designed by AI algorithms, and in shoulder, neck, and back rehab protocol designing. And socially assistive robot here helps in motivation, engagement, and adherence to the rehab program. In neuroprosthesis development, machine learning algorithm can be helpful in symbiotic neuroprosthesis and myoelectric control by using brain-computer technology interface. And intelligent prosthesis also needs some programming. And rehab technology, another technology used AI in rehab protocol designing. IVA intelligent virtual agent is another. It is a computer generated animated virtual character which suits to the person, so it can be designed accordingly, and it helps in peer training or human coach, caregiver, care provider. It is not experiencing any burnout or fatigue. It can continue prolonged. It is sometimes more reliable than human. And virtual affective agent is another form of IVA, which is recognize and express human emotion and support the affection. Virtual human rehab psychologist helps in modify according to cultural need of the patient, language, communication, colloquialism, mannerism, everything. So these are virtual humans. Instrumental environment or smart home, these are recent. These are actually sensors used surrounding area, so to collect the data. It can be from remote, so and it can be helpful in feedback and also data collection and rehab protocol planning. So combining with this AI, you can continuously monitor the things from remote. AI so to summarize, it can be helpful in examination and cognitive behavior, continuous measurement, risk estimation also it can be helpful. Physical and virtual technology of AI can be useful in rehab protocol. Measurement of body movement, as I said, speech, cognitive function, data analysis programs, automatic measurement and analysis of everyday situations, psychological evaluation, everything can be easily and faster way and accurately, precisely in a protocol manner can be done to avoid error in medical practice. But there are certain misconceptions about AI application. One is AI can replace human caregiver and cause harm to quality of care, but it's not a fact. There are personalized feedback monitoring system. Another is implementing AI is complicated and expensive. Initially, everything is expensive, but gradually, after more and more use, it will be easy to understand and apply. And another misconception is AI is not reliable, but it is not a fact. It is designed and evaluated with rigorous methods of standards, and ethical consideration has been considered. Continuous evaluation by R&D is done, and there are future scopes and opportunities. Situation is low and middle income country, they are rapidly using this technology. Mostly cost and non-ability of healthcare workers. So the remote area can be covered by this technology by using the all sensors and all. And there is scope of research also if there is any limitations. So both advantage and drawbacks of existing system of rehab with future applications and AI-based solution for decentralized rehab care is the area of future research. But there are barriers. Interoperability means combination of data from various sources. So that is required. So because rehab protocol should be made on social and other issues, and including the clinical. So that to be compared and mixed. And data transparency should be there. Black box nature of AI may confuse certain clinicians, so that should be transparent to all. And actionability. Inside of AI should be actionable otherwise, and clinicians should be given free hand to change the protocol if required. So take home is, AI tool can offer an exciting possibility of transforming rehabilitation medicine from one fit all paradigm to personalize, precision-based, decentralized and cost-effective rehab service and delivery model, each and every individual patient to achieve their rehab goal. So there are some studies also done, just showing, and references. Thank you.
Thank you, Dr. Sapan, for the nice presentation. The session is open for discussion. Any members having questions for Dr. Sapan? Since there are no questions,
one small comment. I think the biggest usage for AI in countries like India, LMIC countries, are two. One is data monitoring. Get patients back for follow-up. And second is wearable technologies. Your smartphones, your smart watches, sensors in the feet. For example, with the new software, you can pick up a MI with your smartwatch. I've seen a presentation of people, one cardiologist himself was not able to diagnose, but his machine told you are having an MI, and he rushed to the emergency, got his angioplasty done. So monitoring with smartwatches and wearable sensors in legs to get the feedback and monitoring is the best usage of AI, which is low cost model, which can be very helpful in countries like India and long term. Thank you very much.
Thank you, Dr. Sapan. Now we go to the next talk. I welcome Dr. K. Vijayan, consultant neurologist and neurosonologist.
They are to arrive, sir. I think meanwhile we'll have some from team from Synergy. Yes. One gala dinner video promo will be playing.
Sir, the last two speakers are yet to arrive, sir. Shall we have a break for about 15 minutes and then shall we rejoin later?
I think the next chairperson can do it in the next session. Okay?
Okay, sir. Okay.
Yeah,
Yes, sir.
thank you.
Yes, sir.
With this, we conclude the session. Thank you very much.
Thank you, sir. Thank you. Sir, just wait for the memento distribution, sir.
I request Dr. Rambalavanan sir to facilitate the chairpersons. Now we shall break for tea for 15 minutes and then reassemble again at 3:15 p.m. for the next session.
we can create the lesion through which we can stop the tremor predominant Parkinson's disease. I'd like to welcome to the dais to start with Dr. Vijayan and then Dr. Ursula. Yes.
Good afternoon, everyone. At the outset, I'd like to thank the Physical Medicine Rehabilitation Scientific Committee to allow us to present our new innovative technique. It's really revolutionized the treatment of movement disorders. First of all, I should congratulate my colleague Dr. Vijayan forming as a team for bringing that excellent, wonderful machine to the Royal Care Hospital. It's really taken up to the next level of the movement disorder treatment. So we are going to more or less, it's not a very formal didactic lecture. We'd like to have an interactive session. So we could stop at any time. We can answer the questions and queries. Meantime, we will be showing a few videos which we have done so far. Almost 60 cases we have done with phenomenal success. Then he will give us some basic principles of the MR guided focus ultrasound, how it evolves, what are the limitations, and what's the uses and indications. So I'll invite Dr. Vijayan first, and then I'll chip in.
Respected chairpersons and dear comrades. This is the team. It's a team effort. It's not a one-man job. You have to have a team for this, and we built this team, this wonderful team of neurologists, neurosurgeons, radiologists, and of course various technicians. And of course, we won't forget the help offered by our PMR department also in rehabilitating these patients once we get them out of the treatment suite. Now, this is a totally non-invasive method. Now, we all know, I'll give a short introduction about Parkinson's disease and dopamine. Parkinson's disease, as we all know, is due to lack of a chemical called dopamine in the brain. The dopamine is secreted by the substantia nigra, and the dopamine is the chemical of more. When I say chemical of more, it is a chemical of action, it is a chemical of attention, it is a chemical of addiction, and it is also the chemical of award or reward. So it has so many functions. The very fact that we and me and you are all surviving today as a species is because of dopamine. Dopamine is the chemical that urges you to ask for more. If you have a tent, it asks you to have a house. If you have a house, it asks you to build a bungalow. If you have a bungalow, it asks you to get a car. If you have a car, it asks you to get a bigger car. If you have a bigger car, it asks you to get a plane. If you have a plane, it asks you to go. So that is endless. So that is why it is called as the molecule of more. What happens when this molecule is lost, when you lose the chemical? Not only you have what are the classical motor symptoms of Parkinson's disease, the classical tremor, rigidity, akinesia, and postural instability, but you also have other non-motor symptoms of Parkinson's disease. Now, of which the most disabling, all these four symptoms are very disabling. Of course, the instability is very much disabling. Now, this technology, for you to imagine, this is how we produce the lesion, a small lesion in the brain. Now, how do we produce it? But as school children in your physics class, you would have used a convex lens to focus sun rays on a piece of paper and burn a small hole in it, or use a leaf and burn a small hole in it. Now, it is the same way. Here we focus ultrasound. Instead of focusing sun rays, we focus ultrasound on the brain. How do we know where we focus? we use the MRI. That is why it is called MR guided focused ultrasound. And we burn a small hole. Why do we burn this small hole in the brain? The brain, as we all know, is an electrochemical organ. It contains a lot of chemicals, and also it consists of a lot of circuits. And these circuits generate currents in millivolts and microvolts. Now that is how you think, you act, you see, you hear, you smell. Everything is based on these small electrical currents generated in the brain via these chemical components. So it is an electrochemical organ consisting of large amounts of circuits. Now, due to lack of dopamine, what happens is there are a few circuits in the brain that become hyperactive. When these circuits become hyperactive, then there is no way of controlling them. If you replace dopamine orally, it doesn't simulate the exact precise mechanism of generation of dopamine in the brain. So that is the reason why when you give Syndopa, the patient get better initially, but later on they develop side effects. Not only they get better initially, they don't get 100% better. It doesn't solve all the symptoms of Parkinson's disease. These sort of therapies were even used before Syndopa, but in a very crude manner. That's called radiofrequency ablation by drilling holes in the skull. But later on, when Syndopa and all the dopa agonists came, this went out of favor. After 15 years of dopa, then again the new technology, deep brain stimulation, came. It offered hope. Now, as the honeymoon phase with deep brain stimulation and Syndopa is over, now ablative therapies have again come. Why ablative therapies have come again? Because one, they are more effective, they are instantaneously effective, and now they can be done safely. Previously, the safety was an issue. Nowadays, the safety is totally taken care of. It's almost 100% safe technology. And touch wood, there are no single major complication reported till date from more than 170 centers in the world performing this procedure. And we are happy to say that we are the only center in India to have started this procedure. This is the timeline, and in 2016, a first case report or case series was published, a randomized control trial was published for essential tremor. Same year, a case series report was published for Parkinson's disease. It was approved for essential tremor. 2019 for tremor-dominant Parkinson's disease, and 2020 it has been approved for all the symptoms of Parkinson's disease, including rigidity, bradykinesia, and what more, if we target a particular region in the brain called as the pallido-thalamic tract, even the balance improves, the gait also improves, which does not improve with medications, nor does this improve with deep brain stimulation. This is one feature which makes it little more better than all the other modalities of treatment. Okay, having done this, do you need to throw away the medication? No. Parkinson's disease is a degenerative disease, so we treat the symptoms, we cannot cure the disease. So it is an adjunct to treatment. The cornerstone of treatment is, of course, medications. This is an adjunct, additional adjunct to treatment. Now this is how the instrument looks like, the MRI, and this is the ultrasound transducers. It contains 1024 elements, and all these 1024 elements focus ultrasound waves at 650 kilohertz to a particular part of the brain, and we destroy the hyperactive circuits alone with sub-millimeter precision. So with sub-millimeter precision, when the circuits, these particular circuits are destroyed, the patient gets relieved of the tremor, rigidity, bradykinesia, and even more, the patient's gait also improves, though not immediately. After about 4 weeks, 6 weeks, we've seen that the patient's gait also is improving with this technology. So this is how the patient is fixed to the machine with a helmet and the transducer. This is how we make the measurements. We mark various measurements here because these circuits are not classically seen on the MRI. We have to make measurements. How are we safe then? Because the patient does not undergo any anesthesia. The patient does not have any anesthesia. It's only local anesthesia for fixing the frame. There is no general anesthesia. So the patient is fully conscious. He keeps interacting with that. The whole team, we keep on going every 10 minutes, 15 minutes, we go inside the MRI suite and we keep examining these patients again and again to see if the patient has improved, one, two, whether the patient has developed any side effects or not. If these, if the patient has improved and if the patient does not develop any side effects, then we go on to complete the lesion and we completely target that particular area and we burn out a small hole in that area, destroy the circuit totally, and the patient is relieved of his symptoms completely. Now this is another how we mark the areas. This is the MRI, and you can see that this is the target, and this is one important critical area in the brain which is for memory, which is called as mammillothalamic tract. This is another critical area in the brain which is called as the substantia nigra. So like this we, subthalamic body, and based on this, how do we make it so safe? We have 4 phases in this treatment. At an alignment phase, we raise the temperature to 40 to 45 degrees Celsius. There we know what we have produced because an MR thermography is integrated in the machine. So it shows the temperature exactly. See, this is the target area and this is the area where the temperature has increased up to 42, 45 degrees. So we know, we mark the size, shape and location of this lesion, and then once we are sure we have aligned the lesion, we align the lesion in various things. We align the lesion in axial plane, we align it in the, this is the axial plane again, we align it in the sagittal plane, and we also align it in the coronal plane. In all the 3 planes, we align the lesion. So once we have aligned, then we go ahead to raise the temperature to this level, 46 to 50 degrees Celsius. At that level, what happens, the patient completely symptoms go off. Even if he has any side effects, he will let you know. We make the patient write, we make the patient draw, because the patient is fully conscious and he is with us throughout. And once we are sure that the patient has become better, there are no side effects at all, then we go on to this phase called as the treat low phase. Now in this treat low phase, at somewhere around 50 to 55 degrees, very rarely we go to this treat high phase. We produce, again we increase the temperature, and then finally we produce this lesion. You can see a dark blue hole and surrounding light blue hole. Both of these can be lesions. How do we verify this? Not only clinically, we also do an MRI during the procedure. So during the procedure, you do MRI, you see a white spot on the MRI at the area which is where we intended to make the lesion. And of course, we are also seeing the patient clinically. Then we stop the procedure. That is the time when we stop. So it's, though we make the measurements, we mark all the measurements, ultimately the lesion or the target is what the patient guides us to. Why? Why do I say so? Because the patient keeps telling us whether he is getting better or not. If he is getting better, he tells us. If he is not getting better, again he tells us. Then we can move this direction, target, in either the X, Y or Z direction. So in all the 3 directions, we can easily move these targets, and thereby we can finally make the lesion. When we finally make the lesion, it looks like this, and then we can do an MRI scan, and we can also find out where the lesion is exactly. So we are very safe. Since we have marked the critical structures, we have made the lesion, we've seen the patient, we are very, very safe. So it's a very, very safe procedure. This is how we do the MRI. During the procedure, we see these white spots, and then we stop the procedure when we see these white spots. Now, this is all I told. The advantages of this procedure, I'll tell you, it's sub-millimeter precision. So the machine will not allow you to even create a lesion if your target, marked target, and where the ultrasound shoots are more than 1 millimeter. So it should be less than 1 millimeter. So that critical it is, less than 1 millimeter. There are no major complications. When I say no major complications, there are some minor complications which can occur. Few minor complications which get better with time. It's real-time monitoring, no anesthesia, no incision, almost 100% effective and totally non-invasive. Now with this, I will finish this introduction and I'll ask my colleague Dr. Arul Selvan sir to present a few videos of the patients which we have done till date. We've finished about 62 patients, 66 treatment procedures, and all these patients are doing very well and they're improving over time. Sir.
Thanks, Vijayan. That was a very nice introduction. You have dopamine, don't ask anymore. At the outset, I would like to again thank the organizing committee of the Indian chapter of Physical Medicine Rehabilitation, the Tamil Nadu chapter. So I'll show you some of the cases. As we said, we've done so far about 60 cases, just above 60 cases and 66 procedures. And many of our patients are all doing very well. I hope the videos are working. This is a patient, you could see that he has a tremor predominant Parkinson's disease on the left hand side. So as Vijayan sir said, it is a team effect. Everyone is a part of the team. The videos are not working. That's it.
Feel very beautiful. Petrol very good. Okay. Right.
This gentleman has got a tremor on the left hand. You could see that pre-operative scores and the post-operative scores, you can combine that. Pre-procedure is 119, post-procedure is markedly reduced to 60. And the PDQ score is 13 months later. We have roughly about a 1 year follow-up for all these patients. It's done a phenomenal improvement. So the improvement is sustained, consistent, and then it is still continuously going. This is one-off procedure. You don't need to come back again and doing the procedures. This is only one-off. As he emphasized, this is a non-invasive, very safe procedure. Technically, although it's demanding, but it's very, very safe. Very few millimeter precision. So pre-procedure score and post-procedure score is comparable.
Try. Handsome.
You could see that decreased facial
How do you feel
expression,
today, sir?
perioral tremor, right hand tremor.
Okay. Try.
This is another patient. You could see the marked dyskinetic movement. He is a patient of Pakistani origin, now settled in Dubai. Dopa-induced marked dyskinesias. He cannot able to eat, he cannot able to lie down. Very frustrating for him, very frustrating for the family also. He takes only half a Syndopa, he is extremely sensitive for that. The same patient, you can able to see he is eating his chapatis after many, many years. He can able to feed himself. Not only able to eat, he can able to jog. This is in a hospital corridor, he is able to jog. It's absolutely wonderful that the patient is markedly improved. So we have done one side on him. He is coming back after that for the second type procedure also on the other side. We've done on the right side. He's coming for the left side now. Here post procedure, this is the gentleman who could not able to significantly having tremor on the right hand, improved on the tremor, bradykinesia. You can see that marked difference between the left hand and the right hand. He had a resting tremor on the right hand, which is almost vanished. You can see his walking.
So he has a left hand tremor, which we have not done the address so far. But the right hand, he had a tremor, rigidity, and the bradykinesia, which is markedly improved. Again, the same UPDRS scoring procedure is about 169. Post procedure is 72, and the PDQ scale is also markedly improved. This is another gentleman. Right hand tremor, resting tremor, increase in posture, and also in action. Not only has a hand tremor, he also had a leg tremor also. You see the right hand tremor and the right leg tremor. Post procedure tremor has improved phenomenally. You can see the cursors. We are asking to hold the stick on that to see that tremor has improved. And the pre-procedure to the post-procedure. So another patient. He was working as a pastor in one of the Western African countries, somewhere in Namibia. You could see that following the procedure, he could be able to walk very well. The arm swing is much better. Bradykinesia has improved. And the tremor has also disappeared. He sent this photo from his farmhouse there. Let's skip this video. We are testing for the bradykinesia.
Surya.
We're testing for a cogwheel rigidity. This is a lesion we made it on this patient. You could see that one is on the pallidothalamic tract, another one is in the ventro-intermediate nucleus of thalamus. This is a MR confirming that we have focused ultrasound lesion in it very precisely. See the post-procedure improvement. You could see that the initial freezing hesitancy and then started running, gait disturbances. Leg tremor, and then you could see some hand tremor also. bradykinetic. As we assess during the procedure, you could see that the clinical assessment is the core and important during the procedure. Although DBS, we could do the same thing during the procedure also, but sometimes the patient will be drowsy once you open up the dura and the phase of pressure is varying. But this is patient will be conscious throughout the procedure, and you can do all the assessments. You can assess the rest tremor, bradykinesia, rigidity. See that foot tremor. You could appreciate the tremor is markedly reduced. Again, he had the MRI lesion, very precise, roughly around 6 to 8 millimeters in size. The lesion is one done on the right side of the thalamus for the left arm and left leg tremor. Post procedure, we noticed that he had a significant freezing difficulties of the gait that has also improved. The left hand tremor.
Okay,
The
stand
bradykinesis is also improved now.
Turn around. Okay.
Just take a couple of minutes. Can able to do the finger nose coordination much better. So the previous UPDRS was 97 on this patient has come down to 21 following the procedure, and there is a much clinical improvement also. Just show you the last two videos and then I'll stop it.
திரும்புங்க. சரி, நேரா பாருங்க. நமக்கு கையை நீட்டுங்க.
So he had a right hand tremor that's improved on that one.
Just try.
Try to write. You could see how vigorous the tremor was.
Okay.
It's not only the resting tremor, it's increase in action and posture. I'll show you one last video. See the tremor on the left hand. Post procedure, there was a marked improvement. This is the same patient. Hardly you could notice any tremor on the left hand. This is a patient who had a severe Parkinson's. Again, like a similar patient before, I've shown the videos. He had a dopa-induced dyskinesia. He was taking only about 4 Syndopa a day, 110 milligram. If further increase will cause us a marked dyskinetic, unwanted movements on her.
You could see that how writing movement, dyskinetic, and sometimes it could be painful for a while also.
Try பண்ணி
If
பாருங்க.
you're not able to walk,
மாமி ட்ரை பண்ணி பாருங்க. பிடிக்காம நடந்து பாருங்க.
இல்லை கொஞ்சம் இதுவாக இருக்கும் இல்லையா ரிஜிடாக இருக்கிறதுனால.
same patient, following the procedure. We've done only one at a time. Recently we have done on the other side also.
நிற்க தான் முடியுது ரொம்ப கஷ்டமாக இருக்கு.
So we have done on the left side of the brain, so the right hand and right leg is doing well. Left hand and left leg, she still has some dyskinetic movements. This must be the last video. I'll stop it from here. So to conclude my talk, so MRGFUS is a very novel technique. It's a perfectly safe procedure, very few millimeter precision. We can control it by giving the joules and energy what time, at what level we want it. We did not have any complications so far. Some of the complications are very transient, like ataxia, weakness, temporary weakness. It's all lasted for about 1 to 2 days, and then it's improved markedly. Thank you once again for your patience. Thank you very much.
Thank you, Dr. Arun and Dr. Vijay, for an enlightening talk. And I'm sure it's going to revolutionize the treatment of Parkinson's. You'll get more and more patients. Now the questions from the floor. Any questions?
Yes, sir.
Yes, Dr. Abhishek.
Hi. Are you using the Lexel frame for making the coordinates?
We are not using an Excel frame, we are using a stereotactic frame. We have not shown you on that one.
Okay.
An Excel frame is not used, we are using a stereotactic.
And the ultrasound machine is embedded in the frame system only.
Yeah, we've shown that piezoelectric cell is arrayed in a 360 circle with a helmet-shaped one. So it is fixed with the table so that the head goes in and then it focuses the array. It's a focused array of piezoelectric cell array with that one.
What is the treatment time normally? It
Treatment
takes
time.
One patient takes
If
1
the
hour.
patient is cooperative, we will be taking about 1 to 2 hours. Because we are doing only one at a time now. We are not licensed to use both at the same time. Being it's a lesional surgery, we may cause a permanent weakness. That's what we are worried about. The US FDA and also the Indian government has agreed only for the one procedure at one side at a time. So we'll be doing only a right or left side only.
You have about a 1 year follow-up. Any change in the non-motor symptoms also?
Non-motor symptoms.
Yeah.
That's a good question. When the dopamine is more, all of the non-motor symptoms also got improved. So many of the patients who had a subtle depression and then constipation, when the mobility has improved, these symptoms are also improved. But we did not document, but there is a substantial improvement in non-motor symptoms. Interestingly, the other side also improves in our patients. You would agree with me, Janis?
Yes, sir. Just to add on that non-motor.
Hello, sir. I am Dr. Kaniyarusu from Madurai.
Just one
To add on that non-motor symptoms, there was one patient who said that he got back his taste. And I'm not sure, it's not documented in world literature. Till date, it has not been documented. One patient who said he got back his taste. Then there are a lot of patients who say they lose the craving for syndrome. Craving is gone. And then as we showed on the videos, dyskinesias are totally abolished. DOPA-induced dyskinesias totally abolished. And even if you re-challenge with DOPA, they don't come back.
Parkinson's disease is an extension of Bryan-Capellan. Many of the patients will not have any smell. That's the first symptoms or sign. We'll pick it up. So when it improves, the taste also improves. I think that could be an explanation for the non-motor symptoms.
Hello, sir. I am Dr. Kaniyarusu, a physiatrist from Madurai. Up to what stage you do this surgery? of Parkinsonism?
No,
Stages of
that's
Parkinsonism.
depending upon the patient's selection criteria.
Yeah.
Some patient will be in stage 2, but they'll be doing a very high profile job. For example, one of our patient is a chief executive in a bank. So he doesn't want the tremor to be shown in the meeting. So he was at stage 2 or early stages, but he wanted to be done to abolish the tremor.
Okay, last stage you have gone?
Last stage, probably stage 3. We have not done any patient with the bed bound at all.
Yeah.
When the patient comes in the bed bound, we directly reject it because it does improve the quality of life. We need to have certain quality of life to achieve that. So if you don't have bed bound, then there's no point in doing the procedure and increasing the mobility.
So up to 3 you have been, sir?
Yes.
Thank you, sir.
Thank you, sir. Any recurrence so far? There was one patient who had a tremor as recurred in 6 to 9 months time, but that is multifactorial because he is alcoholic dependent patient. He also had a familial tremor, essential tremor. We have done the procedure, but he gone back and then he was living in the high estates and was drinking more. So we have to warn him again, and then we've done the procedure again, and then tremor has improved and he's abstinent from alcohol. He is not recurred so far.
The recurrence rate is around less than 10%. Less than 10%.
I'll pass down to Dr. Vijayan.
It's 25 lakhs. At present, we are charging 25 lakhs for one side, and for the other side, when they come, we charge around 5 to 6 lakhs for the other side.
So mainly the consumables is very expensive. The silicon membrane which has been imported from Israel, that alone cost about 5 to 6 lakhs. So the consumables are costing phenomenal amount of money, and then we have to pay the GST over that. They are very delicate. Compared to DBS, it may be little bit more or less in the same, because the metropolitan like Bombay and then Hyderabad, they also charge a similar amount. But the patient choose this one because it is non-invasive. You could see the results on the table itself. The deep brain stimulation, we have to do a frequent programming. For example, tremor and all, it will take 1 year. So, and dystonia will take even 1.5 years to see the improvement. Complex programming, networking, and then an invasive. Anybody would not like to have a foreign body sitting inside the brain. We don't know, although there are no infection rates so far, but we don't want your foreign body to be sitting in the brain, and then anytime that's not the big issues. No, sir, not yet.
No head-to-head studies, sir, as of yet. Comparing, this is a very new technology now. Though the lesioning surgery is very old, it's a new technology. Only thing I would say, the results, as he told, are seen immediately on the table. It's a one-off treatment. You need not come back again. Most of our patients, both myself and sir, will follow only on video. We don't ask them. We have patients as far from Jaipur, Delhi, Mumbai, Hyderabad. So we follow them only on video. We don't follow them. We don't ask them to come to the hospital. That is one thing. The gait disability improves with pallidotomy, which does not improve with DBS, which does not. In fact, DBS makes it gait slightly worse, and medications also make the gait worse. But here, pallidotomy and pallidothalamic tractomy improve the gait. That has been documented. That one thing has been documented vis-a-vis DBS, but no head-to-head comparisons.
Many patients on the post-procedure, they just cry of emotion because they have not had a useful hand so far for many years. They could able to write, they could able to feed themselves, they can able to shave themselves. It's a very great relief. They don't want to be dependent on other carers for this patient, and they are immensely thankful for that. And many patients have returned and then given the documented writing also saying that so they felt extremely joyful and happy after the procedure because they see the results instantaneously. Madam, yes, ma'am.
Most of the cases that we have seen the video where either tremor dominant or dyskinesia dominant, was that a selection bias, or the patient were willing more for going for surgery if the tremor or dyskinesia was dominant?
At present, we are licensed only. We are only for tremor, essential tremor, and tremor predominant Parkinson's disease.
dyskinetic movements. Only we were licensed only for this.
If the patient only has rigidity or the robotic gait only, you don't
It
prescribe
improves,
this.
ma'am. That also improves.
Yes, sir.
Not as good as tremor. Tremor improves more than 90%. And
Okay, that's
stays
what
for
I
many
saw that
years.
most of the cases were only.
The rigidity and the bradykinesia improves by 70 to 80%. That the gait also improves, but over a period of time. So when we target the palatothalamic tract, it takes care of bradykinesia and rigidity. When we target the VIM, it takes care of the tremor. So it does.
It can be done, but.
No, we have done. We have done.
done.
We've been doing also. As an offshoot, most of the patients have.
And during your speak, you were telling that still the cornerstone of treatment is dopamine, oral drugs.
Yes, madam. Medicine is a cornerstone of treatment.
So should we still titrate the medication post-surgery,
Yes,
sir?
madam. Yes, madam. You have to.
The off and on phenomenon will still happen?
It might happen. Most of the time, the off periods come down remarkably. Some patients are on 8 tablets, 9 tablets per day. They're taking only 1 or 2 tablets per day now.
Okay.
So that much remarkable improvement. At least you can expect 30 to 50% reduction in drug dosage over a period of 3 to 6 months.
Okay. Sir, the total follow-up, the maximum follow-up was 13 months.
Yes,
here.
ma'am.
What's the worldwide follow-up period and
3 to 4 years. 4 years now from Switzerland. More than 4
Michigan
years.
has got 4 to 5 years.
Okay, when there is a recurrence, you still prescribe another surgery, or we have to.
So
Can be done. Can be done.
Fails and they want to go for DBS, that can also be done on the failed patients, but we have not done anything so far. Only one patient occurred, and then we have done the lesioning on that one. As Jean sir said, I think Parkinson's disease is a degenerative disorder. We are not altering the course of the disease at all. We are just giving symptomatic relief. We have to understand that. Many patients will think that you do that and then disease get arrested. No, not at all. The disease progress, the natural course will continue to go ahead. We are just helping them symptomatically. The tremor improves, bradykinesia improves, rigidity improves. Unfortunately, the disease course will be continuing. We cannot alter the course pattern.
But then, for that period of time, the relief you are offering is really magical. Thank you so much, sir.
Thank you so much. After this enlightening talk, can we have you back on the dais so that now, thank you. We'll call upon the next speaker of this session, Dr. Ramamurthy, in-house speaker. He is the professor and head of Department of PM&R in PSG Institute of Medical Sciences and Research, Coimbatore, and he'll be talking about management of diabetic peripheral neuropathy, comprehensive and holistic approach. Dr. Ramamurthy.
Right. Good evening, friends. I thank the organizer for this opportunity. It's a profile of my institution. I welcome every one of you for this presentation. I'm going to discuss the topic in this heading. Case 1. 48 years old Mrs. M from Salem, a type 2 diabetic for the past 12 years, presented with numbness of both feet and a non-healing ulcer in the right foot over the first metatarsal head region for the past 2 years. She also complains of unsteady walking and her footwear slips off while walking. Her blood sugar values are fasting 165 milligram, postprandial 279, HbA1c 9.8. Case 2, 43 years old Mr. T from E Road, a type 2 diabetic for the past 7 years, presented with burning sensation in both feet for the past 6 months. He also complains of erectile dysfunction for the past 3 months. Blood sugar values, fasting 147, postprandial 286, HbA1c 9.8. So I have presented 2 cases. Both cases are complications of type 2 diabetes, namely diabetic peripheral neuropathy. The first case, diabetic peripheral neuropathy with negative symptoms, numbness, and the second case, diabetic peripheral neuropathy with positive symptom, pain. How to manage these cases? So whenever we get a patient, we elicit the history. For lack of time, I'm skipping the history. Assessment of peripheral neuropathy. Whenever you get a case of diabetic peripheral neuropathy, you have to find out whether it's a large fiber neuropathy or small fiber neuropathy. Because the pathology, clinical features, medical management outcome are totally different from large fiber and small fiber neuropathy. Large nerve fibers are A alpha, A beta, A gamma. They conduct proprioception, somatic motor, vibration, pressure, touch, and deep tendon reflexes. When a patient has large fiber neuropathy, there will be loss of vibration, proprioception, position, touch, deep tendon reflexes. So the patient will have numbness walking over the cotton wool or ice. In the management, as of now, there is no drug to bring back the sensation. So we advise glycemic control. The duration of the diabetes and the severity of the diabetes are more important. So we insist the patient to have a blood sugar target like fasting less than 100, postprandial less than 150, HbA1c around 6 to 7%. When the patient has persistent hyperglycemia, the following biochemical events will happen, namely increased polyol pathway, increased glycation, increased free radical production, protein kinase C activation, reduction in vascular endothelial growth factor. In hyperglycemia, the excess glucose will be converted into sorbitol in presence of the enzyme called aldose reductase. The sorbitol destroys the nervous tissue. The covalent bonding of protein or lipid molecule with the excess glucose is called advanced glycogen end product. They damage the nervous tissue. A molecule with single electron in the outer orbit is called a free radical. Normally in our body, free radicals are produced and the antioxidants in our body remove them. When the free radicals are produced in excess, that leads to a condition called oxidative stress. In oxidative stress, a nuclear enzyme is activated called poly-ADP ribose polymerase A that will damage the nervous tissue. In hyperglycemia, there is a formation of diacylglycerol that will activate an enzyme called protein kinase C that will again damage the nerve fibers. You all know the blood vessels are lined by endothelium. So the endothelium, vascular endothelial growth factor is secreted. In diabetes, there is progressive endothelial dysfunction and reduction of the vascular endothelial growth factor that results in neuropathy. Okay. So when the patient has hyperglycemia, the nerve damage occurs through increased polyol pathway, increased glycation, increased oxidative stress, protein kinase C activation, and reduction in vascular endothelial growth factor. So in the intervention, so in the management of diabetic peripheral neuropathy with negative symptom, we have drugs that may alter or slow the progression of the nerve dysfunction. So already we see the glucose is converted into sorbitol in presence of aldose reductase. We have a drug called aldose reductase inhibitor, a molecule called epaltristate available in the name of aldonil. So that will control the damage. Then we have anti-glycation products, namely ivinoconidine 300 mg to be taken 600 mg per day. Then third one, antioxidants. Several antioxidant drugs are available. The recommendations is we take alpha-lipoic acid at the strength of 600 mg. Then fourth one, protein kinase C inhibitor, roboxytaurin it is available, but it is not get approval from the FDA for treatment of diabetic neuropathy. And the vascular endothelial growth factor is not available. Still, it is in the experimental status. So, in the management of diabetic peripheral neuropathy, large fiber neuropathy, these are the management. Number one, glycemic control, aldose reductase inhibitor, AGE inhibitor, and antioxidant alpha-lipoic acid 600 mg 1 OD. A patient with large fiber neuropathy who has benumbed sensation, he will have a recurrent injury to the insensitive foot. The probability of he or she developing the ulcer, non-healing ulcer, amputation is very high. So your prescription for a large fiber diabetic neuropathy is incomplete without prescription for a MCR footwear and a foot care instructions. So you have to prescribe a MCR sandal or a footwear with a quarter to protect the foot. Why do you prescribe MCR footwear for a diabetic peripheral neuropathy patient? The normal plantar pressure is 80 gram per centimeter square. In patient with diabetic peripheral neuropathy, the plantar pressure will be very high. It goes up to 800 grams. When you give MCR footwear, it will redistribute the excess plantar pressure. Also, the MCR footwear will also reduce the interfacial pressure. Okay. Foot care instruction, you have to tell the patient how to protect the foot. There are 20 points. For lack of time, I am skipping this. Okay. So this patient was followed up for 6 months. First month, second month, third month, 6 months, there is no improvement of the symptom in spite of all these drugs. So second case, diabetic peripheral neuropathy with positive symptom, burning sensation. So assessment, the small fibers are A delta, B and C. B and C are the autonomic fibers. A delta carries the pain and temperature. So when the small nerve fibers are affected, in the large fiber neuropathy, I told loss of proprioception, loss of vibration, loss of touch, everything. In small fiber neuropathy, the patient will have exaggerated pain sensation. Why? I will tell you at the end of the session. The numerical pain that is called pain is 9 out of 10. So in the clinical presentation, it may be a burning or lightning or stabbing with a knife. Management. So we have drugs that may alter or slow the progression of the loss of function, like already we discussed, aldose reductase inhibitor, AGE inhibitor, and antioxidants. Therapies for symptomatic relief. The abbreviation TBN stands for diabetic peripheral neuropathy. The DPN stands for duloxetine, pregabalin, nortriptyline. These are the first line of drugs. Okay. The duloxetine is the pregabalin is antiepileptic. The other two are antidepressants. Pregabalin, the subgroup GABA analog, duloxetine, serotonin, norepinephrine reuptake inhibitor, and this is tricyclic antidepressants. You have the choice. When the patient has insomnia, sleepless leg syndrome, you can choose pregabalin. When the patient is severely depressed because of the pain, you can choose the antidepressants. You can start with duloxetine, you can add pregabalin. You can start with norepinephrine, you can add pregabalin. You can start with pregabalin, you can add duloxetine. You can start with pregabalin, you can add nortriptyline, but never two antidepressants together. Okay. How I treated this patient? The pregabalin recommended dose is 75 milligram to begin with, then weekly interval of increased by 75 milligram. So the patient was given 25 milligram, 2 at night, day one. The patient will have constipation, so always you must prescribe pregabalin with Dulcolax. It is a calcium channel blocker drug, like nifedipine. It also will produce edema, so you watch for pedal edema and weight gain. Simultaneously, I give capsaicin cream 0.07% that will deplete the substance P from the nerve terminal. In India, we have 0.025%. In Amazon, it is available as 0.075%. After 1 week from 9, the pain scales come to 8. Then I titrate the drug. The patient was given 150 milligram of pregabalin for 1 week. From 8, the pain came to 7. Then again I uptitrated after 1 week. This time 225 milligram, 2 at night, 1 at daytime. The pain came to 6. Then again uptitrated. So 300 milligram of pregabalin, 2 at night, 2 in the morning. The pain has come to 5. It is moderate pain. The pain is not fully relieved, so I added the antidepressant. Duloxetine, it is available as 20 milligram or 30 milligram. I started with 20 milligram night. This drug is produce nausea. You must take all these drugs for you. You take pregabalin. You see how you feel the nauseating feeling and the constipation. You take the duloxetine. It will produce severe nausea. So always we give along with domperidone. So pain came to 3. Then again titrated duloxetine titrated to 40 milligram at night. And the pain has come to 1. Okay. So 2 important statements from the author of this article: neuropathic pain, quality of life impact, cost and cost effectiveness of therapy. So I taken from the PubMed. Patients with neuropathic pain are usually not prescribed medications with demonstrated efficacy for the conditions. NSAIDs are not recommended, steroids are not recommended, opioids are not recommended. The carbamazepine we prescribe the Decretal are no longer recommended. The recommended primary drugs are pregabalin, duloxetine, nortriptyline. When you prescribe, when they do receive appropriate treatment, they receive dosage that are on an average far below the dosage with demonstrated efficacy. I told you pregabalin must be given up to 300 milligram. Okay, discussion. The first case, who presented with long fiber neuropathy, benumbed sensation, at the follow-up, no improvement of symptoms. The second case, the small fiber neuropathy, pain relief is achieved. Why? When I did MBBS in the late 70s, we studied pathology from the book, Boyd's Pathology, wonderful book. The author writes in the preface, assess your pathology, so is your practice. If you know the pathology of the disease, you can understand the course of the disease, you can predict the prognosis. So this is a neuron, cell body, axon, and myelin sheath. The hallmark of diabetic neuropathy is loss of myelin sheath and axon. Okay, there will be, when there is any injury to the neuron, there will be disintegration of the myelin sheath and fragment of the axon. When regeneration occurs, the axon grows, guided by the myelin sheath, and the proximal segment will meet the distal segment. This will happen when it is a mechanical injury. In diabetes, it is a metabolic injury. Injury occurs all the time. All 24 hours, there will be the patient will have hyperglycemia. So degeneration always occur. Degeneration, regeneration, degeneration, regeneration. At one stage, the degeneration predominant. As a result, the growing proximal end will not meet the distal end. That is to say, the patient will not get back the sensation again. So established symptomatic large fiber diabetic neuropathy is generally not reversible. So you have to tell the patient, you will never get back the sensation in the feet. So what to do for a patient with a large fiber neuropathy? We have to protect the feet from amputation. We have to protect the feet from developing the ulcer, Charcot neuropathy, and amputation. Vitamin B12 methylcobalamin is not a panacea for diabetic peripheral neuropathy. I am not against the molecule, but it's very expensive. The soft gel, one capsule costs 16 rupees. The injection costs 120 rupees. So some of the prescriptions with methylcobalamin. Okay. So what is the indication for methylcobalamin in the management of diabetic peripheral neuropathy? I'll finish in 2 minutes. Metformin is the denominator drug in the management of diabetes. This metformin reduces the intestinal absorption of vitamin B12. When the patient has proven vitamin B12 deficiency, then you supplement with vitamin B12, 1000 microgram parenterally till he reaches a normal level. Why small fiber neuropathy is so painful? See, in small fiber neuropathy, during the regeneration, the proximal end meets it's a distal end. There is no sensory loss, but the newly grown axon, there will be abnormal electrical discharge from the growing nerve fiber. That's why the patient will have severe neuropathic pain. So take-home messages. Symptom, benumbed sensation will not improve in large fiber neuropathy. So in large fiber neuropathy, the management aims to slow further progression and prevent complications like diabetic foot ulcer, Charcot neuropathy, falls, and amputation. In patients with small fiber neuropathy, burning sensation can be 100% relieved if appropriate drugs are prescribed in adequate dosage. Methylcobalamin, available in the trainer, is not the drug of choice in the management of diabetic neuropathy. It is indicated only when there is proven vitamin B12 deficiency. These are my references. It all came in July 2023.
Thank you very much, sir, for great presentation. Any question from audience? Okay. Thank you very much, sir. Thank you. Now, our next speaker, Dr. Shiva Kumar, sir. He is a senior consultant in pediatric surgery, Apollo Hospital, Chennai. He will be speaking on new modalities in the management of pressure ulcer.
Good evening, ladies and gentlemen. At the outset, I thank the organizers and Dr. Chella for giving me this opportunity to present in front of this august audience. I begin my presentation with this statement. Majority of the pressure ulcers can be effectively managed by non-surgeons. I repeat, majority of the pressure ulcers can be effectively managed by non-surgeons. This picture depicts the huge or enormous plantar pressure of Lord Vamana over King Mahabali. So that is the significance of pressure. In a busy OPD, just by inspecting the color of the floor of the ulcer, we can decide on the management of the ulcer. If the floor of the ulcer is amber in color, it is an epithelializing ulcer, nothing needs to be done, only reassurance is required. If the floor of the ulcer is red in color, it is a granulating ulcer, only saline dressing is required. If the floor of the ulcer is green in color, it is an infective ulcer. The antibiotics has to be started based on the gram staining and culture sensitivity, in addition to the diabetes control. If the floor of the ulcer is yellow in color, it is a sloughy ulcer. The slough has to be removed either manually or by agents like urease and papain. If the floor of the ulcer is black in color, it is a gangrenous ulcer. It requires immediate sharp surgical debridement and amputation. This depicts the various floors of the ulcer: granulating ulcer, infective ulcer, and a gangrenous ulcer. This bar diagram depicts the 5-year mortality rates of various chronic diseases, out of which diabetic foot, the mortality rate is much higher than many common malignancies. There is rule of 15 and rule of 50, 50 in diabetic foot. 15% of diabetic patients will have diabetic foot ulcers in their lifetime, and 15% of diabetic foot ulcers will have underlying osteomyelitis, and 15% of diabetic foot ulcers will lead to an amputation. Rule of 50, 50% of diabetic foot ulcers with underlying osteomyelitis need amputation. It means 50% of diabetic foot ulcers with underlying osteomyelitis does not require amputation, which can be salvaged. 50% of amputees require a second amputation in less than 5 years, and 50% of amputees do not survive beyond 5 years. Examination of diabetic foot requires only a pair of sensible eyes and hands. In India, it is our tradition to touch the elders' feet to seek the divine blessings. It is a method inculcated by our forefathers on inspection and palpation of diabetic foot periodically. Ladies and gentlemen, examine the foot of your patients and get immense divine blessings. This is a typical diabetic foot, which has all features of it. There is dryness of the skin, cracks, fissures, callosities, increased pigmentation of the foot, AV malformation, clawing of toes, crowding of toes. There is increased web spaces, and significant surgical sign of an ulcer, both in the diagnosis and in the treatment, is the edge of the ulcer. Edge is defined as the junction between the margin and floor of the ulcer. If the edge of the ulcer is sloping, it is a healing ulcer. If the edge of the ulcer is punched out, it is a chronic ulcer, static ulcer, trophic ulcer. If the edge is undermined, it is a deteriorating ulcer. It requires immediate intervention. During surgical debridement, punched out edges and undermined edges has to be converted into a sloping edge for the ulcers to heal. The predominant inference of a diabetic foot examination is to decide whether it is classified as whether it is neuropathic or a neuroischemic ulcer. Just as we have dermatomes in neuropathy, in nervous system, we have angiosome in vascular system. So it will say if the particular angiosome, even in a peripheral vascular disease, if the particular angiosome supplying the ulcer is fed, the wound ulcer tends to heal. I was part of this study on near infrared optical system to the University of Florida. We did 2 studies. One is to assess the vascularity by using near-infrared optical system for the ulcer. And the second one was removal of the callosity improves the oxygenation to the tissues. The most important cause of non-healing ulcer is the absence of offloading. Management of pressure ulcers is both non-surgical and surgical. The convention is total contact cast. It heals more than 90% of pressure ulcers in 8 to 10 weeks. This is a simple method of offloading called Mantagni method of offloading. What we do is we roll 4 or 5 gloves, wrap it on a gauze and fix it posterior to the ulcer. It offloads the ulcer. Removable cast walker is a commercially available total contact cast, and it is equally effective if worn properly with compliance. It can be equally ineffective if worn only to your clinic visits. These are the other offloading methods. My favorite is walker. Every profession is divine in its own right. We surgeons practice it in both letter and spirit. See, we perform abhishekam to the foot before we complete the surgery. Surgical management involves removal of all necrotic, non-viable tissues until we reach a healthy bleeding wound base. The pus has to be thoroughly let out and deep tissue has to be taken for culture. This is an interesting patient. Patient was fully debridement, everything was done at Pondicherry, and the surgeon over there found the interphalangeal joint exposed in the great toe and was advised amputation of the great toe. Fearing amputation, patient came to us. So what we did is, we wanted to salvage the great toe. So what we did is, we used collagen and elastin matrix along with WAC to salvage the great toe, and the joint was fully covered with granulation tissue, and we closed it with the skin grafting. So this is how we did the vacuum along before applying the matrix, collagen elastin matrix, and then we covered with a foam, and we connected to the VAC, and within 5 days we got the wound with a fully granulated. So there are many indications for VAC. My take is, if it is an exudative ulcer, and if it is a large ulcer, and if there is no bleeding in the ulcer, these are the places which we generally use VAC, and if there is no major organ is being involved, vital organs are not involved. Indications, as I told, there are many indications, humpty of indications. I would definitely not go for everything, but if it is an exudative ulcer, and if it is, we are going to salvage the preventing amputation, we will definitely go for. And contraindications, as I rightly said, vital organs should not be done, there should be no bleeding. And in necrosis, we should not do VAC, we have to do a proper debridement. Dermal substitutes, there are many available now. What we do is use collagen and elastin matrix. So it is usually applied when the bones and tendons are exposed, and so that it covers with granulation tissue gets covered. And even in full thickness burns, we can use this dermal substitutes. It gives tremendous effects. Collagen usually used as a filler, and it reduces the scar tissue, whereas elastin is one which improves the neoangiogenesis as well as increases the elasticity of the skin after the grafting. This is a patient of severe necrotizing fasciitis. Patient came in a very moribund state from Kuwait, and the patient was resuscitated, and extensive debridement was done, and a wide split skin graft was done, and patient walked home without a single amputation. This is another patient who came from Srivilliputturu. Patient had a chronic lateral malleolar ulcer. It developed into osteomyelitis with calcaneum and tarsal bones. Patient was advised a below knee amputation, and patient fearing amputation, they came to us. So this is how the ulcer was. So what we did is we did a thorough debridement, sequestectomy was done, and We used the dermal substitute along with VAC. This is an MRI which shows extensive involvement of the calcaneum as well as the dorsal bones, and the X-ray also shows the similar. And the patient healed well even without a skin grafting. Patient is able to walk with his own feet without any amputation done, and moreover, patient is back riding a scooter and do his work. This is another patient who was advised below knee amputation. So, and what we did was we did a CT angio to find out there is an obstruction in the anterior tibial and posterior tibials, and both the vessels was stented. And what we did was a midfoot amputation, and you can see the difference how the vascularity has improved, and the patient walked home with on his own foot, avoiding a major amputation. This is another neuroischemic ulcer, and patient and his wife both are scientists by profession. And when they developed an ulcer in the third toe, and which became gangrenous, it was amputated by the surgeon without assessing the vascularity of the foot. And next, within 1 or 2 months, less than a month, the patient developed the second toe also gangrenous. Patient became jittery, and they abandoned the surgeon, and they went from one place to another. They went to Kochi, they went to Chennai, and so many places they went, and finally they came to us. And we evaluated the vascularity to be very minimal, and there was no flow. And unfortunately, we could not do a angio or a CT angio or a angioplasty because he was a patient of chronic kidney disease with the urea more than 100, creatinine 7. So we had only one option left, hyperbaric oxygen therapy. And you all know hyperbaric oxygen is 100% oxygen in a closed high chamber, and it improves, it gets dissolved in the plasma, and so that the oxygenation to the tissues increase 3-fold compared to the normal circumstances. And I would like to thank Dr. Priyavardhana who helped me in this patient. And patient, we did give HBOT pre-op and post-op also. In 3 weeks duration, the wound started granulating and epithelialized fully, and the patient smiling happily with this 1 month therapy, problem solved. 6 months problem was solved. And this is another patient with a lateral malleolar ulcer. Lateral malleolar ulcers are very difficult to treat, appears to be very simple, very challenging. I was telling about the Srivalli Tippattur patient who was advised a beak amputation, who developed only a lateral malleolar ulcer. Lateral malleolar ulcer appears to be very simple because only a lapis is very small, but it is on the malleolus, so easily it involves the osteomyelitis occurs. So this has to be treated properly, offloading has to be done, and patient was salvaged. This is a typical trophic ulcer, healed with an offloading. This is another mangled foot, advised amputation, and this also what we did is we did debridement, VAC, and wound closed with the skin grafting. Therapeutic footwear is a misnomer. It is only used to prevent the occurrence and recurrence of ulcer and not used to treat the ulcer. I repeat, majority of the pressure ulcers can be effectively managed by non-surgeons, and categorize every pressure ulcer as either neuropathic or neuroischemic before starting the plan of management. Thank you, one and all.
Thank you so much, Dr. Shivakumar, for a lucrative presentation. We can take one question.
Yes, sir. Yes, sir. Thank you, sir.
Mic, please.
guess it's on HBOT.
Yes, sir.
Do you recommend HBOT only for these neuroischemic severe ulcers, or how do you choose patients with this diabetic ulcers for HBOT? Because the FDA recommends even for deep osteomyelitis, for many even necrotizing fasciitis.
True.
There are many conditions which
Very
the
true.
FDA recommends.
Yes.
So how do you choose your patients for HBOT?
Very good, very interesting question, useful question for all public. And I have generally used for neuroischemic ulcers. The reason is the oxygenation improves, because in neuroischemic ulcers, oxygenation is the big issue for the wound not to heal. But as you rightly said, wherever there is more of osteomyelitis, and moreover, wherever the free radicals are more, as Ramurthy sir said, wherever there is more of free radicals, you have HBOT to neutralize it, okay? And wherever possible, we can definitely use HBOT. It is going to give a tremendous results. And if the patient is compliant, we can use it for any indication for diabetic foot ulcer, more so ever for the ischemic ulcers. Thank you, sir.
Thank you so much. Thank you for this presentation. Now the next topic, we call upon Mr. Anand from Synergy. Mr. Anand?
Yeah, good evening all of you. And I thank the organizers for giving us this opportunity. So today's topic of mine is going to be on a modern day epidemic and the novel innovations in the field of rehabilitation with which we can treat our patients. So in this modern days, poor posture is a chronic epidemic, and we see patients like data, even 10-year-old children, they have demonstrated spinal degeneration. And these postural malalignments, they even predispose to problems like migraine, high blood pressure, decreased lung capacity, where it deprives the human body of oxygen supply as well. So there is a significant relationship between the bad posture and the early death and complications and pain and agony, what the human community come across. So the functional breath, the core, the pelvic floor, and the low back, they play an integral role, and they have a significant role when it comes to maintaining the quality of life, because chronic stress, anxiety, trauma, injury, and habitual postural patterns, they dim down the natural coordination and activation, which is very much important to address to a lot of perennial problems which we are coming across in this modern era. So what happens is the vicious cycle of inactivity due to some reasons, because of modernization and confinement to the system, we do less of activity. When we are less active, our muscles become weaker. When they become weaker, when we are trying to do some activities, they tend to consume more energy or more oxygen. So then we become breathless. When we become breathless because of the fear, we avoid doing activities which gives more demand of oxygen consumption, and thereby the vicious cycle keeps on running and highly restricting our quality of life. So it is a combination of a healthy core muscles. The diaphragm, it acts as a canister which maintains a proper coordination at the level between the rib cage and the pelvic floor. And the pelvic floor muscles are also an integral part of our rehabilitation. And definitely the lower back also plays a very crucial role. So whenever we are addressing to problems with lower back or pelvic floor, we should also concentrate into the significant role played by the diaphragm and also the core muscles as well. So the musculoskeletal health also takes a very bad beating because of the improper posture, because we slouch, we have shoulder back posture, we have kyphotic posture, we have exaggerated lumbar lordosis and so on. So what it does is basically it reduces the coordination between the rib cage and the pelvic floor, where the canister, the diaphragm, gets highly compromised to move efficiently and to maintain a proper breathing pattern. So this, if the oxygen supply is not appropriate and if the canister, the diaphragm, is not performing its duty appropriately, it decreases the brain threshold, it creates an imbalance, and it creates a lot of movement problems as well. Same way, the most unsung hero in everyday activities is the pelvic floor muscles. The pelvic floor muscles have a very significant role when it comes to organ support, when it comes to sexual arousal and erection qualities, and also it is an integral part of the core, and they are very much important to maintain proper continence when it comes to bowel and bladder functions. So they are the most unsung heroes when it comes to the care of our patients. So the pelvic floor and the breathing, they are integral. So when we inhale, the diaphragm descends and the pelvic floor also descends. And when we exhale, the diaphragm ascends and the pelvic floor also ascends. So always there is a connection between the diaphragm and the pelvic floor. So definitely, if for any reasons the patient is having dysfunctional breathing, this will affect how the pelvic floor is functioning as well. So the thoracic diaphragm and the pelvic floor are interlinked. So when it comes to compensation with the pelvic floor, the most common health problems, particularly in women when compared to the numbers what we see in men, are common, like obesity, hormonal imbalance, PCOD, infertility, menopause syndrome, arthritis, cancer due to breast and cervix origin. But of them, the most predominant one is the pelvic floor dysfunction. So this leads to a lot of problems. So these are all integral, like the back problem, it could be due to dysfunctional breathing, that might influence your pelvic floor functioning, that might lead to urinary incontinence, and ultimately our patients, due to inactivity of the pelvic floor, they might have some sexual issues with sexual arousal, orgasm, and erectile dysfunction also. So these are all interlinked to one another in one way or the other. And in this modern era, when we have to address our patients to give a better rehabilitation and give a better quality of life, we need to have a clinical toolbox which is efficient enough to approach all these indications in a holistic manner. So for this, for treating this modern day epidemic, we have some wonderful devices, like we have to the left device called the spine empty core, which is the state-of-the-art spinal decompression device. And to the right corner, you find a deep stimulating peripheral magnetic stimulation device, which can be used for pain management and urinary incontinence, and so on. So let me just give you a little insight. The spine empty core, it's a core of spinal therapy, and it has a core of multifunctional rehabilitation treatment device, which addresses not only to the spine by doing three-dimensional decompression, which all available devices do. This guy, along with the three-dimensional decompression, he also incorporates spinal mobilization. When we are incorporating spinal mobilization, it helps to increase the dural mobility. It regulates the flow of the cerebrospinal fluid, and ultimately it enhances the balance in the autonomic nervous system. When we are doing all this, we are able to increase the range of motion. We are able to increase the functions of the spine. The pain threshold comes very less, and there is increased neural nutrition supply and increases neural conductivity, and the pain is controlled significantly, and the quality of life improves, along with the three-dimensional approach of decompression, which helps to reduce the disc space. So we can have a combined effect of both mobilization and decompression with this device. So when it comes to cervical option, we have a precise selection of the segments, say from C1 to T1, based on the level of lesion, we can position the patient on the table based on the level of lesion and achieve higher levels of decompression. And if the patient is having unilateral involvement, let us say it is right-sided or left-sided decompression happening, we need to do unilateral correction. That also can be done with few adjustments on the device. Same with the lumbar also, we can do segmental decompression. And the image which you find on the third one, what it does is there is an air pump which induces sacral nutation and counter nutation. When we are encouraging sacral nutation and counter nutation, like the soleus which we have as a peripheral heart, the sacral nutation and counter nutation also acts as a pump, sacral pump, which regulates the flow of the cerebrospinal fluid to and fro from the brain through the spinal cord. When it is regulating it, it regulates the flow of the cerebrospinal fluid, thereby nourishing the nerve cells and also improving the conductivity of the nerve cells. And there are overlapping chambers which come across the patient's waist, and they are also alternately inflating air chambers inside, which will mobilize the pelvis, and it will prevent anterior or pelvic tilt, and it will neutralize the pelvis before either decompression or rotation starts. So we address it in all various manners, like we are able to do customized segmental decompression. We are addressing to the sacral activation, and we are also correcting the pelvis before either we do decompression or we do unilateral correction based on the picture, clinical picture in front of us. And this helps us to activate, because the thoracic segment, which lies between the cervical and lumbar, has a significant role when it comes to shoulder and neck injuries, neck problems, and also a minor role when it comes to low back issues. So we should never forget about the thoracic segment also. So for that, we have a thoracic mobilization segment as well. So this mobilizes the thoracic segment. If I want to have an isolated lumbar mobilization, I can do lumbar mobilization also. Or for some patients, if I want to combine both thoracic and lumbar, that can also be done. Both will work in a synchronized manner. So by this, we are not forgetting the thoracic segment which lies between the cervical and lumbar, and whatever contribution does higher up and lower, we are trying to nullify that as well by mobilizing the thoracic segment. Then we have Celeste Talent Pro, which is one of the premium and powerful electromagnetic stimulation device which will address to various issues. There are various synonyms. We call it by deep penetrating electromagnetic stimulation or high intensity focused electromagnetic therapy, functional magnetic stimulation. These are different names given to this wonderful technology. What it does actually, physiologically, it induces electrochemistry. We will be inducing an high intensity electromagnetic field through the coil. It will initiate an action potential, and when the stimulus overcomes, the cellular depolarization happens and the repolarization process takes over, and that leads to contraction and relaxation in the muscle. So what is very crucial is there are three factors which we need to understand. One is the intensity, second one is the frequency, third one is the interburst or intertrain interval. So once we become a master of these three parameters, we can create our own protocols based on our patient's needs, and we can. Sorry, sir.
Time is.
It was for 30 minutes. Yeah.
Okay.
So with this, what we can primarily attend is, like I told you, the diaphragm being a canister plays a very crucial role when it comes to pelvic floor muscles integration, and also it has a role to play in general well-being and also in lower back issues. If there is problematic breathing, there will be increased stress and inflammation in the body as well. So when we are trying to train the patients on proper patterns of diaphragmatic breathing, we can also strengthen the lower back also in a more efficient manner. We can ensure pelvic core stability, And when we are maintaining the abdominal pressure appropriately by co-activation of these muscles, we can help to reinforce the strength of the spine as well. So when we are inducing diaphragmatic breathing with the help of the repetitive pulsed magnetic stimulation, we are able to increase the cross-sectional area of the deep spine stabilizers like the transverse abdominals and the lumbar multifidus. So when we are concentrating on improving the breathing pattern of the patients, we are able to improve the balance through deep core control mechanisms and proprioceptive feedback, and this will reduce the pressure on the muscles, accessory muscles of breathing on the neck, and thereby they will support the cervical posture as well. So how we can do this? We can place the pulsed electromagnetic stimulation device when the posterolateral approach from the end of the rib cage, and we can target the diaphragm, and by giving repeated stimulation, we can induce strong contraction and relaxation in the diaphragm, which will improve the activation and coordination and breathing efficiency in the patients. It doesn't stop there, because pain is one primary factor for which patients come to rehabilitation specialists. So we can manage pain based on opioid release theory, pain control theory, and also peripheral pain pattern theory by playing with the frequencies. It also regulates the circulation in the human system, thereby it will overcome inflammation and also relieves neural system and unstable cells. So it can also help to increase the range of motion due to repetitive contraction and relaxations happening. We can increase the range of motion and restore better joint play. And conservative fracture healing also can be done by enhancing the blood flow and by supporting the formation of vascular and callus cartilage. So spasticity reduction also can be achieved by reflex inhibition method with this device. And when it comes to the effects, it has an analgesic effect. We can stimulate the muscle at various levels. We can regenerate the tissue, and it can be applied in rehabilitation medicine, sports, orthopedics, neurology, urogynecology as well. So now, how does it play a significant role in urogynecology, and how significantly it can help in pelvic floor disorders? It can be used in urinary incontinence, all type of sexual dysfunctions, chronic prostatitis, and so on, and even for general strengthening of the pelvic floor muscles. So it comes with a UI chair. All that the patient has to do is go and sit on the chair for 20 to 30 minutes. A deep electromagnetic stimulation will induce strong contractions to the pelvic floor muscles by reinforcing their strength and optimizing their position. Thereby, we are able to optimize the position of the rectum, bladder, and uterus as well. So it's a 30-minute procedure where it induces approximately around 12,000 Kegels.
Mr. Anand, your time is only 15 minutes. You are exceeding the time. No, it's a 15-minute slot. It's over.
Can be fully clothed. It's an operator-free treatment, and there are no consumables also with this. And the success is significant improvement, around 95% improvement in the quality of life. And right from first session, there is significant reduction in the use of the pads for the patient, and they're able to recover well, and 75% progress is happening. Thank you for the opportunity. I represent Synergy Incorporations, which is a pioneer in field of physiotherapy and rehab products, and one-stop shop for all your rehab and physio needs. Thank you.
Hello. Thank you.
Thank you, sir.
Thank you. Our last speaker is Dr. Krishnamurthy, sir, consultant pain physician in UK. He will be speaking on orofacial pain.
Good evening, everyone. Thanks for the organizing committee and especially the people there, and Dr. Padmarani, who texted me at 1:30 in the morning to say that, I can use this slot. And as I'm the last speaker, she said I can use as much time till the last person leaves the room, but I'm not going to take more than 12 minutes. I'm an anesthetist basically, but I also do 50% of my job is doing chronic pain. And I have chosen orofacial pain clinic relief, orofacial pain relief, because this is what I do as my special clinic with a MDT type of clinic. And also, this is much more complicated and more threatening and more meaningful to the patient than the other chronic pains like low back pain. And so the next slide. Right, as you can see, 45% of the human homunculus is represented by the face, neck, and the shoulders. So that shows how much importance is for the face. This is because when somebody has facial pain, any basic human behaviors like eating, chewing, talking, communication, and also expression of emotions like sadness, happiness, and also intimate activities like kissing, all those things can be affected. So when those things are affected by pain, these patients feel their basic instinct, human behavior is threatened by the pain. So it gets complicated quite easily. So that's why facial pain is more complex and difficult to treat compared to other chronic pains. Simplistically, this is the innervation, the three branches of the trigeminal nerve, and also you get some cervical plexus innervating the neck. And the face has also got enormous autonomic innervation, sympathetic, parasympathetic, all types of ganglions, nerve centers. So the face is rich with nervous system, and this makes facial pain to manifest with autonomic symptoms. This is a lady with burning mouth syndrome. If you can see, the problem is in the mouth, but our entire eyelids, forehead, they're all red and swollen. That's because of the autonomic impact of the chronic pain system. A few slides on physiology. This is the pain from the facial area is communicated to the cortex through the three sets of neurons, first order, second order, and third order. When there is a problem, say for example in the jaw, the first order goes to the nucleus tractus solitarius of the trigeminal nerve or caudate nucleus, and then there is a synapse. And from the synapse, there are two types of nerve fibers, as Professor Ramamurthy said. Any A delta fibers, which carries the sharp pain. Sharp pain is like an acute pain, any sharp pain like pins and needles. It goes through the neospinothalamic tract. There are no synapses. It goes straight to the thalamus and to the cortex. Whereas deep dull aches or a type of chronic pain, it goes through the paleospinothalamic tract, which has multiple synapses. So the speed is very bit slower compared to the neospinothalamic. And also it gets filtered at the reticular formation, periaqueductal gray. So whatever messages that is conveyed through the paleospinothalamic tract may not be exactly what is happening there. So there is a lot of modulations before the pain fibers reach the cortex. So the pain might be different, but what is perceived might be different. And this is again descending inhibition, which is like a braking system for all the pain. Even though descending inhibition works for all the pains from everywhere in the body, it is more affected by the facial pains. And this is one reason why manipulating the descending inhibition system will be more useful in managing chronic orofacial pain. There's also now research papers saying that things like TENS, acupuncture, and even meditation, they kind of stimulate the descending inhibition and help in management of the facial pain. This is another important difference between chronic pain in other parts and the face. We call it as convergence, which is just like our referred pain. You know, when you have appendicitis on the right iliac fossa, sometimes you can feel the pain in the left iliac fossa, something like that. So if you look at that one, the red neurons are from the first and second division of the trigeminal nerve. They synapse in the caudate nucleus, but there are also the green fibers from cervical region. They synapse in the same caudate nucleus. Not only they synapse in the caudate nucleus, they go up and communicate with the neurons coming from V1 and V3. So what happens is, both when the pain messages go to the brain, the cortex might get confused whether the pain is coming from the shoulder or from the forehead. So sometimes when the problem is in the trapezius, the patient might feel pain in the forehead, and this is because of the crosstalk of these neurons at the caudate nucleus. And this happens only in the facial pain because of the lengthy nucleus in the medulla and the upper spinal cord. And this is again another central example of central sensitization, which is quite common in facial pain than in peripheral low back pain or neck pain. If you look at that, you know, when there is a source of pain in the trapezius, for example, when there is a muscle spasm or tenderness or some injury to the shoulder, the nerve fibers not only go to the thalamus and the cortex, but on the way, you know, they can also stimulate the V1 and V3, and then the cortex can send efferent fibers, which can cause contraction of the masseter muscle, for example, in this case. It's called co-contraction. Co-contraction is the type of contraction where the agonist and antagonist contract at the same time. When the agonist contracts, the antagonist should relax for a smooth muscle movement. But when both agonist and antagonist contract, it causes intense pain there. So basically, the problem is in the shoulder, but then the patient comes to the doctor with intense pain in the cheek or in the jaw. And if the patient goes to the dentist, they might think there is some caries, they might pull the tooth out, but that's not going to solve the problem, but that can make the pain worse. This is the laminated appearance where the pain fibers from the face are just conducted in this laminated fashion. For example, lamina 5 it goes down to the bottom of the caudate nucleus, whereas lamina 1. And this gives some features like the pain is always conducted along the lamina. If they have pain in the lower jaw, it goes up to the vertex, and they don't cross to the opposite side. If there is a problem in upper jaw, it can kind of refer to the lower jaw on the same side, but it won't go to the other side. And this shows that the reticular formation modulates each and every impulse coming from the face, and that's why they are susceptible to biopsychosocial influence of pain, which is more common. So if you don't treat facial pain quite quickly, then they are more likely to become chronic pain. And that's because of the influence of reticular formation. So this is our hospital where we have this MDT team, which is formed by anesthetist, ENT, neurologist, physiotherapist, occupational therapist. And this is the referral pattern. We get referrals from dental practitioners, GPs, ENTs, A&Es, and general pain clinics. And this is what this is a data for 2 years. We saw about 300 patients. The most common cause for referral is temporomandibular joint. And then next comes the neuralgias, and then musculoskeletal pain, the third, and then the dental pain, the last one. What we did not see any intracranial pain or sole dental pain as a cause of referral, and severe mental illness or anything. So temporomandibular joint and pain dysfunction syndrome, these are the signs and symptoms which can be, which you all know, and it can be treated by non-invasive methods, minimally invasive methods, and also invasive options. This is one reason, just chewing the nails, which can cause temporomandibular pain. And then the non-invasive stuff or stabilization, repositioning, And then these are the drugs which Professor Ram Murthy explained, some of those drugs, antidepressants, anticonvulsants. This is all we use, nothing new. These are the different types of exercises delivered by the pain physiotherapist, chronic pain facial physiotherapist. And then if there is no improvement, we just kind of use combination therapy and also arthrosynthesis, where we put 2 needles into the temporomandibular joint and flush the joint. And we don't do these replacements. And neuralgia is the most common cause for facial pain, and the treatment of choice is anticonvulsants. These are the different treatments for neuralgic pain. And also this persistent idiopathic facial pain is a diagnosis of exclusion. When you have excluded all other causes, treated all other causes, still the patient is having pain, we label them as PIFP. And the most common cause for this is anxiety and depression. And then this is the musculoskeletal causes, muscle spasm with trigger points and things like that. This chart tells you how a small dental abscess can lead to fibromyalgia or a systemic myalgic disorder. It can get better after a bit of muscle soreness and myospasm, or if you leave it longer, it can go into like a regional muscle spasm, and if they don't get the proper treatment, they can go to systemic myalgic disorder, which is fibromyalgia. So it starts from one area in the face, and the entire system can be affected. And these are all the trigger points which can be misleading. For example, if you look at this sternocleidomastoid, I'll just take 1 more minute. See, that's the sternocleidomastoid, and you can see the crosses are the trigger points. You know, they might have pain there, but sometimes they also have pain around the orbit or on the other side, the cleidomastoid, which is the deeper layer. The problem might be in the cleidomastoid muscle, or and then if you see, the patients can be feeling the pain in the forehead. So what I'm trying to stress is the site of pain and source of pain can be different. So you need to treat the source of pain rather than the site of pain. The site of pain can be misleading. So these are all the various trigger points where you need to put, and these are all the exercises we use. That's nothing new for you. You know, you're using all these things: TENS, ultrasound, temporomandibular joint injection, trigger point, and inferior massage, resistance, moist heat, cold therapy, colon therapy. So we were able to treat about 45% with physical therapies, no medications, just a TENS, acupuncture, massage, and 41% needed small dose of painkillers like pregabalin, gabapentin, and 14% needed outpatient interventions like trigger points and nerve blocks. So that's it. So the message is facial pain can be very complex, and it can be much more meaningful than the other chronic pain. And secondly, because of the intense nervous supply to the face, it can cause a lot of autonomic symptoms. And the third thing is, people can go into anxiety and depression quite quickly if you don't treat facial pain within 6 to 8 weeks. So try to diagnose and treat them early. And the fourth thing you need to remember is the site of pain and source of pain can be different. So you need to treat the source of pain rather than the site of pain. Thank you so much for listening.
Thank you, Dr. Krishnamurthy, for a wonderful presentation. I know treating the pain generator is more important. That is the take-home message. We can afford one question because we are already running late. Okay, I'll ask you one question. When do you do the interventions? When do you plan to do the interventions? Because 45% of your cases you have dealt with physical therapy.
Yeah. So mostly we try the non-interventions first. So we have a physiotherapist and psychologist, and if we can manage them with all those non-interventions. And then if they are still not happy, it's basically, each patient is different. For the same problem, one might get better with interventions, whereas the other might be, okay with. So we try the non-invasive methods first, and then if they fail, then we do the interventions.
But I'm sure because these are all the temporomandibular joint dysfunction pains.
Yeah,
right?
yeah.
And if pure trigeminal neuralgias, then you have to intervene.
Yeah,
You
yeah,
have to,
yeah,
you-
yeah.
you
But
can't
not
wait
all
for years,
cases,
yeah.
Some of them can be managed with just medications,
Pharmacological.
just pregabalin, carbamazepine, oxycontin. You need to find what drug works for that particular patient. Sometimes, the pregabalin may not work, so you just try duloxetine, or that might not work, you try oxycarbamazepine. So, and then it also depends on what the patients want, If somebody wants the pain to be completely gone, 100%, then, the failure rate is high. We won't be able to satisfy them. But some people say, I'm okay with about 50% reduction. If I have a good night's sleep, that is all I need, then the success rate is high. So basically, if somebody comes to me, I give them all the choices, okay? But there is no evidence to say that injections are better than medications, or medications are better than physical therapy, or doing nothing is better than everything. So it's pain medicine is, as you know, we can't do randomized controlled trial in pain because there is no, the definition of pain varies from each person, and what they expect as pain relief also varies from each patient. So there are no, so I give them all the choices, and then they will ask me, what will you choose, Then I will say, I won't choose anything, because if I get pain, I better go and, I won't go to the doctor. That will be my answer. So what I'm going to choose is not going to help you. So you trial and error, and you find the best combination that works for you. And then sometimes it might take even 6 months before we know what is working for that particular patient. It's all by trial and error.
So this is Dr. Vijayan. You showed a picture of a burning mouth syndrome, and then you left it off. Now, how do you treat burning mouth syndrome, and what is the common
Burning mouth syndrome is, again, we start with, psychological, because most of them, if you look into burning mouth syndrome, they have a history of anxiety and depression. There might be a lot of, burning mouth syndrome, irritable bowel syndrome, chronic visceral pain, facial pain, PTSD. They might have a history of PTSD. And also, if you explore the history further, they might have, childhood traumas, sexual, mental, and psychological, insults. And so those things, one of the common causes of facial pain is hidden psychological trauma, during childhood. So you explore, there is a psychologist who will explore all those things. And then you go again treating with medications, the same anticonvulsants and things like that. And they also use some local anesthetic gels, like lidocaine and things like that, which they can gargle. There is also local anesthetic lozenges, like, like a Vicks thing. They can put it in the mouth and keep it, And then finally, if it is still not, they are not happy, we have fentanyl, like a sublingual fentanyl, buprenorphine, or some fentanyl patches, like a lollipops, which can be given for them.
Have you injected Botox, sir?
Sorry?
Bottled them?
Yeah. So we use plenty of Botox. If they don't respond to steroid injections, we use Botox for trigger point injections. We use Botox even into the temporomandibular joint to relieve the spasm. And for headaches, Botox works because the headache patients, they go to neurologists first, they try everything, and then they end up in more side effects from medications, then they come to us. And then we use Botox. There's about 32 points around the scalp, depending on if they have more of frontal headache, you inject more. But I also use ultrasound to inject the Botox, because if you inject Botox too superficial, it's not going to work. And if you inject Botox under the muscle, it's not going to work. So it should go into the muscle, and we use ultrasound to get it. Of course, here we can do it, but lower back, sometimes we think the Botox is going into the muscle, but it won't go into the muscle. So if you inject Botox into the right spots, that gives a good response. So we use Botox quite a lot.
Thank you so much, and thank you.
Thank you.
With this, we'll end the session, and we'll invite all the speakers on the stage.
Yes, ma'am.
For felicitation.
Yes, ma'am. I request
Dr. Krishnamurthy, be on the
sir,
stage,
please stay on the stage, sir. I request our organizing chairman, Challakumara Swami, sir, to felicitate Dr. K. Vijayan and Dr. V. Arul Selvan, sir. I request our chairpersons to felicitate the speakers of this session. I request Dr. Ramamurthy, sir, to come to the stage. I request our chairpersons to felicitate Dr. Shivakumar, sir. Request our chairpersons to felicitate Mr. Anand from Synergy. I think he's not here. I request our chairpersons to felicitate request our chairpersons to felicitate Dr. Krishnamurthy, sir. request our organizing chairman to felicitate the chairpersons. Thank you, ma'am. Thank you, sir. With this, we are concluding the scientific sessions of today. We are having our gala dinner at Lee Royal Meridian of Neelambur, and the dinner session starts by 7 o'clock. We have arranged transport pickup from PSG. We have 2 shuttles, one at 6:15 p.m. and another one at 6:45 p.m. I request all of you to join with us for gala dinner. Thank you.